The year is 2020, and technology has never been more important in healthcare. The body of research has grown, and medical breakthroughs continue to accelerate. It is vital for professionals to stay current in the rapidly changing landscape of treatment of heart disease. Welcome to the New York Transcatheter Valve Symposium. While COVID-19 has challenged us to take our conference online, course directors Dr. Samin Sharma, Anna Pornakini, Gilbert Tang, Stamatios Larakis, and Roxana Moran have created a packed and compelling program. Over the next several hours, we'll take a patient-focused approach to valvular and structural heart disease. Our brief time together is packed with live transcatheter procedures, moderated discussions, lectures, and interactive Q&As with the experts, all exploring new and emerging tools in diagnosis, management, and treatment. The symposium will cover emerging technologies in management of structural heart disease, transcatheter valve intervention, the heart team approach to valvular heart disease, barriers to care in patients with valvular heart disease. Attendees will receive CME credits commensurate to the extent of their participation. Thank you for joining us. Staying up to date on the latest developments strengthens our ability to provide truly top-of-the-line care to our patients and empowers the medical community as a whole. Remember to follow COVID guidelines, stay safe, and enjoy the conference.
Hello. Good morning or any other time in the world to welcome to New York Transcatheter Valve 2020. And of course, with the COVID being a virtual, and that maybe even the COVID war will be over, a lot of activities, a lot of conferences will be virtual. So I really welcome with my course directors to this exciting 6-hour session, trying to bring the latest in the field of structural heart disease. As you have seen with the agenda, that we have very packed, very focused topics by the world expert in the field of structural heart disease, and it will be supplemented by 2 live cases of the transcatheter valve intervention, TAVR particularly, knowing that that has become the routine now, and while other transcatheter technology is still growing. And also in the end of the day, that all faculty will be there for all the Q&A. So I know that for many people, they need to ask a specific question. Ample opportunity will be given for everyone to put in the chat box, and we'll make sure all the questions and queries will be answered. With that note, also please join the exhibit hall, which on the main screen will take you through the latest development by various individual industry, what is coming what is there and what is coming in the future. With that note, I just welcome once again, and I'll start asking my course co-directors a brief word, and then we start our proceedings of today. And Dr. Roxana Moran will be the main moderator for the major part, and then followed by Dr. Josh Dangus, and then Eberhard Grube. So, Anu?
Yeah, good morning to people from entire world from New York. Just to say that we never thought something like this could happen, but I can say I actually like it. No need to travel. Everybody is comfortable wherever they are, and they can, listen as they're doing their work, and also watch the live cases. And same thing, what Sinai is known for is doing live cases and teaching the tips and tricks of how to do this, simple to moderate to complex cases easy. And we have a great panel for the entire day. So I would just ask everyone, just stay tuned and listen to the top up-to-date lectures of this exciting panel that we have here today.
Gilbert?
Hello, everyone from all over the world. Thank you for joining us. It's been quite a year, and we're happy to see that it's coming to an end, hopefully, with the vaccines coming. But we have a jam-packed program, as Dr. Sharma and Dr. Kinney mentioned today, from who's who in the structural heart world. So we hope you enjoy our program and the live cases, and getting a lot of education out of this. Look forward to seeing you later.
Beautiful. Stan?
Yes, good morning and welcome from all over the world. Thank you for joining us, even virtually. We have a great program and we hope that you enjoy it. And we'll see you later in the QA part of the conference. Thank you for joining us.
Great. Roxana, now this is your show, particularly that you are very instrumental in organizing this excellent talks, topics, and speakers. So you will be the moderator for most of the sessions, right, starting now. And we really thank you for making extra effort to make this program so successful.
Thank you, Dr. Sharma, Dr. Kinney, for your incredible support, but for your genius thoughts about how to put this Congress together. Live cases, truly live, with a live moderated panel. And I want to welcome everyone to this second year of the New York Valve meeting, the third year, actually. I think this is the third year of our New York Valve meeting, but we plan to continue to grow this program. There's been such tremendous positive feedback from all of you. We love that you're online with me and I'm watching all of your questions. We have over 500 people logged in looking to work with us, and we know that this will increase throughout the day. And even though there's an ongoing FDA panel going on, which we'll be also kind of keeping a tabs on, as you know, I'm very interested in that. But this is really where all of the learning will take place today on transcatheter, aortic, mitral, tricuspid valves with the best faculty. And we are planning a fantastic keynote lecture from no other than Pat O'Gara, who will give us the state-of-the-art lecture, and then the most amazing panelists and live case moderators like Eberhard Grube, Alexandre Abezaid, and so many of my colleagues from around the world who have come in and supported this meeting. And we believe this will be an incredible success and look forward to having everyone here in New York City right before Christmas and having you all here with all of us live. So without much delay, because we have so much to dive into, we're going to start with Dr. Sharma. He has always been the best and gives us the top 10. And whenever he comes out with the top 10 advances, honestly, they're kind of come true, and everyone enjoys listening to that. And he does a lot of work. It's amazing. I say to myself, how does he do it? How does he come up with all of the top findings? And I learn from them. So Dr. Sharma, we want you to tell us about the top 10 advances in transcatheter valve therapy 2020. If there was any advance this year, please tell us.
Hello, welcome to the New York Transcatheter Valve course 2020. Like earlier two courses, I'm going to talk now of top 10 advances in transcatheter valve therapy 2020, basically giving you the latest data in last 1.5 years. As you know, the status of transcatheter heart valve, we start with the pulmonic. Now we are almost aortic valve, majority are being done with the transcatheter. Then next frontier has been mitral valve, where a lot of work being done, and then the tricuspid remains the last one. Now, as you know, this field of transcatheter therapy started by Dr. Anderson, made the Anderson stent valve, and which was the transcatheter aortic valve implanted in sheep and ceased functioning, which led to the clinical trial by Dr. Alan Crebier. And after a lot of reiteration, finally in April 2002, the valve was implanted in a patient, and patient did extremely well. Clearly, he is the father of transcatheter valve therapy, and conclusion was the non-surgical way we can take care of it, and that is a great way to start our transcatheter program. Now, like everything else in the disease process, we always wait for the symptom. So the question comes now is, once you have a very effective therapy and can be done with a minimum complication, can you go from symptomatic to asymptomatic stage that early in the disease process? And that is what happening in most of the valvular disease treatment. Now, TAVR itself in last 10 years with the multiple trials and thousands of patients in various risk groups has really solidified its role in treatment of severe aortic stenosis. That is, the TAVR is the way to go with the appropriate anatomy, as long as complication remains low. And the guideline of ACCH, you just have to supplement a class 1 indication for all types of TAVR. So therefore, our traditional teaching of the low, intermediate, high, and extreme is no longer valid at present, because it's a contemporary, because now you put only two groups: higher risk, which is more than 3% STS, or lower risk, particularly those cases, if something happens acutely, you may need to open the chest or put a patient on cardiopulmonary bypass. So clearly that those patients need to be assigned separately on the schedule compared to high-risk patient where TAVR is the final treatment. Now, we also learned that besides having a death, which can occur rarely, that there are 5 important procedural complications, starting with a stroke, then paravalvular leak, the bleeding, AV block, need for pacemaker, and AKI. That really determines the long-term outcome of the TAVR patients, and we really have to be very aggressive in managing these patients, these complications, and decrease them as much as possible. What I'm going to speak now is about 2020 advances, which were selected because of widespread acceptance, made the significant observation, and change our practice. The first one is structural heart disease intervention in COVID-19 pandemic. So as you know, during the pandemic time, this is a guideline from ACC SKY consensus statement that during COVID-19 pandemic, all elective procedures were postponed, and clearly needed a room for the COVID patients. But at the same time, we also learned that you need to follow these particularly structural heart disease patients, because they have event every few weeks, not every year, but every few weeks, and therefore very close observation is required. So made the statement that which patient should get the TAVR procedures quickly, do not defer, particularly patient with a severe symptomatic AS, and then of course minimally symptomatic with a high, very tight valve with a, let's say, peak velocity more than 5, should be done quickly. They should not be deferred. An asymptomatic patient is reasonably to defer for 3 months with a very close follow-up. Now for the mitral clip repair, it was same, FMR or DMR 3 to 4 plus, which require hospital admission, and you can take them off the inotropes and cannot be discharged. But otherwise, the patients who are stable can definitely be deferred. Then the same valve-in-valve TMVR, the PVL closure, and other structural heart disease intervention like PFO closure, ASD closure, septal ablation, they all can be postponed without any problem unless in a rare case. Also, we learned that while postponing, close outpatient monitoring is required every week with a telehealth, should continue to really follow these patients and also avoid any clinical trials. So this, just to say what happened during this time period of the deferral, this is the data from Sweden, that patients who are deferred had a 19.6% event rate compared to 4% who got the expedited TAVR. Similar data at Mount Sinai. When we postponed for that 1 month, 323 to 421, 28 patients of the 77 deteriorated. 6 patients underwent urgent TAVR and 2 died. Then another 3 months deferral led to more patients developing MACE, particularly urgent TAVR, and of course additional 3 deaths. So just to say, this is a very deadly disease, and you can, even if you defer, you have to think about doing them urgent case if necessary. So clearly, what we learned that aortic stenosis is a serious disease, need to be taken care appropriately. Then we have another article from the JACC about restructuring structural heart disease practice during the COVID-19 pandemic, and they go through tier 1, tier 2, tier 3, similar on the similar guidelines, but very good, more extensive an explanation of which patient should get procedure soon. And key is that also try to avoid bringing patient too much and keep a shorted hospital stay, and if necessary, put a pacemaker at the same time when the TAVR is being done. The second advancement is the TriGuard cerebral embolic protection in the REFLECT-2 trial. As we know, during TAVR, numerous mechanism where the stroke occurs, and most important is the embolism from the valve or from the aorta, and of course the sentinel devices at present approved by FDA to capture these debris in appropriate anatomy. But then the TriGuard system in the Reflect-2 trial was evaluated, which is a basically self-positioning nitinol frame and with a mesh. So everything it captures and then brings it out. And it went through phase 1 and phase 2 studies with the 2-to-1 randomization of the TriGuard versus control, and basically saw that TriGuard did not reduce vascular complication or the disabling bleeding, which actually occurred more, and more importantly, that neurologic point of view, there is more worsening of the neurostatus of these patients, and so also the various neurologic events. So clearly the device failed. Only one section or one subgroup where it really made difference, that large lesions were noted less in the TriGuard patient compared to control group. But whether it didn't matter, overall trial was negative. So I don't think we'll see this device further, maybe with your only time will tell. Then comparative TAVR trial, knowing that at present 2 devices are FDA approved with the balloon expandable SAPIEN reiteration and Evolute core valve, also many advancement, various generations. Then Boston Scientific, the device Accurate Neo in the scope 1 and scope 2 trial was compared against Accurate Neo against SAPIEN 3 in the scope 1 trial. There are more chances of reimplantation, 3% valve in valve was done because of dislodgement and so, compared to less than 1% in the SAPIEN group. But overall, the device failed its superiority, rather it was inferior. Event rate was 23.7 in the Accurate Neo group compared to SAPIEN 3, 16.5, because of higher acute kidney injury and paravalvular leak. So then went to the scope 2, which was the same Accurate Neo device against core valve. And the endpoint was same again for 1 year, and they found an intention to treat. Overall, it was not inferior. So basically, it was overall did not do well with the 15.8% event rate compared to 13.9. Although in per protocol, the difference was less significant. So it will still remain whether device is effective, but overall, it failed to kind of, I would say, prove its efficacy at present. So these are the 1 year data of the scope 2 trial with a mortality of 13% with Accurate Neo and 9% in the core valve. So now we have ongoing trial with the Accurate Neo 2, which is a different, larger skirt, ceiling skirt, and better deliverability, and will cause less and causes less paravalvular leak. And this is ongoing at present with the Accurate IDE trial of 700 plus patients. We are part of it, and of course, next 1 or 2 years will tell us whether can we have another transcatheter valve in our armamentarium if it really comes out non-inferior to existing core valve or SAPIEN valve. So then is the frailty in the long-term outcome of the TAVR. So what does frailty means? It is the overall general condition of a patient. We know that many patients score, STS score may be the same, but some do well, some do not, because they have other very poor general condition, like low serum albumin, anemia, hand grip strength, and slow 5-meter walk. They say if you have more than 6 seconds is bad. So 5-meter walk is a routine, and if any of these parameters are affected, we call frailty. And there have been numerous papers on to answer this in last few years, and basically established frailty as an important predictor of long-term outcome of TAVR patients. So this is the data from the STS ACC registry, which mandate all these parameters of the frailty to be incorporated at baseline and at follow-up. And if you take 3 of them, low albumin, anemia, and slow walking, and you can see that if you are none, the incidence of death is about 6-7%, and it multiplies and it becomes more than 5 times, 25-38%, if all 3 frailty indicators are there. So clearly, our goal should be to work on these frailty parameters, which we measure them, but we usually do not manage them. And in the TAVI 6-minute walk, TAVI patients did better than surgery, as shown here in terms of the walk in meters. Clearly, that TAVR patients did better from the frailty indices point of view, better 6-minute walk compared to surgery. Now, health status in the low risk partner trials had the similar message that after the TAVR, a better KCCQ, overall summary, and individual endpoint and quality of life endpoints with the TAVR versus SAVR. One thing which we really need to explore now, once the TAVR is available widely, it is that racial and ethnic differences in treatment and outcome of severe AS. And basically, this has come to the limelight because there is aortic stenosis paradox that patients who are Black, Asians, non-Black patients, they usually have quite a bit of aortic stenosis, but cell detection is less and then subsequent treatment is less. Although outcome is slightly worse, but not that, but more important is appropriate diagnosis and treatment has to be extended to all our ethnic patients. Then the valve-in-valve TAVR versus redo SAVR for bioprosthetic aortic stenosis. We know that once the valve is deployed, whether it's a bioprosthetic aortic valve or surgical valve or TAVR valve, basically with time, there is calcification occurs, the leaflet degenerates and give rise to stenosis and regurgitation, with the data being that post-surgery, about 15 to 25% at 10 years will require some intervention, either do redo surgery or valve-in-valve TAVR. And basically, this is a whole issue of the valve deterioration comes in under the umbrella of bioprosthetic valve dysfunction, which include structural valve deterioration, reversible valve deterioration of thrombosis, endocarditis, and non-structural like PVL, PVR, and so. So key is the structural valve degeneration. That is what has been a big concern, that whether TAVR valve do as good as surgical valve on long run, particularly in the low to intermediate risk patient who will live 10 or 15 or 20 years after the TAVR procedure. So basically the definition is more than 20 millimeter increase in the gradient, and so this is a common definition. So you have 10 millimeter gradient post, patient comes back and becomes 32. So that person has developed structural valve degeneration. And what has been shown is that of course, more and more patients, when we follow them at later part, will start developing even the TAVR degeneration. But the issue has been the paper, with the two major papers which were published this year about valve-in-valve versus redo SAVR for treatment of surgical bioprosthetic. First one was from Ontario, Canada, for 5-year follow-up of about 600 patients with 131 match group, showed lower all-cause mortality. Again, lower all-cause mortality in favor of TAVR compared to surgery, although readmission was slightly higher with the TAVR group, as shown here. So seems to be the survival was better, and other MACE endpoints were similar. The second study was done from France for 10 years, 4,300 patients, large numbers with a 717 matched who had a valve-in-valve TAVR and redo SAVR, follow-up of 4 years, and basically found that short term, you have a lower death rate with the TAVR compared to surgery, as you see it very clear here, and other endpoints were overall equal. Of course, higher major clinical event at 30 days. Now, once you go follow these patients to 2 to 4 years, you start seeing that while initial advantage of that valve-in-valve TAVR is lost, and now you start having a little more event in the TAVR group. So this is the red is the TAVR and the blue is the valve, the surgical valve redo SAVR, and you can see the curve just start separating in favor of little lower event at after 2 years, whether it's a death or other MACI in these patients. So clearly, this need to be seen further, and these are the overall individual endpoints as shown here. That combined endpoint favor, particularly that the death rate with the redo SAVR was lower, and lower hospitalization, and other endpoints were not different. Now, also learned that basically the patients who have high STS score or Euro score, which was done in this study, less than 5 or more than 5, in less than 5, the redo SAVR did better than valve-in-valve TAVR, which did slightly better, non-statistically in high Euro score patients. So clearly that at present, which we know that the valve-in-valve TAVR is done in patients with high STS risk score. And of course, this field will continue to evolve with various other publications, but we need a randomized trial to answer this question, valve-in-valve TAVR or redo SAVR, which one is better in these degenerated bioprosthetic valve. Till that time, FDA has approval of high STS risk patient appropriate for TAVR. Then the TAVR outcomes in bicuspid aortic valve. So bicuspid aortic valve is basically We are talking about the congenital bicuspid aortic, which has its own issues in terms of severe calcification, asymmetric, and not a right fit, and any valve still continues to have paravalvular leak that we learn over the years. And then there is a concomitant aortopathy, that aorta is enlarged. So we know that many times bicuspid valve, when aorta is already 4.8 and 5, are reasonable that not to do the TAVR, and patient should go for Bantal procedure. And this is the initial report from STS registry of about 700 patient, bicuspid versus tricuspid in the matched patient. As you can see, 30-day and 1-year outcome was kind of identical between two approaches. Now, this was the SAPIEN. Now we have the data on the Evolute Tower of the 150 patients, and also have similar data that low good valve area of 2.3 effective orifice, and overall only mild aortic regurgitation in about 40%, and very rarely you have a severe aortic, moderate to severe aortic regurgitation. So basically, it seems to be the field is ongoing at present. Then truly understand which real aortic stenosis patient, bicuspid AS patient, will benefit from the TAVR valve. So looked into this aspect of calcification and of the leaflet and raphe. So if you have no calcium, your outcome was very good, 5.9 at 2 years. If you have calcified raphe or excessive leaflet calcification, outcome was 42.6. Now, if you have the calcified leaflet plus excessive leaflet calcification, so outcome was even worse. So clearly it tells you that overall there is a gradient based on the calcification of the leaflet as well as raphe. Now, most common, we have either calcium of the raphe, which is, or leaflet calcium in 42.6%, others are about 25% each. So therefore, TAVR is now approved for all STS risk type bicuspid AS after heart team discussion. There has to be appropriate case for this procedure. Then the partner 2A trial, we have the 5-year outcome and comparative valve area. So partner 2A was the trial of intermediate risk patient comparing the surgical versus surgical AVR versus TAVR, either transfemoral or transaortic. About 20% cases were transaortic. And basically now we have 5-year data in these patients that you have death and stroke, as you can see, non-significant, identical between two groups numerically, and rehospitalization definitely was higher in the TAVR group. Of course, new AFib was lower in the TAVR group, and aortic valve reintervention was more higher in the TAVR group compared to surgery. And this is the Kaplan-Meier curve of 5 years, exactly identical outcome. Now, drill down into the more details of various aspects of patient follow-up. Clearly, the TAVR had higher rehospitalization, little higher endocarditis, although p-value was 0.19, and aortic valve reintervention. So very important that we need to think about these aspects when we are looking for managing these patients. Now, mean aortic valve area was slightly better with the TAVR 1.5 versus 1.37, and mean gradient was equal. Now, what really issue was the paravalvular aortic regurgitation, giving rise to moderate to severe TAVR, moderate to severe AI or AR, PVL with the TAVR compared to surgery. Surgery, this number was very small, like 3%, it was 17%. And we also know that the degree of paravalvular leak is associated with mortality. Moderate to severe has mortality of 65%, mild 48%, and none to trace 41%. And why? Because SAPIEN XT and SAPIEN 3 were used in this partner 2 study. Now we use SAPIEN 3 Ultra, which has extra cuff, and that gives rise to lower paravalvular leak, and hopefully that will improve long-term outcome. NYHA class as well as KCCQ overall summary initially did favor TAVR, but overall was identical at 5 years. So seems to be the both approaches, TAVR or surgery, are equal. Now then in the mitral arena, mitral, the clip as well as replacement. Now this is, we know about the data of the co-op trial that the mitral clip saved life, decreased hospitalization. Now what about the patients after the trial was concluded that there was a crossover, and 58 of these patients of the 312 got the clip after the trial concluded. And what did you find? That by doing this clip, they have a rapid improvement in their overall number of patients who develop in terms of MR grade will become less. And more importantly, if you take the follow-up in terms of the hospitalization, outcome of these crossover patients were similar to originally who got the mitral clip. Same thing with all-cause mortality. Curves exactly identical as if you did the clip in the beginning, because these are the patients who survived and then crossover, and this is the combination. So seems to be that anytime you decide this is a very good device in heart failure patient, particularly FMR, and there is a document on this aspect about the transcatheter mitral valve intervention. There are 361 sites at present we do, and they actually have guidelines in terms of performance metrics, what you should be monitoring for these cases. And they continue to make a better design in terms of mitral clip and adding new the grasping features and new varieties. And as we know that CMS has approved S2 mitral valve repair, but they still need to, they're waiting for the public hearing phase, and soon will be available for, or will be approved for functional MR. Now, what about the mitral valve replacement? Numerous valve, multiple small trials have still been ongoing at present, and this has been put into various valve types, and a small number of patients. We have some 30-day data, we have midterm data. Overall, it seems to be that this field is gradually progressing of the complete mitral valve replacement using the TMVR. Now, there are some data available that what is better, TMVR better or co-op better? As you see here, the 30-day mortality, stroke, and unplanned mitral valve surgery all favored co-op device in a comparative study. Now, moderate to severe MR definitely is eliminated or becomes very little with a TMVR compared to co-op mitral clip, where you leave some regurgitation. And the mortality during follow-up clearly favors the mitral clip. So at present, 2 ongoing trials, Intrepid using Apollo, and Tendyne with the Summit trial, which is really looking into various subgroups of either directly the TMVR device or comparing with surgery, or now adding the feature of comparing with the mitral clip is ongoing at present. Mount Sinai is part of Apollo trial with Dr. Adams and Dr. Leon being PI, and this is still having a slow enrollment, but this field is going. Now, it really will take a push once we have transfemoral early feasibility study. It just started transfemoral. Hopefully, we'll start doing this transseptal puncture and then put the valve. Right now, presently done with the apical cut down, and will be done transfemorally soon. And so, Abbott Tendyne has already got approval in the Europe. Now, update in the TAVR procedures and outcome by the TVT registry. The basically just recent publication from the TCT on various aspects of the structural heart, particularly from the TAVR point of view, is just published and gives you a really bird's eye view and glimpse of how this field has evolved. With the TAVR sites became 669, and overall 73,000 TAVR procedures were done last year. I'm sure this year will be a little less because of some COVID pandemic, but overall, many centers are performing TAVR, over 700 plus at this time, and 70 plus thousand cases. And overall, what has happened, the mortality rate has gone down, whether it's in hospital, which is blue, or 30-day, or 1 year, all have come down. So basically, 30-day mortality is around 2.5, 2.8, and 1 year mortality about 14%. Now, indication have expanded, and more important, access site, because of smaller the valve device, now more are being done femorally, and non-femoral sites are still there, but done in about 2-3% of cases. More interesting is that now the TAVR procedures have crossed the surgical valve. So you see that the TAVR versus surgery, now clearly in last 1 or 2 years, there is now more TAVR procedures being done in United States, 73 plus thousand compared to 50 plus, 55 plus surgical valve. Alternate access, the axillary and carotids are the way to go. Others are gone down very significantly, but those are the 2 approaches which are gaining momentum. Now, risk profile is going down, length of hospital stay is going down. Same thing, stroke rate actually remained constant, about 2.3 at 30 days and about 4% at 1 year. The pacemaker rates had plateaued around 10%, and the various other devices and other techniques for cerebral protection using Sentinel is done in about less than 10%. Remember, 77.4 cases of 72,000, so it's a less than 10%. Then fracture of the surgical valve ring also done. Basilica, lesser aortic leaflet is also done, but very small number of cases. The real advancement of 2020 is the anticoagulation pharmacotherapy post-Tower, because we know the guidelines. The guidelines was that despite the lack of evidence, a combination of low-dose aspirin and a thienopyridine is used early after TAVI, 3 to 6 months, and of course after clip also, followed by aspirin or a thienopyridine alone. So this is one strategy. Second, if you have, therefore, the authors of the popular TAVI, investigators of the popular TAVI wanted to test this hypothesis that patients who don't need oral anticoagulation, should you be using dual antiplatelet therapy or aspirin only? The second concept was patients who are AFib, combination of vitamin K antagonist and aspirin or thienopyridine is generally used for 3 to 6 months. And of course, it be weighted against bleeding. So what if in patients who need oral anticoagulation, should you give it alone or in combination with another antiplatelet therapy? So those were the two questions needed to be answered in a large number of patients, cohort A and cohort B. So cohort B was done first, which is anticoagulation with or without clopidogrel after transcatheter. 20% were NOAC in the monotherapy group, and in the dual therapy, 30% were NOAC. And basically we found significantly lower bleeding with the anticoagulation alone compared to anticoagulation plus clopidogrel. Now, these are the secondary endpoint of CV mortality, process bleeding, stroke, and MI. So whole idea was that no increase in thrombosis and ischemic events were identical between two approaches, numerically lower with oral anticoagulation. What about the second point? Aspirin with or without clopidogrel. So rather than doing a double, maybe just give aspirin alone compared to second group is aspirin plus 3 months of clopidogrel. Similar message came. The single antiplatelet therapy of aspirin did better compared to aspirin plus clopidogrel in terms of bleeding, which we knew. But what about other points? Thrombosis, exactly identical. CV mortality, ischemic stroke, MI was identical, whether you use aspirin alone or aspirin plus clopidogrel. So basically it became that in patients who there is no indication for oral anticoagulation, aspirin alone compared to aspirin plus 3 months clopidogrel reduce the rate of bleeding events, including major life-threatening or disabling bleeding, and does not increase the rate of thromboembolic event. So these are the top 10 advances. This is Mount Sinai data. We are doing quite well. 370 despite the COVID timing. We'll do more. This is 370 as of now. So there will be additional growth with the length of stay less than 3. TVT registry wise, we are doing quite well. So if I sum it up, TriGuard and Accurate Neo in advances of 2020, no good. A mitral clip, TMVR trial, tower durability, valve-in-valve tower, thumbs up. Tower for bicuspid, tower for intermediate risk and frailty indices, thumbs up, double. And the tower during COVID-19, don't postpone them, do it. And oral anticoagulation and aspirin alone is the way to go for these patients to improve overall survival. And we have this monthly webcast, which is second Tuesday of the month at 9 a.m. And Dr. Keeney has developed another teaching tool, which is the app Tower Cathode, and they're introducing many new features of how to engage the coronary arteries in these cases. So also, I just will sum it up and with the ACC accreditation that American College of Cardiology evaluate various programs nationally, and we were the second one in the New York to receive this ACC accreditation, which is the effort of numerous team members of the structural heart disease at Mount Sinai, which led to this accreditation and tower certification. With that note, I stop here and thank you very much.
Thank you, Dr. Sharma. As usual, a fantastic, fantastic top 10 in a difficult year for TAVR, still with some data, shows a lot about our subspecialty. We have Professor Eberhard Grube, Alexandre Abezai, Dr. Michael Mack will be joining us, as well as Didier Cheche for the live case panel, and I'll introduce them appropriately. But I want to welcome everyone back again to the live session here now, and introduce our keynote speaker. Each year we have an inaugurate our meeting and open the meeting with the best of the best. And this year we have an amazing speaker that we've been able to invite, and he's gracefully accepted and will deliver the opening keynote lecture, Dr. Pat O'Gara. He is the master of ACC, of course, the Watkins Family Distinguished Chair in Cardiology at the Brigham and Women's Hospital, and professor of medicine at Harvard Medical School. Dr. O'Gara was president of the American College of Cardiology from 2014 to 2015, co-director of the ACC Board Review, editor-in-chief, the consummate professional, the editor-in-chief of the ACC Collaborative Maintenance Program, the current chair of the task force of our guidelines. And I just can go on and on and on about this man who has taught me personally so much. Every week, he's one of the deputy editors of JAMA Cardiology. Every Friday morning, I learned so much from Dr. O'Gara. We are so honored to have him here today. And his keynote is on hot topics and future directions and valvular heart disease in COVID era. This has been the most difficult year, and he's going to give us the path forward. Dr. O'Gara, welcome to the New York Valve Symposium.
Good morning. I'm Dr. Patrick O'Gara from Brigham and Women's Hospital and Harvard Medical School. And it's a pleasure for me to join you in this wonderful 2020 New York Transcatheter Valve Forum. I want to thank the directors of the course for providing me with this terrific opportunity to speak with you today. I have been tasked with a discussion of valvular heart disease in the COVID era, the path forward. Here are my disclosures, which should not impact the substance of my talk. Well, let's start by recognizing some of the significant advances in valvular heart disease that have occurred over the course of the past 2 decades. These would include our improved understanding of the natural history of the disease through several studies, the arrival of multimodality imaging, and our reliance on both echocardiography as well as CT imaging for the bulk of our decision-making in patients with valvular heart disease, but also with important contributions from cardiac magnetic resonance imaging. Transcatheter technologies have continued to improve and are now made available to increasing numbers of patients. It's been nearly 2 decades since Dr. Cribier implanted the first TAVI prosthesis. And we should also, I think, pay tribute to our surgical colleagues who have developed increasingly durable and successful ways to repair natural valve tissue, both in the mitral and aortic position. We can rely on randomized clinical trials for evidence in areas in which we did not previously have it. And finally, we have made great strides in terms of understanding the presentation, management, and outcomes of patients with valvular heart disease through our registries, chiefly here in the United States through the STS-ACC-TVT registry. Here I'm showing you an example of the benefit of using multimodality imaging to gain a better understanding of the natural history of aortic stenosis. These are data from a cardiac MR study looking at both diffuse interstitial fibrosis and replacement fibrosis in patients with aortic stenosis exposed to chronic pressure overload. And not surprisingly, increasing degrees of myocardial fibrosis, as shown here on the right-hand side of the slide, are associated with reduced event-free survival over time. And certainly our ability to detect abnormalities in the ventricular adaptation to the chronic pressure overload has increased and improved dramatically over the course of the past 10 years. Think now of the application of global longitudinal strain imaging as a routine feature of the assessment of patients with aortic stenosis. And here are examples that we've learned from 4D CT to understand the incidence as well as the importance of hypoattenuating leaflet thickening, namely bioprosthetic leaflet thrombosis in patients who've undergone transcatheter aortic valve replacement. We now understand from several studies that this occurs in up to 10% of patients early on following valve implantation. But we also understand from recent data published from the Partner 3 registry that this is a very dynamic process. And as many as 50% of patients who have documented leaflet thrombosis at 30 days will not have leaflet thrombosis at 1 year, whereas as many as 20% of patients without leaflet thrombosis at 30 days may have it at 1 year. So these present challenges, I think, to the design, execution, and adjudication of trials of antithrombotic therapy following TAVR. Dr. Dangus will speak with you later in this course about that particular entity. Now, we certainly have had several advances in valvular heart disease understanding, but there remain substantial gaps. For example, the appropriate screening and detection of individuals in the community with valvular heart disease, understanding who they are and recognizing them before onset of symptoms or irreversible changes in ventricular architecture or function. Appropriate access to services by which valvular heart disease can not only be evaluated but also treated. This, of course, is a huge issue that underscores or reflects problems with disparities in access to care and outcomes here in the United States. The equitable provision of not only evaluative services, but also corrective services in patients with valvular heart disease. Why, for example, do restricted lines of referral that are dictated by insurance coverage prevent an individual from being able to access a reference surgeon or a top flight interventionalist in his or her community? And can we not make access to these kinds of expert services at comprehensive valve centers more uniformly available, independent of issues regarding finance? We know relatively little about the genetic underpinnings of valvular heart disease, including the genetic underpinnings of bicuspid aortic valve. Patients with bicuspid aortic valve have a smattering of single-nucleotide polymorphisms that have been identified, however, without a dominant mutation. And we know that there is familial transmission, but familial transmission appears to be incomplete, variable, and certainly an area in which more data and more understanding are required. And what about our efforts at preventing the continued chronic and long-term progression of valvular heart disease over time? Certainly, we have not identified any particular pathways that appear to be successful when it comes to stopping the process of the development of leaflet fibrosis, thickening, calcification, etc., as would otherwise exemplify the natural history of somebody with aortic stenosis. And then again, I should point out that although we do have randomized controlled trial data in some areas in valvular heart disease, we have very little randomized controlled trial data across the entire spectrum. And more studies of this nature are needed, provided they can be appropriately designed and executed. Here's an example of a randomized controlled trial published just last year after presentation at the American Heart Association. This is a surgical study of patients with very severe asymptomatic aortic stenosis, jet velocities in excess of 4.5 meters per second. Patients were randomized to early surgery versus a strategy of expectant observation or conservative care. And patients who were randomized to early surgery had a marked reduction in a cumulative outcome of operative mortality or death from cardiovascular causes. The average follow-up in this particular trial was about 4 to 5 years. Additionally, perioperative mortality rates across the 4 centers in South Korea that performed this particular trial was 0%. And whether the results of this trial can be generalizable over a larger number of centers with a broader population or spectrum of patients, as might occur here in the United States, remains to be seen. But nevertheless, a very important randomized trial in the valvular heart disease space. Certainly, there have been several randomized trials in the TAVR space, but aside from these two areas, very, very few. Now, certainly TAVI has dominated our discussions over the course of the past decade. I'm showing you this very compressed timeline in which TAVI now is applied across the entire surgical spectrum of risk and is now being applied in research to patients with asymptomatic severe aortic stenosis and to persons who have moderate aortic stenosis with LV systolic dysfunction. It is being applied in an observational registry-based way to patients with bicuspid aortic valve disease, but I will have a few comments to say about that later. There are some issues and some gaps with respect to TAVI. They are included here on the slide. There are questions about valve durability and the age threshold below which one would feel increasingly uncomfortable to implant a TAVI valve compared to a surgical valve. There is uncertainty around appropriate use of antithrombotic therapy, single antiplatelet therapy, double antiplatelet therapy, combination anticoagulant antiplatelet therapy, or monotherapy with an anticoagulant. And if an anticoagulant is chosen, a vitamin K antagonist versus a non-vitamin K antagonist. This space has evolved very quickly. There have been several trials reported and published over the course of just the past year, and Dr. Dangus will be discussing this further with you. There's the issue of conduction system trauma that occurs at time of TAVI, how to certainly predict its occurrence, but most importantly, the adverse long-term consequences of right ventricular pacing. The uncertainty as to who with bicuspid aortic valve disease may be a candidate for a TAVR intervention, although these patients were excluded from the randomized trials of TAVR versus SAVR. Certainly they are undergoing TAVR intervention with increasing frequency as each year passes. We must learn more about them, and hopefully we can eventually design a trial that would provide us with more transparent understanding of the comparative effectiveness of surgery versus transcatheter strategies for younger patients with bicuspid aortic valve disease. And then lastly, the very challenging issue, what is the appropriate strategy when anticipating that sequential procedures will be necessary over the lifespan in a younger individual who opts for a biologic heart valve replacement. These, I think, are difficult discussions that should be had prior to the index procedure itself. Now, I'd like to talk a little bit about the gap with respect to preclinical information that might impact our further understanding of valvular heart disease here, even in the COVID era. And we have spent most of our time, certainly over the course of the last decade, concentrating our efforts at interventions in patients here with severe disease of a symptomatic nature. And certainly TAVR has established itself as a transformative technology that has revolutionized our approach to valvular heart disease writ large. But can we not turn the clock back and focus efforts here at the earliest stage when identifying patients who are at risk for the development of valvular heart disease, such as persons who live in sub-Saharan Africa who have acquired a rheumatic fever at a young age, or individuals who are born with a bicuspid valve recognized in childhood and adolescence? Can we apply any kind of preventive measures so as to forestall or even abrogate the need for an intervention later in life? Now, certainly, we all know that the development of calcific aortic stenosis is an active process that typically evolves over the course of decades, and it depends in its earliest stages on endothelial dysfunction, on inflammation, on fibrosis, on calcification, on biologic processes with which we are quite aware. And we can actually follow this active biologic process with PET imaging, as shown here by Professor Dweck and colleagues when looking at the intensity of macrophage activity here at various early stages of disease that would go on then to predict increasing degrees of calcification over time. It's important to point out that these three atherosclerotic risk factors, namely hypertension, diabetes, and dyslipidemia, comprise a third of the population attributable risk for the development of new onset aortic stenosis across a population? Should not efforts at these three common atherosclerotic risk factors be doubled? And should we not see that if we could control these at a relatively earlier age, we would then show benefit not only with respect to a reduction in myocardial infarction and stroke, but also possibly with respect to a reduction in the incidence of a severe aortic stenosis over time? There's been great interest in the identification of lipoprotein A as a potential instigator, if not accelerant, of the process of aortic valve calcification over time. And we are excited about developments that have occurred with regard to the use of antisense oligonucleotides that are specifically targeted against lipoprotein A and shown to reduce their levels significantly. And now whether we can show a connection between a reduction in the level of lipoprotein A and a reduction in clinical events remains to be seen. But certainly there's great excitement in this particular area. There have also been some early observations with respect to clonal hematopoiesis of indeterminate potential, or CHIP. And as you know, this particular problem that resides among a certain clone of bone marrow cells can be responsible in late age for the development of a variety of chronic illnesses, including atherosclerosis. And these investigators in Europe have identified CHIP driver gene mutations that are associated with increased inflammatory activity that appear also to be associated with worse outcome following TAVI implantation in elderly patients with aortic stenosis. And I'm sure that we will learn more about the intersection between clonal hematopoiesis and of indeterminate potential, atherosclerosis, hypertension, diabetes, inflammation, and endothelial dysfunction as the years go on. Now, a few words about the COVID pandemic and in the era in which we find ourselves and the implications not only for access to care, but also for the research that we still need to do as a community in order to understand valvular heart disease at increasingly granular levels. First, we should start with the recognition, though, of the structural racism that unfortunately characterized or has characterized so much of our activities over the course of time, certainly here in the United States. We have learned quite a bit about disparities in outcomes as a function of race, as a function of zip code, as a function of a variety of the social determinants of health. And certainly we have obligations as an individual, as an organization, and as health systems to actively and everywhere try to deconstruct the barriers that allow structural racism to be perpetuated from one week to the next. These, I think, would eventually impact a variety of attributes here, as you can see around this particular circle, that continue to contribute to the adverse health outcomes and adverse outcomes with respect to valvular heart disease that the unfortunate, that the underprivileged, and typically people of color experience here in the United States. Now, it's not lost on anyone that we are yet in the third surge of COVID infection here in the United States. These are data taken from November 24 publication, the COVID tracking project. And as you can see here, the daily case rate in the second panel here has increased sharply just over the course of the past 6 weeks. We know that states that did not apply public health restrictions to the same rigor as other states seem to unfortunately be experiencing increasing incidence of new infections as each day goes by. There's an increase in the number of hospitalizations and unfortunately an increase in the number of deaths. And certainly the pandemic dominates all of our lives, not only with respect to the work we do within the hospital, the decisions we make with regard to resources, the performance of elective procedures, our educational efforts, as well as our interactions with family and the broader community is completely dominated by COVID, and it's not clear that the end is clearly or rapidly in sight, I should say. We're hopeful for the vaccine, but time will tell. Now, it's interesting to go back in the early stage of the pandemic and remind ourselves of some of these startling observations that were made. Here I'm showing you hospitalizations across the Mass General and Brigham, beginning here in January and through the end of March, early April. And as is true in Boston in general, Massachusetts, as well as New York and New York City, there was a sharp reduction in hospitalizations during the second month of the pandemic. These are the so-called missing patients. And we all saw a marked reduction in patients with acute myocardial infarction, with acute stroke, and with congestive heart failure. Were they staying at home? Perhaps that was the case because on the other or the flip side of this particular observation was the observation that there was an increase in the number of calls to emergency medical services for either out-of-hospital cardiac arrest or the observation of death without the typical trappings of a cardiac arrest. More people were dying at home, possibly because of their active decisions not to seek medical care out of fear of infection. And this particular observation then could be rapidly applied to what was happening with respect to our ability to do clinical research. People were not coming back to the hospital. They were perhaps also acquiring infection and developing endpoints in clinical trials that would not otherwise have been predicted when the statistical analysis plan was initially designed. And here I'm showing you some data from clinicaltrials.gov that were published by Mario Guadino and colleagues in Jack earlier this year, showing, as you can see here, a spike of activity in April, representing the number of trials that were stopped during the early phase of the pandemic on the basis of the desire to protect research personnel, as well as the observation that fewer patients wish to return for follow-up visits to provide informed consent and all of the other challenges that occurred early on. And stopping clinical trials of this nature, of course, had and continues to have serious implications for the research ecosystem going forward. Here is a statement from the Heart Failure Collaboratory that was published in Jack earlier this year, showing the effects of COVID infection on the number of research sites that remained open. And you can see here this downward curve, a decrease in adverse event reporting, and a decrease in cardiovascular hospitalizations that I've already showed you. And on the flip side, of course, the increase in cardiac arrest. Well, almost immediately, efforts were put into place to try to overcome these barriers, ranging from first and foremost to protect the health and safety of not only our patients, but also our research assistants and our research enterprise. Other ways by which to ascertain endpoints using wearable devices, changes in event adjudication, also changes in the prospective statistical analysis plan, and difficult decisions about whether to suspend a trial, to terminate a trial, or to continue a trial in hopes of being able to capture more events towards the end of the trial. And also on the flip side, there are other things that occurred that have changed our lives, I think, forever. Certainly the advent of telemedicine services is here to stay, and we will always go forward with a different attitude as well as a different reimbursement towards both telephone and video visits with our patients so as to avoid the need for in-person evaluation in a hospital setting. The same is true, I think, of our educational classroom work as well as forums of this nature. It's very unlikely that we will go back to the kind of in-person meetings that we were using routinely in the years preceding this particular pandemic. There's been important deregulation, I think a very important look again at the judicious use of resources and much more collaboration across clinical trial enterprises, certainly heart failure trialists and valvular heart disease trialists, to name just a few. The FDA, of course, has not sit idly by. They have stepped forward and made it easier for all of us to continue our clinical research efforts during this period of time. They have helped in reframing issues about how it is that informed consent should be obtained, whether this can be obtained electronically, whether this can be obtained remotely by other means, data collection, which can also be obtained now remotely using wearable devices to which I previously referred, endpoint adjudication, event adjudication, flexible sample sizes, adaptive design with respect to trials, and then some modification of statistical analysis plans as dictated by the reality of being able to bring a clinical trial to completion. We should all pause, I think, and congratulate and learn from our colleagues in the UK who put together this simple trial among many simple trials that they designed and executed. This is the Recovery Collaborative Group, published in the New England Journal of Medicine, showing an improvement in survival in intubated patients with COVID-19 treated with dexamethasone compared with those treated with placebo. A very, very important observation that was enabled by the platform design nature of the trials that they had established. Remember also, they looked at hydroxychloroquine, among other interventions that did not turn out to be useful. They were able to enroll rapidly, possibly because they worked through the National Health Service, and they certainly relied on a very simplified case report form. And this became, I think, the template that has now been utilized by the NIH in the construction of the ACTIV-4 trials, looking at the use of anticoagulation for the prevention of thromboembolic complications in patients with COVID infection, including patients hospitalized as well as patients following hospitalization. So there are some barriers to a pragmatic study, and I'd like to end with this particular discussion of whether, for example, there would be enthusiasm for an evaluation of SAVR versus TAVR in patients with bicuspid disease. This is a very thoughtful piece that was published earlier this year by Adrian Hernandez and colleagues in the New England Journal of Medicine that points out the barriers to pragmatic trials when studying intervention A versus intervention B. There's a lack of incentives currently in this space. Of course, there's the label indication that allows the use of TAVR in patients with bicuspid disease. There's limited enthusiasm because perhaps the train has left the station and this is being done frequently enough that it's no longer interesting. Patients are resistant to randomization. The informed consent process, especially during the workflow, is onerous. And then, of course, the implications of COVID and the difficulty in performing research in the current environment. Nevertheless, I do think that these can be overcome. We have much to learn from the Recovery Trial Collaboratory. We have much to learn as well from the Sweetheart investigators who helped provide us with a template for the performance of a randomized trial in a registry-based format. And I do hope that we can continue with our efforts of activism as well as inquisitiveness as to maintain the equanimity necessary to always acknowledge that there's much more to be learned in this space of valvular heart disease. The structure and the substrate is there, and I think we as a community can move forward in a very positive way with much confidence. I do want to thank the organizers once again for allowing me to participate with you. I hope you enjoy the rest of the course. Thank you.
Informative. Very good. Cutting edge.
Wow. Thank you, Dr. O'Gara, for that fantastic opening lecture. We now go live, I think, to lab 3 or lab 2.
6. Lab 6. Yeah. No, but we cannot hear now, Dr. Mehran. Hello, Roxanne? Yeah. Zoom. Can you see us and hear us now? No, okay. Well, after masterful lecture by Dr. O'Gara, we are ready for live case demonstration, and particularly towards end of his slide about the bicuspid aortic valve. And this patient is for the bicuspid, but we cannot hear Dr. Mehran clearly at present. But can you hear us, Roxana? No.
We hear you, but I wanted to introduce the panel. So let's make sure that you have that we have live panelists from around the world. We have live panelists from around the world. I want to make sure that everybody introduces them perfectly well. We have Dr. Alexander Abazaid, who is has been a pioneer really in bringing in.
See, again,
tell them to show this camera. Tell him, show this camera,
no, this
not that camera. No, it's that camera.
He's the director of interventional cardiology in Sao Paulo, Brazil, in a brand new center, and I'm really looking forward to hearing all the things that he's doing right now, and I know he's going to have a fantastic addition. Eberhard Grube doesn't need any introduction. You all know that he is another innovator in our field. Without his incredible efforts over the last 20 years, we wouldn't be where we are today. Eberhard, welcome to our panel, and thank you for being a partner with us on this course. We also have my very good colleague and excellent interventionalist, structuralist, Dr. Didier Cheche from Toulouse, France, who's a true star and a PI of several ongoing prospective randomized studies, and I'm just so thrilled to have him here on this panel. And then, at last but not least, the infamous Michael Mack, our surgeon. He's here. He is really one of us, but he has really pioneered the field and is now leading the valve collaboratory with Dr. Leon, and just so wonderful to have all of you here on this live panel. So we now go back to lab 6. Dr. Sharma, if you would introduce the case for us.
Yes, and thanks all the panelists. We'll need a lot of advice and comments on this case. I just want to introduce new members. So me and Dr. Keeney, everybody has seen, and Dr. Tang. We have the fellow here, Sunny Goel and Faisal. So 2 fellows, and our anesthetist, the cardiac anesthetist, is Dr. Eric Fried. So with that note, we start this case. And Stematos means and Stematos is on the echo section. You'll hear quite a bit from him. And these are all our the key participants for today. And the disclosures which have been shown earlier part of the presentation also. And we also tell after in between time for audience to go to the exhibit hall, which is again electronic. So this is the case, 77-year-old male presented with dyspnea on exertion and has the risk factors, as you can see here, most important being the T-cell lymphoma, going active chemotherapy, coronaries are okay, dilated ascending aorta, and also has some COPD on various medications, and was found, this was about a month ago, as a screening echo, was normal ejection fraction, was low flow, low gradient, with a mean gradient of peak gradient of 44, mean of 27, and the peak velocity was 3.3. It has changed a little bit, and we will show that now with the active live echo and comments from Dr. Stam Larakas. Yes, so can we go to the echo, please? Yes.
Yes, good morning from New York. I have on my left our structural imaging fellow, Dr. Anastasius. As you can see, this patient has normal LV function and normal RV function. Again, normal LV and RV on X plane. No much matter regurgitation. Normal strain, but -21. You can appreciate the aortic valve. You can appreciate the doming, which suggests that the valve is congenitally malformed and most likely bicuspid. Also, you can appreciate the dilated sinus of Valsalva, which measures about 4.1 centimeters. Also, the leaflets are thickened and calcified. This is the short axis view, which shows perfectly nicely that the aortic valve is indeed bicuspid type 1A with fusion of the right and left cusps. And you can appreciate the raphe here, which also is calcified. This is the non-coronary cusp. You can appreciate nicely that this type 1A bicuspid aortic valve.
Actually, that's a very good picture. Can you comment on, people talk about acquired bicuspid versus congenital bicuspid? How would you differentiate the fused commissures in the acquired bicuspid? Sometimes we do talk about that.
Yeah, I mean, this valve, you know, it looks that usually if it's acquired bicuspid, you can appreciate some that the commissure is opened a little bit, you know, between the cusps. Here is completely fused.
Okay.
So it's this looks that it's congenitally bicuspid aortic valve.
Beautiful.
And this is the X-plane of the aortic valve again. This is with color, no much aortic regurgitation, mostly stenotic valve. Today, with the help of Dr. Malcolm Anastasiou, our excellent fellow, we were able to get actually higher gradients. As you can appreciate, the Vmax is 4.3, the peak gradient is 74, and the mean gradient 44. So by these measurements, also the previously was, by the continuity equation was severe, but today also by gradients and everything, the valve is severely stenotic, aortic valve area of 0.5 centimeter square.
And I think this is a very important point, that within 1 month, things have become from low flow, low gradient to a high flow, high gradient. And clearly the velocity is almost like became 70% higher.
Yes.
So this is what had been, but a paper from ours also in the COVID timing, when you want to defer these cases, the event rate occurs almost 10% per month, if either requiring urgent TAVR or death, these patients. So clearly underline that whole concept, which we have learned over the years, that severe aortic stenosis is a very bad disease and need to be taken quickly. This is a classical example, echo done at Mount Sinai, the numbers which I showed, 45-27, now became 74-42, 44, just doubled, I mean 70% more within a span of about 3 to 4 weeks. Yes.
Yes.
Stem, anything new you want to tell?
Yes, also, that's an excellent point. And also, many times depends also on the operator. You know, sometimes if you have to try harder, you can find higher gradients, but I agree. This case was done here, the velocity was lower, and in a month's time, the velocity is now into severe levels.
Okay.
And by continuity equation, both times the aortic valve area was severe.
Okay.
This is full volume of the aortic annulus. We try to measure the aortic annulus with 3D, as they do also with CT. Sometimes when we cannot use contrast, we prefer this method. In this case, we did it just for demonstration. And as you can appreciate, the area of the annulus is 744, very close to what you will see the measure by CT. And also we are able to measure the height of the coronary arteries. In this particular case, the left main from the base of the annulus was 1.45 centimeters, which is also about the same as you can see they measure by CT. And the last view, this is the view that we use after the valve is deployed. This is a gastric view to evaluate the gradients and also to evaluate for valvular, but most important in this particular case for paravalvular regurgitation. That's what I have to say. Back to Dr. Sharma.
Okay, all right, we can go back to the slide. So quickly present and then so this
Dr. Sharma, can you wait 1 minute?
Yeah.
Can you hear me?
Yep.
Dr. Sharma?
Yes, very well.
Okay, so first of all, we've got to fix some things here because you're not me as I'm talking, and it's tough because I think this is a very important thing. You showed us a change in the hemodynamics, and I wanted to just see if the panelists had some thoughts about that because I think this is a really big teaching point. Samir, Mike, Mac. Samir first, then Mike.
I think that in the bicuspid aortic valve, many times this is an important point that when you measure the gradients because of the eccentric jets, transthoracic wise, sometimes you cannot align to the jets properly. And so either invasive or a more detailed analysis is necessary when we think that the valve is calcified and not opening. and the gradients are low. So that is my sense that this is probably related to the way now that with the TE, they aligned the jet properly. And with regards to the whether it is congenital or acquired, there is no real acquired bicuspid valve, because most of the pathologies that we see are not really commissural fusion. So it is most commonly a bicuspid valve that is congenital. And now there is a very nice classification that a lot of people have worked on to say that what should be the how much fusion of the commissures are there. And you can and Michael Mack and others have written on this particular
Yeah,
topic.
so let's have Mike give us Dr. Mack comments.
So I'll give three brief comments, Roxana. I agree with Samir that the differentiation between acquired and congenital is an artificial one and really of no relevance in terms of clinical decision making, and virtually all valves are congenitally bicuspid. Secondly, as Samir said, you've got two different techniques, transesophageal and transthoracic, to be able to measure the jet. I don't believe that there was rapid progression in a 3 to 4 week period of time. It's two different techniques getting different windows to look at it. And thirdly, you got a patient now under general anesthesia that's been unloaded, and that unloading by itself is going to increase the gradient. So I think those are the factors that explain the difference.
No, those are excellent explanations. And I think we are learning a lot now. We all got a mass email from Edwards about echo parameters in understanding hemodynamics versus what's happening. And I think we're going to have a very good discussion around this, because I think there's a little bit of madness going on, but absolutely correct about what you just said, that this is most likely a different view. This is definitely a congenital bicuspid valve. And now you're going to tell us the CT measurements, Dr. Sharma. We're back to you.
Yeah, so
thank you.
Actually, you can see the aortic annulus is on a larger side, which is anything more than 683. We call it large annuli, and area is 763 in this particular case. Maximum 36.6, minimum 27.4 with a mean of 32. So always question comes, what to do? Many times with a very large aortic annulus, we send them for surgery. But in this particular case, when active chemotherapy had a radiotherapy in the past, is not appropriate case, even otherwise a very low risk. So these patients basically resort to the tower. Gilbert, you want to comment on this?
Yeah, our group has published a multi-center paper on this, and certainly we've treated annulus this big, tri-leaflet or bicuspid before with the balloon expandable valve, and have quite good success as shown in the paper. I mean, I think what makes this patient particularly anatomically favorable is also the LVOT is a little bit smaller. If you look at the LVOT, we look at it routinely in terms of sizing as well. It's 631, so it's within actually the 29 sapien free range. So we feel pretty comfortable treating this patient. And if you look at the next slide, you can see certainly what stem show the large sinuses and STJ are very large, and you can see the raphe actually is not significantly calcified. As everyone knows, the recent Raj McCar's paper looking at severe bicuspid calcification, the raphe calcification is a predictor of potential adverse event. In this one, actually, the raphe is not severely calcified. So we think we should have a very good circularization of the valve with this particular case. Next slide. And again, just to show you here, that's the hockey puck view. You can see the raphe on a 2 o'clock position. The upper right panel is not like a big spear. Certainly there is calcification, but we think you should be able to open it up with a pre-ballooning and balloon expansion. Next slide.
And the coronary heights are
yes, the coronary heights are well. Yeah, you can see that this quite effaced. Next slide.
Yeah.
Access,
so before you go to the femoral access, let's hear the panelists, because this is a really
we'll do it. No, but I know, but remember, we had to, we'll continue discussion while the case being done, because patient is ready. The sentinel was already placed, which is about 30 minutes. So we'll continue. So just wanted to complete the presentation from the vascular access point of view.
Go back. Yeah, we have Parasuram. Parasuram actually was our structural fellow, and right now he is the young structural attending of this program. If you can just focus on Parasuram, he's going to start talking on the femoral access.
Sure. Yeah. Thank you, Dr. Kinney. Thank you, Dr. Sharma. So the CT scan actually showed pretty much non-calcified and a long CFA portion. We chose the right side And since especially the patient is on active chemotherapy, we always do a up and over bailout. So we actually got the non-main on the left side, and we actually have a V18 wire pot and the ipsilateral SFA through the left CFA. Also, in high-risk cases, we get extra vein in case if like thinking if some complications can happen, then we can actually go quickly on the pump. So we actually have an extra vein in the groin as well.
Okay. So so then Arch, this patient already have the Sentinel.
Yeah.
I know the national data as of 2019, use of Sentinel was less than 10%, but clearly in our center, we make it like many others, that Sentinel as a default strategy, which is done in about 60% of cases and will show. And so, and basically the valve sizing here, knowing that the large annulus in this particular case, going to use 29 millimeter, put additional 2 or 3 cc's of the contrast to really get to our area of 763. And this is basically sum up that low risk, but in a kind of extreme from overall point of view, although STS is low because of comorbid conditions and so. So this is where we are ready with the for the valve, and now Dr. Keeney is ready to cross the valve, and now we'll get all the panelists to discuss, but maybe we can just show one aortogram. This is a Sentinel device, and the aortogram, and then we'll just start. This is the large dilated aorta, 4.1, and while Dr. Keeney is now going to cross it with the AL1 because of the large annulus, that's what we do. Otherwise, AR2 usually we use. And now, Roxana, you can have our discussion, our extreme panelists.
Well, thank you so much. So a really great case of a bicuspid valve. I want to hear from Didier Cheche, especially given that, you know, the choice of the valve and, you know, here the Sapien is chosen. Is there a valve that should be chosen, one versus the other? And then we'll come back to Alex and Eberhard about neuroprotection and also some of these parameters. Didier, welcome.
Thank you. Thank you. Welcome. Good morning, everyone. So just to make it brief, I would say that for bicuspid aortic valves, you can use whatever device you want. Here it's more about the matrix of the patient. And as we are facing a very large annulus, we don't really know about what is the configuration of the supraannular region, but here I estimate that it's more like a flared configuration. So definitely the Sapien 3 is the most appropriate device with additional CCs. If the dimensions were a little bit smaller, and Evolut Pro would have done the job beautifully in that case also. So every device works. In this particular case, I would stick to the Sapien 3.
So what's your practice now in Toulouse? Are you feeling with, I mean, there's a little bit of a dilation of the aortic root here. Are you worried about the aortopathy? This is a 77-year-old man. Do you have any concerns about TAVR in a case like this?
So you're perfectly right, Roxana. This is a key concern when it comes to bicuspid. What are the dimensions of the ascending aorta? And when it is dilated, and if the patient is definitely not a surgical candidate, we will use the shortest device that we may have for this patient. And once again, the Sapien 3. Otherwise, if we have a normal configuration of the ascending aorta, we use preferentially in our center the Evolut platform for bicuspid valves, because of larger EOAs, very low gradients in this particular subset of patients.
I see you're already crossed the valve, Dr. Kinney. Thank you. We knew you would be there quick. Let's get a couple of more comments, and then we'll come back to you in understanding whether or not you pre-dilate, et cetera. Dr. Grube, any comments about the case so far and the use of neuroprotection? Would you ever go forward without?
Yeah, thank you, Rox. And I agree with Didier. I think you can choose whatever valve you want to choose, and you know the 29 Edwards is probably appropriate. The question to me comes up, and I might disagree with Didier on that, because there's still the jury out on what's the best sizing method. You know, there has been proposed many of them. I don't think we have a clear message in this particular case. Whatever you choose is fine, but if you choose a self-expanding valve, because of the large annulus, I would most probably go for a 29 Evolut Pro or Evolut, because, you know, as you know, the valve will never be circular. I've never been really impressed by annular measurements. And so I would not oversize the core valve. The reason being that if you oversize, the valve is being pulled into the ventricle, which you don't want. So here I would probably go with a 29 Evolute or Evolute Pro. I would not dilate in order to make the sealing a little bit better. And I think the choice of neuroprotection is excellent here.
Yeah,
In
wire.
bicuspids,
Yep.
this belongs to the risk factor for embolic protection.
Great.
Yep. So
Alex,
we have crossed the valve.
comments?
We have AL1. Yeah, AL1
Yep.
crossed it, and now we are ready to post the pre-dilate with a 25 millimeter ZMAT balloon. So we are ready to pre-dilate. I mean, pre-dilate for before our actual tower insertion. I know there's a lot of concepts. Some people don't pre-dilate, some people dilate.
Okay. What is it?
And
150.
and it's the confida wire.
So what's your philosophy
AVM.
on predilation? Alex, maybe we can hear from you and then we'll come back to Dr. Sharma on his philosophy. Alex?
I think it's an important comment, Roxana, because for bicuspid varicalcified valves, I tend to predilate to prepare the valve most of the time. So I think that Dr. Sharma has the same thoughts as I did. So I would prepare, and sometimes I even use for sizing. Remember, for bicuspid, we are never so precise in sizing. So I like to predilate most of my bicuspid. And again, perhaps this would be a good candidate for. I'm sorry that they terminated, but calcified and bicuspid, it would be a good combination for Lotus. But that's okay. I think Sapien is a good choice.
Oh, for Lotus, I see. Okay. All right. So any other thoughts before we go back to the main room to see what's next? And maybe you can tell us exactly what you're planning next, Dr. Kinney.
I know.
Yeah, we've pre-dilated, and I think just to give the tips of crossing, since we already know has a dilated, we have a dilated aortic root. We used AL1 with a straight Terumo wire. Now, bicuspid actually could be challenging to cross since it is fused raphe, and the aortic eccentric aortic opening could be challenging, but we are able to cross quickly here. Once you crossed with AL1, you change to pigtail, and then we go with our confida wire. We did the BAV like we said. Same. I think what the discussion is going on is to make sure the calcium and the raphe open up, and we will be able to get the valve to the position quickly rather than having some struggle to go through the fused raphe. So right now we have the valve. We just wanted to make sure two people always confirm the skirt is facing down. We have Gilbert Tang, who is going to be the first operator. I'm going to be the second operator, and the wire will be held by Parasuram, who will be the third operator. Very important, all the three operators know what their job is, and we're just going to go up.
You ready?
Yeah, starting.
Okay.
Yeah. Let the wire go a little further. Yep. And this wire, the valve need to be adjusted to bring it on the balloon once into the aorta in this view, and try to move as little as possible. Keep your view, which you're going to implant. Yeah. Good.
Please go through the steps one by one, Gilbert. Gilbert, go through the steps one by one. Please don't assume that everyone is an expert here.
No, I know. So you see here the loader cap. If are they showing here? Yeah. The loader cap is already here, and you need the loader cap fully inside the sheath, so the valve goes in. And this is also an important step, that your valve should go in and will not through the sheath and come out of the sheath easily and not hit any calcium. There is a risk that the valve could be stripped off at that time. Now the next step is loading the valve. Now it's the job of the second operator and the third operator. So the third operator is advancing the wire, and this is what I'm going to do. You release here and start bringing the balloon back. This has to be done in the straight part of the descending aorta. So you see the.
Please show them. Yeah, Laurel, exactly.
Lock it, and then you still keep doing with a fine small wheel. You see here, fine adjustment.
Yep.
The distal marker of the balloon is inside. Now it's completely loaded. Lock, unlock, just to make sure there's no tension. Then you go use this large wheel to flex.
So it's important.
So it has to be
pay attention
completely
to make
flexed.
sure you see the sentinel device, so you
Yeah.
don't end up interacting with the sentinel device as you cross the arch.
While Parasuram is holding the wire, he's advancing. I'm fully flexed.
Okay, we're going to
Now-
cross the valve.
And Gilbert is telling the
Okay.
NS,
It's important to tell
Please
the
show the
show
fluoro.
anesthesiologist you're crossing the valve.
Yeah, floor is there
Yeah, fluoro's there.
on the right side, no?
Yeah.
Yes.
and now
Yes,
also
yes.
what I did is I unflexed a little bit. Okay. Now we have to bring this catheter back. So
back.
the balloon is sheath back. Yeah.
the
So
valve
I'm
is
going to
across,
advance.
so yeah.
He's trying to
Yeah, good.
adjust it.
And we bring the pigtail back
So
down.
based on the calcium, you see that
So Maggie.
I think it's 70 iota 30 LV. We'll confirm it.
Okay.
So you bring the pigtail. Pigtail
right,
actually has to be in the
It's a big
non
group.
if we can.
The
I'm
right
trying
side.
to. So to get it, what you do is come up, counter, keep counter.
Good.
That's all we
That
can.
will be okay.
Yeah.
That will be
Okay,
okay.
go in. It's not in the non.
No, it's okay. I think that's
Okay, some dye.
Yeah, it's better.
maybe
Non
that's
is
just big
fine.
root.
In this case,
It's a
it's
big
better.
root,
Yeah.
It's a
That
big
looks
root,
good.
so you can, that's
Good.
okay too.
Okay, so
Yeah.
now I got it in the right position. Some dye. What do you think?
Yeah,
Yeah,
tell
that's
next
pretty
step
good.
what you want to do now.
So no, now I'll unlock. If you see here, this is
Blood pressure is stable.
yeah, good, right?
Yep.
So are you
now we'll
using the
confirm
echo
position.
parameters now?
No.
No,
nothing yet.
right now everything
we
will be
see?
fluoroscopy. Okay, so I have Ramon who is on the pacemaker. So I will be the only person talking and giving instructions. So go 180. So I want to make sure the mean is less than 40, which is right now. Show the hemo, some injection. Okay, stop.
Okay, show the hemo also on the left side below. And this is the time where you tell everybody is in the same page. You tell our cardiac anesthetist also that we are going to go up, because remember, compared to, I always say, with the surgery, the whole process is slow. It takes time. Slow in the means that it's a cumulative, and here is all or none. So everybody should be ready in case there is a problem in getting the blood pressure up. Give a rapid doses, high doses of epinephrine to bring the pressure up. But anyway, so they have been seen. Position is good. Now ready to deploy.
Everyone
Okay.
disagree on the panel?
Yes.
Yeah, I
Okay,
think the
180.
panel likes the
I'm going
position.
to take the pigtail.
Yep. Good.
So
Sure, no,
I'm ready to go up. So blood pressure is 40, slow inflation. You see the valve coming out, and now I go full. Now, when I go full, I want to make sure I complete zero expansion. Zero. Good. Few seconds there. I pull back.
And you keep pacing.
You stop pacing?
Stop pacing.
Or
Continue.
when do you
Yeah.
stop
No,
pacing?
you only
Yeah.
stop pacing after the balloon comes
Yeah.
out.
Once the balloon is completely deflated, you stop pacing. And Eric, the anesthesiologist, is paying attention to give increase the blood pressure.
Yeah, but the blood pressure is good. It's coming up.
Yeah.
Yes, coming up.
Resuscitation was, nothing unusual happened. Many times, particularly people with a low ejection fraction, it takes time to bounce back. But this case right away came back.
Looks
Pressure
very
is
good.
good.
Looks
There's
very
a
good.
para-
Now we get the echo. Now
Let's
we
look-
can take the
there's something
hemodynamic
here.
out and put the echo below, please.
At 2 cc. 2 cc.
There's some paravalvular leak,
Yeah.
I see.
Yes,
Right?
yes, there is.
Yeah.
See on the left screen?
That's at least mild there.
Yeah.
I would add the,
At least mild
Let's do it.
paravalvular regurgitation.
But let's ask the panel. We go with 2 more cc.
Yeah, so what do you all think? It's a little bit of, it's not severe. It's like mild to moderate, maybe
no.
mild, I would say. Is it moderate?
Mild, yeah.
Can we
No,
see it?
it's yeah.
You want to bring the echo
Can
on
we
the
see
main
the
screen
jet?
and just
No,
to
no.
analyze?
Okay, this
Yes,
is good.
yes.
This is good. You
No,
can
we can see
Okay.
it. Just show us the jet.
Okay. Can you put explain, please?
And in this particular
the
case,
panel
knowing
think?
that that PVL, a young guy, and he's supposed to have good prognosis of his CLL. So we will try to maximize. They put an additional 2 cc's before, They can put additional 1 or 2 cc's. We knew that annulus was very large. So not unusual, add 2 more cc's while balloon of the valve is still there, and go back and with additional 2 cc's because it's still mild plus. It's a mild minus or mild plus. So this seems to be mild plus by our echocardiographic team. STEM,
yes,
speak, please.
Yes, can you see the long axis? So I say it's mild, good mild paravalvular leak. Yeah.
Now, since we know the annulus is benign and no risk of perforation, we can post-dilate. We should go ahead and post-dilate. Let's put 2 more cc's and we'll go again.
Anybody on the panel
please,
would not do this? Didier, Eberhard, Alex?
You want to do aorogram first?
I believe that in this case, there is a need for post-dilatation, but I think that there was one thing that could have been done slightly different in the CT analysis is understanding what is the configuration of the supraannular region. Because if you have something that is way larger than the annulus, you're not going to get a device that is going to seal properly. So if you have a tapered configuration, the risk of the ability to seal everything with the supraannular region makes sense. Here, probably we have a flared configuration, so there may be a residual regurgitation because it's a very large anatomy. But it's already a very nice result, I have to say.
All right. No, this is a really good point. So the supraannular
150
ridge
again?
configuration.
180. Eric, we are post-dilating.
As they're post-dilating, any comments, Eberhard, Alex?
I think I would like to mirror Didier's point. I think this is what we see when you try to circularize in a large annulus. You know, there will be some leak, and I'm doubting.
Okay, stop.
You know, that you get rid of it.
Okay, now we come out, right?
Yeah.
It's still there. Okay.
Yeah, and I think that's what Didier was saying, that based on the CT, Dr. Kinney, that it may be that you will not be able to get this paravalvular leak be gone just based on the way the valve is positioned and the configuration of the valve and the configuration of the supraannular ridge by CT. That, you know, you did your best, you went up a little bit, you post-dilated, you gave a couple of more cc's, and what he's saying, and I think the rest of the panel are agreeing, that you're not going to get rid of this little mild leak.
Do the aortogram now. Okay, we'll do the aortogram. Yeah,
we'll put a pigtail in first, Dr. Sharma.
Because
what Gilbert, you agree with that? Gilbert?
Yeah, no, so Didier, we actually
Yeah,
Didier, we actually look at the supraannular aspect of it. I mean, because of dilated root, you know, we know that it's going to be larger than the mean diameter that you measure the annulus. I would say it's probably around, like, I don't know the exact number right offhand, but it's probably around mid-30s or 35, 36. If you look at, let's say, a commissure distance. But I think the other thing that's different about this particular anatomy compared to other bicuspid anatomy, as you saw, is that there's really no supraannular calcium. You know, in terms of that might constrain the valve or make it a potential bit better seal. So it's pretty benign leaf-like calcium overall. So we've actually started doing post-CT in some of these bicuspid patients and show that even if you add volume to an undersized valve, it really goes up to about 31 millimeter in the frame dimension at most. It's not like going to go to 33 or 34. Indefinitely, you know, so I think there is could be some limitation to how big you can expand the S3 at least in the patient versus on the benchtop model.
Can we re-zero everything?
We go put the catheter and the pigtail in the LV now to show you some hemodynamics.
Yeah, we can see it now. Show the hemodynamics now. You're done. Yeah. Good. Hemodynamics looks very good. As you see, there's no gradient.
Looks good.
Diastolic pressure is good. Yeah.
Yeah, you can see that despite the mild PVL, the diastolic pressure in the 60s, in the 50s, 60s, and
can we get the TE up?
Yeah. Yep.
And we'll show you the aortogram as well.
Yeah. We are going to show the aortogram.
Yeah, we typically do an aortogram to check the final position, coronary flow, and all these other anatomic parameters.
Okay, inject.
Yep.
All right.
Very good.
Looks very good.
Looks really, really
So you can see
good. Fantastic
we also
results.
like to implant
Can you
these
tell
valves
us
a little
what
bit
the
more high
Yep.
position.
Yeah, no, we noticed that. Can you just give us the plan for the follow-up of this patient?
Yeah. So basically, right now we are still in the same of the aspirin plus clopidogrel for 3 months. I know with the popular TAVI, you can make it only one, but still the guidelines have not come through. So this patient will be on aspirin and clopidogrel and follow up, of course, in-house echo tomorrow. And knowing that no need for any pacemaker, likely will go home tomorrow, pending any full protocol of the post care, which is what our 2 structural fellows do. And the plan will be 30-day follow-up, and of course at that time do all the KCC questionnaire and show frailties and indices which are requirement by the TVT registry, and then 1-year follow-up. Many of these cases now having a Zoom or telephonic consultation. With that note, if it's okay, I know we are behind the.
Yeah. Well, 1 minute.
I also wanted to
just say how you will complete closure. Let's finish 1 second.
The closure and also about
Closure,
the aorta. There is a aortopathy here. I want to know what you're doing about follow-up of that aorta. And then, of course, the closure. So those 2 things, and then we got to go because we're a little bit behind.
Yeah, right.
Sure. So we'll take the sentinel out first now, and then we usually reverse anticoagulation, give ACT back to baseline. And then we already have a wire from the contralateral non-main axis side. So we routinely go with a balloon and then balloon tamponade, even before we actually go down on the ProGlide. And then once we are done with the balloon tamponading and locking the ProGlides, then we take a final angiogram, just make sure that the axis side is okay. And then close the non-main axis side as well.
Okay, good.
And the yearly follow-up for the aortic root dilatation, aortic size, which is 4.1 now. And we know that limit is 5+. So that's a long way to go. And hopefully, who knows, in 5-7 years, maybe appropriate ascending aortic dilatation cases will be done percutaneously also, transcatheter wise. With that note, we complete our presentation of the live case, and you go back to your important hot topics, Roxana.
Well, no, thank you. I want to thank the panel. We're going to come back with, thank you so much for all of the great work. And thank you Didier and Eberhard and Alex. And we're going to move to our internationally renowned first speaker, Dr. Michael Mack, who's a cardiothoracic surgeon and huge contributions.
Here, what he says.
His first lecture will be on adapting to change in structural heart disease training. He's been spearheading some of those trainings in combining surgeons and interventionalists. So we welcome Dr. Mack.
Thank you for the opportunity of discussing training in structural heart disease and adapting to the change that we're seeing with the tsunami of structural heart disease procedures that we're seeing. This is my conflict of interest disclosure. I have been in the leadership of 3 trials of 3 different sponsors in the structural heart valve disease arena. So how have most operators and centers been trained in structural heart up until the current time? Well, industry courses have played a major role. Proctors coming to sites that have mainly been industry sponsored, international meetings that are specific to structural heart disease, including London Valve, Euro PCR, TVT, and TCT meetings, have had a strong role in education and training. A lot of it has been on-the-job training. It's kind of learning by doing, learning from peers, learning from colleagues, learning together. And then lastly, there have been non-ACGME certified fellowships that have been of variable length and various core curriculums that have not been, pardon the pun, structured, so to say. So do we need a more formal structured training in structural heart disease? And I would argue that yes, we do, because structural heart is now a specialty unto itself. It's not just an interventional procedure. It's not just a cardiac surgical procedure. It is a specialty. Although the current forms of training have served us well until now, I think the adoption, especially of TAVR, have been seamlessly smooth in the US and worldwide. The future needs are going to require a more focused and comprehensive approach. And indeed, this isn't all about TAVR. It's about the aortic valve, the mitral valve, the tricuspid valve, left atrial appendage, ascending aorta and treatment of aortic dissections, left ventricular outflow tract issues, HOCM, minimally invasive mechanical circulatory support, and on and on and on and on. So there are a number of programs now that are not ACGME certified, but offer structural heart fellowships for interventional cardiologists. And there are, at last count, 40 programs available in the United States that you can see listed here. There are 10 programs for structural heart fellowships, specifically for cardiac surgeons. And again, you can see that the 10 programs listed here. So what's included in fellowship training? Well, first of all, and I think most importantly, is clinical decision-making, specifically a heart team approach in valve clinics. Shared decision-making with the patient, how to discuss all options with the patient, and truly shared decision-making and not just informed consent. Skills in diagnostic imaging, echo, CT, and MR. Intraprocedural imaging skills, which I think is becoming a specialty unto itself. Procedural skills, exposure to cardiac surgery procedures for cardiologists. I think has been extremely instructive for our cardiology fellows. Management of complications, post-procedural care, and lastly, research opportunities. So we have had structural heart fellowships at our institution now for 8 years, and we've trained pairs of cardiologists and cardiac surgeons together. This is one of our recent graduating trainees, Kareem Al-Azizi, who's an interventional cardiologist, and Anita Kruger, who's a cardiac surgeon, who spent the year training together. This is their workload, or what their typical week was. They cover all structural cases, TAVR clinic, provide second opinions on surgical and TAVR candidacy, mitral valve clinic, which now includes tricuspid valve clinic, valve service responsibilities, including consults, rounding, discharges, attending and presenting at weekly TAVR meetings, attending the monthly mitral tricuspid research meeting, surgical high risk conference, weekly research meetings, and for both of them, scrubbing in surgical cases, obviously with different degrees. And so we're very strongly a fellowship-based program, and here you can see Anita and Kareem doing procedures together. On the left, you can see that Kareem is the primary operator with Anita assisting him, and I am the staff surgeon in the background there between the two. On the right, you can see that Anita is primary operator for a MitraClip procedure, and Kareem is second operator, with Rob Smith being the staff scrubbed into the procedure. And this is a typical experience of what they experienced in their year structural fellowship. Kareem did greater than 436 cases, including 200 TAVR procedures, 20 Watchman, 16 MitraClips, and then over 200 PCIs, usually on structural heart cases. Anita did a total of 273 cases, of which 161 were TAVR, 12 MitraClips. She had to learn transeptal procedures, so she did some additional procedures there. Some specialized surgical mitral procedures, balloon valvuloplasty, tricuspid procedures, and then 68 minimally invasive mitral and tricuspid surgical procedures. So we actually have expanded our fellowship program that as of July 2021, we not only will have an interventional cardiology structural heart fellowship and a cardiac surgery structural heart fellowship, but we're adding an imaging structural heart fellowship now that will embrace echo, CT, MR of structural heart disease, as well as intraprocedural imaging, including ICE. And actually, two of our fellows from July 2021 are a cardiac surgeon and an imaging specialist sent to us by John Webb and Anson Chung from the program in Vancouver. So there is a proposal for having future structural heart training become more formalized with an ACGME certified training that will include all aspects of structural heart disease in a one-year structural fellowship. There are pros and cons to it. The pros are that it promotes and preserves the heart team concept. There's more cross collaboration that will organically filter out into the community at the completion of training. It's possibly the most effective. The training would be disease specific and not just valve specialists for valve specialists and not just TAVR proceduralists. It would be a unique paradigm of multi-specialty ACGME certified training. The majority of knowledge and skills are common to both cardiology and cardiac surgery, and it's a certificate that would be recognized by both specialties. The cons are, well, things are going pretty well right now, and not everybody is convinced that this needs to be formalized. It is the most ambitious way of doing this. It requires deconstructing the current mindset and building from the ground up. There are more likely to be more interventional cardiologists than surgeons trained. It requires an extra year of training. You have to justify interventional cardiologists training surgeons who may be competition. Surgeons start off behind. And right now there's limited surgeon involvement in structural heart, mainly because the job market for surgeons is so great right now that they don't want to spend an extra year training. So this is an example of a fellowship rotation for interventional cardiology and cardiac surgery, how it could be structured. So in summary, structural heart disease is now a specialty within interventional cardiology and cardiac surgery. Although training until now has been sufficient, it is time to formalize training with a basic core curriculum and standardized comprehensive approach, whether it's in non-ACGME or optimally ACGME structure. The optimal way to preserve and foster the heart team approach is with a common fellowship. There's a myriad of devilish details to address, including the burden of additional training, cross-departmental structure, financial, etc. So thank you for the opportunity of making this presentation, and I look forward to the rest of the meeting.
Thank you, Dr. Mack. That was certainly a fantastic lecture, really bringing us up to date on what's happening today in training our physicians, surgeons, cardiologists alike in TAVR and structural heart disease. I am just so thrilled to introduce our next speaker. Dr. Alex Abazaid has been a friend and a colleague for over 25 years for me, and he's my brother, really, and we're just ever so connected in this horrible situation now, even more so together. Alex is a pioneer and a innovator. He thinks outside of the box and brings the best of the best always forward in pursuit of the best care for the patients. He's now leading a huge center in Sao Paulo, Brazil, and we're just so thrilled to have you, Alex, here with us today. Honored to have you as our one of our speakers. And always you're thinking about the next generation of valves. And so we Can't wait to hear your current update on what's coming down the line. Alex Abizide, São Paulo, Brazil.
Hello, my name is Alex Abizide. I work at INCOR in São Paulo, Brazil, and it's my great pleasure to participate in this very important event. So I thank Professor Sharma, Professor Kini, and my good friend Roxana Meran and all the organizers for the very kind invitation. My mission in these next few minutes is to update you on next generation TAVR systems. These are my conflict of interests. This slide really illustrates how we started the whole TAVR field with two systems, the Edwards SAPIEN XT device, and then with CoreValve, and moved very fast to novel generation devices. These current generation devices are meant to improve TAVR performance, including decreasing vascular complication, paravalvular leak, pacemaker use, to name just a few. So today I selected 8 to 9 systems that are being used currently and that will come very soon to most of the cath labs in the world. And those are perhaps the most popular ones and the ones that are very, very promising. So let me start very quickly. I don't think I have to spend much time with the SAPIEN system. It's one of the precursors and the oldest that we tested. We started with that 17, 18 years ago with Professor Cribier, but there's a lot of changes. And perhaps the most important change recently is the SAPIEN 3 Ultra device, which really is this self-expandable valve, balloon expandable valve with open cells and made by cobalt chromium with this extended skirt that the company changed the fabric, so it's a more textured fabric as compared to the flat oven fabric in the past. So you can clearly see the difference between SAPIEN 3 and Ultra. So that certainly can improve the performance in terms of decreasing paravalvular leak. The sheet that Edwards put together is the Excella sheet. And essentially the concept is to have a 14 French device that accommodates a great matrix from 20 to 29 millimeter SAPIEN systems. And again, this is a sheet that gets into the femoral access with 14 French and expands for the valve to get inside and then comes back to the original size. So very good news for vascular complications. Very short movie to show you the concept for those who are not so familiar. Again, balloon expandable device, cobalt chromium, and you can clearly see the skirt that was built to decrease paravalvular leak. So very simple concept with an open cell and a short valve. We will guarantee will provide with good coronary access. Moving to the second system, and again, a very popular one by Medtronic, Evolute R Pro. And there is clearly change from first generation to the most recent generation. They were able to tailor height and shape, again, conformability and sealing, which is good news also for paravalvular leak, with a very circular cohabitation, which helps to avoid also the generation of the valve. And again, moving forward, Evolute Pro Plus is this device that you can see with an extended skirt as well to avoid leakage, and with Evolute FX, which will come very soon to the market. Portical will remind you a little bit the design of Evolute, but with some differences, as if you will. You see that the diamond's a little bit more open. Again, self-expandable nitinol valve. Probably the insertion of the leaflets is a little bit less high as compared to Pro, but is still considered to be close to a supraannular solution. This is a short movie to show how this valve works. Again, self-expandable. As we retract the sheet, you're going to open the valve, you see the leaflets working, and then you can partially deploy and retrieve if the location is not perfect. So again, very similar concept, very much what you saw with the core valve system. The accurate Neo2 by Boston Scientific is perhaps the one that I have a larger experience since we performed the first in-man study in Sao Paulo, Brazil. So this is also a self-expandable valve with a supraannular solution. As you can see, the leaflets are higher than the annulus position. It has these 3 anchors really to help you to position and make the whole device more coaxial and more stable, so you can go ahead and do the final deployment. So remember, this valve as a 3-step procedure with the lower crown, upper crown, and the stabilization arches. So in this next few slides, you're going to see how this device works and how is the mechanism of action and how we deploy it. After the alignment, you retract the sheet and then you release the upper crown. So at this point, you can move the valve forward or backwards. The second step is to release the arches. So by doing that, you can really have a more fixed device, more centralized and stable, so you can go ahead and perform the last step, which is to move the sheet forward and release the lower crown. So then immediately the valve is working. So just a real life example. As you can see, after position, we release the upper crown. The second step is to release the arches. So then you see that automatically the system will be more centralized and very stable. So then you can go ahead and release the last step, which is the lower crown, and the valve will be in the right position. Again, self-expandable valve, and of course with next generation being released. This is the final result for this case with no leak in very good position. So I thought that would be interesting to show one slide with some data. And this is the data that we collected here in Brazil with our first 100 patients with long-term follow-up. This is a 5-year echo data showing the sustained result in terms of valve area. Here you can see in this blue line, and also with low gradient. So this is again mechanistical data with echocardiography as long as 60 months. So good performance, and of course we can discuss the recent results from scope 1 and 2 that I'm sure that is going to be one good point for discussion. But in our experience here in Brazil, with a good number of patients and good sizing and good planning, we have very sustained long-term results. Again, very good news is that all the studies so far has been performed with NEO, with accurate NEO. Now we have NEO2, which has this extended also a skirt. As you can see, most of the devices will come with this solution to decrease paravalvular leak, and accurate is also a good example of that. So very soon we're going to have more data on NEO2, and I think the performance will be much, much better than the ones that were tested in scope 1 and 2. GINA valve, also very interesting concept, because this valve can be a good option not only for aortic stenosis, but also for aortic insufficiency. And the reason why I'm saying that is because this valve has a mechanism that grabs the leaflets. And by doing that in less calcified valve, there is a lot of regurgitation, this could be a fantastic solution. As you know, in most of the devices that we have available now, they are not perfect devices for aortic insufficiency. And this might be, you know, an official indication for AR. The other system that we had personal experience is the Allegra system by NVT that was recently acquired by Biosensors. Also another nitinol self-expandable valve. And this has perhaps the insertion of the leaflets is not so high, but as you can see, this is an interesting mechanism that releases the valve more in the middle and then towards the edges. So that makes the device a little bit more predictable in terms of deployment. And this is an example that we did here in our institution. As you can see, you release first the center and then you go towards the two edges. And that makes also the deployment a little bit more predictable. My valve from Mary Life Science is another balloon expandable valve. It reminds you a little bit the design of Sapien, as you can appreciate. There are some interesting features of this valve. It comes also pre-mounted, so it's already in the sheath when you deploy it. We don't have to do the maneuver to get the balloon inside the valve because it comes pre-crimped onto the balloon system. So this is the Python expandable introducer that Mary Life Sciences created. It's a special tissue that expands so it doesn't have that overlapping that most of the expandable sheath has. So I think that we'll have an interesting application since we need to be less traumatic with vascular access. This is a real life example, a case that was performed in India by Professor Sharma. So this is the position. You see that a very calcified valve, and this is the expansion and deployment. So good balloon expansion. And here on your right-hand side, you appreciate the final result. Again, good sizing and with no paravalvular leak. Finally, I would say that in some situations, better than any prosthesis is to have no prosthesis. So I think that the Leaflex by Picardia is a great example of a valvotomy device that can postpone a more definitive treatment or even do some kind of special cutting that will avoid any kind of permanent device. So this is again the concept in a short animation. The leaflet catheter advancing into the left ventricle. There is a deflecting catheter. Then you can proper position the device. You see the expander that was just unsheathed. And then the second piece is the frame, which you're gonna grab the leaflets in perhaps more than one or two orientations. So as you can observe, we're gonna do some good scoring of the calcium and release the leaflets, release the adherence. And by doing that, you're gonna monitor pressure measurements to see if you have a drop in gradient. So it's a very smart device that we can use either for preparation for a TAVR system, or this can be a standalone device. So very interesting, as now we are talking about treating younger patients who are talking about durability. So this can be a fantastic alternative in the near future. So as you can see, the clear scoring as we expand the expander with the frame on multiple situations and multiple locations. So very interesting concept. So this is my conclusion slide saying that major improvements certainly have been made on TAVR technology during this past decade. TAVR indication has expanded to lower risk, as we all know. Since there is no system that addresses all the limitations such as paravalvular leak, pacemaker use, vascular complication, we might have to customize the strategy based on clinical anatomical findings, and certainly proper training and case screening are the key for success. So keep in mind that very soon we're going to have multiple options, and we might be able to customize our choices based on certain anatomies and certain clinical indications. With that, I thank you so much for your attention.
Alex, unbelievable, an incredible lecture on the future technologies, and so exciting that we are very, very happy to have had you from INCOR, an incredible center that it will now be even better with you there. So thank you, Alex, and it's going to be great to have you in the Q&A sessions that are coming up in a few in the next hour. I'm hoping that you'll return. But thank you so much, Alex, and thank you for being there live with us, and keep working. And now I move to our next speaker, another really, really close friend, Dr. Raj Makkar from the Schmidt Heart Institute at Cedars-Sinai is no stranger to anyone. Obviously, he's been prolific in the field of TAVR. He's currently the Associate Director of Interventional Technologies at Heart Institute, Associate Director of this Heart Institute. He is the Stephen R. Corday Chair in Interventional Cardiology and the Vice President of the Cardiovascular Innovation and Intervention. He has so many titles, it'll take us forever. But today, he's going to talk to us on TAVR and bicuspid valve. So perfect, because our first case was a bicuspid valve, and it will be great to hear from him. Thank you, Raj, for being here with us today. Dr. Raj Makkar.
I'm Raj Makkar from Los Angeles, and I want to thank Samin and other course directors for inviting me to talk at the symposium, and I want to wish everyone good health. In terms of bicuspid morphology, 4D-CT is an excellent tool for phenotyping. As you can see in this particular slide, that these are all different bicuspid aortic valves, but they have different implications in terms of planning the procedure, or whether in terms of choosing whether you would actually send this particular patient for surgery or for transcatheter aortic valve replacement. So what matters most to a TAVR implanter is the number of commissures more than the number of cusps, the degree of calcification, the presence of raphe, if it is calcified especially, correct sizing, which is affected by all of the above features, in fact, to minimize not only root injury, but also to reduce paravalvular aortic regurgitation. Now, despite multiple series, including this very classic manuscript by Dr. Roberts, which suggests that though the prevalence of bicuspid aortic valve in patients undergoing isolated AVR is almost 50%, when you look at number of registries, such as the TVT registry, only 3 to 7% of the TAVRs are actually being done for bicuspid aortic stenosis. So as we talk about the data for TAVR and bicuspid aortic stenosis, I think we should keep this in mind, that TAVR is therefore being used selectively in bicuspid AS, and the data should be interpreted accordingly. So I thought I would start off by describing what is going on in our lab. So here are some case examples. So this is a 64-year-old gentleman with symptomatic bicuspid aortic stenosis. What I want to point out here is the fact that the left main coronary artery here was originating at 7.9 millimeter square, and that was clearly an anatomical exclusion we felt, and this patient was sent for surgery. Here's another patient who's 53-year-old physician with severe aortic stenosis. The showstopper for TAVR here was in fact the aortopathy. If you look at the aortic size, it was more than 4.5 centimeters. And in addition, the calcium was actually quite significant. So clearly, this is a patient that we sent for surgery as well. Here is a patient who's 80 years old. And in fact, if you look at it, there's not one, but two calcified raphe here, but they're not very severely calcified. And the left main origin was borderline, but the sinuses were large. We went ahead and treated this patient with balloon expandable TAVR, and he did really well. And this is his echo, the following day with no paravalvular leak. Here is a patient who's 65 years old. The gradient is 50 millimeters of mercury. And if you can see, there's actually some calcification in the LVOT. But the coronaries were very high. So we, in fact, thought that not only is this a good case for TAVR, but also a repeat TAVR in the future, which may be required given that he's only 65 years of age. There were other social issues with this patient, and we, in fact, decided as a heart team that TAVR was a suitable treatment for him, and we treated him with the SAPIEN 3 valve here, as you can in fact see, a SAPIEN Ultra valve, and this is the echo on the following day with no paravalvular leak. And to get a little bit more controversial here, in fact, is a 69-year-old patient who has aortic stenosis. Once again, the left main height was 9.9, but the sinuses were quite large. And this patient wanted a TAVR, and we did go ahead and offer a TAVR to this particular patient. As you can see, that the valve is actually quite ways away from the ostium of the left main. And despite the fact that we protected the left main ostium, we did not have to use a stent. We feel that this patient may also be, in future, a reasonable candidate for TAVR in TAVR down the road. This is the echo that actually showed mild paravalvular leak. So what is the data? I think I want to start off with this TVT registry data in almost 2,700 bicuspid aortic stenosis with the average age of 74 and STS of 4.9. And, after propensity matching, what we found was that the bicuspid aortic stenosis TAVR outcomes were actually quite good. Though the conversion to surgery was more frequent in bicuspid aortic stenosis, it was still less than 1%. And the annulus rupture occurred in 0.3%. The need for second valve was in 0.4%. If you look at 30-day outcomes, the all-cause mortality was similar between bicuspid and tricuspid aortic stenosis. The stroke rates were somewhat higher in patients with bicuspid aortic stenosis, 2.4% compared to 1.6%, and the pacemaker rates were 9.1%. One-year mortality was similar. If anything, a little bit lower in patients with bicuspid aortic stenosis. And similarly, the stroke rates actually were very similar at 1 year. The paravalvular leak rates were also not different between bicuspid and tricuspid aortic stenosis, but I think it is important to understand these are site-reported without core lab adjudication. Similarly, mean gradients and aortic valve areas were also similar between bicuspid and tricuspid aortic stenosis. Looking at the TVT data, we do get a big picture, but I think it's important to be granular. And my associate, Sang-Han Yoon, in fact, assembled more than 1,000 CT scans from over 24 sites globally, and looked at the anatomical features. The type 0 bicuspid aortic valve was present in 10%, and the rest of the 90% of the patients actually had type 1 bicuspid aortic valve, and half of these actually had calcified raphe. The STS score of these 1,000 patients was 3.7. SAPIEN was used in 70% of these patients, with the Evolut Pro being the second most commonly used valve in 18% of patients. The 30-day mortality here was 2%, and the stroke was 2.4%. But more importantly, looking at all of these different phenotypes, CT phenotypes, what Sang-Han showed was that the combination of calcified raphe plus excessive leaflet calcium, in fact, produced worse outcomes in terms of aortic root injury, in terms of more than moderate paravalvular leak, and also in terms of 30-day mortality. So here is the central illustration of this paper that was recently published in JACC, and what it shows is that the combination in the upper curve of the combined calcified raphe and excessive calcium was one that was associated with the worst outcomes compared to patients who had none of these features. So what should we do? And how when there are patients that need TAVR, and in fact they have high-risk anatomical features such as this one. You can see there is excessive calcium, there is calcified raphe, and this is clearly somebody, a patient where if you don't be careful, would be prone to aortic root injury. So here are the this is the area 497, and in this particular case, once again, we used a 26 millimeter valve, but in fact with a lower volume, in fact -3 cc's. So I think these things are important as we do these procedures, and you can see how the calcium and how it actually causes the recoil, which necessitated, in fact, an additional dilatation, though with a smaller, not with more volume, but with the same volume. This is the aortic root angiography. So it was feasible and possible to do this high-risk patient because the clinical situation demanded so, but I think one has to be careful. So what are the other data? So I think the other important data are the PARTNER 3 bicuspid registry and continued access program. I think if you look at these are data from 30 sites, a total of 237 patients were presented to the committee. 173 patients were enrolled in both registries, and almost 1/3 of these patients actually were excluded because of anatomical features. You can see that the age is 68 and 71 years, and the STS score here was 1.4 and 1.5 in registry and continued access program. I think the important thing to stress here is that there was zero mortality. If you look at in-hospital, zero mortality, and if you look at other complications as well, they were actually 0%. So I think these are excellent data for the use of balloon expandable stent in bicuspid aortic stenosis, with the caveat that, of course, as you must know, that 1/3 of these patients were excluded based on anatomical features. If you look at the 30-day outcomes, once again, all-cause death was 0%, and at 1 year, the all-cause death was 1.4%. One has to say that these are outstanding data. And these are some of the other secondary endpoints. I think the important thing to point out is the pacemaker rate was 9.9% in registry and 5.1% in the continued access program. So some learning there. Now, paravalvular aortic regurgitation rates, there was no case with moderate or severe paravalvular regurgitation rates. And the rates for mild PVL were about 27%. So similar data exist, not as large, but also for the Evolute Pro in bicuspid aortic stenosis. So I think if you look at the outcomes here, these are data presented by John Forrest. You can see that the 30-day mortality was 3%, and this was significantly better than the previous experience with the core valve, and the stroke rates were 5.6%. Now, going to the more recent experience, not from the TVT registry, but from a properly controlled prospective multi-center registry sponsored by Medtronic, where once again the key exclusion was less than 60 years of age. 222 patients were screened, and 149 patients actually ended up getting the valve. And most of these patients, like all series, were type 1 bicuspid aortic stenosis, 90%. And the average age was 70, and the STS score was 1.4. Once again, if you look at the all-cause mortality, it was 0.7% at 30 days. So I think these are excellent data. If you look at the stroke rates disabling, also less than 1.4%. The valve hemodynamics were excellent, and also there were no cases of moderate or severe aortic valve regurgitation. So in ending my talk, I want to first talk a little bit about what are the practical considerations. I think it is important to be careful about unfavorable anatomic features on CT. So I think it's important to be careful when there are patients with excessive calcium and patients with calcified raphe, and combination particularly of these features. Some degree of undersizing is appropriate, but we still believe in annular sizing and not in supraannular sizing. Positioning the valve may be a little bit harder than the tricuspid valve. We tend to do these cases with TEE due to higher rates. There are higher rates of AI and aortic root injury, and I think TEE can be helpful in detecting these and taking care of these. Pre-dilatation is a good idea. And I think it is it is important to keep that in mind, and post-dilatation may be required as well. So in summary, the favorable outcomes, there are favorable outcomes with TAVR in carefully selected patients with the SAPIEN and Evolute in real-life TVT and sponsored prospective registries. CT phenotyping is important in patient selection and procedure planning, while bicuspid TAVR is justifiable in intermediate and higher surgical risk patients. Higher risk anatomical features such as extreme calcium, heavily calcified raphe, concomitant aortopathy should prompt consideration for surgical AVR in low-risk patients. Randomized trials and prospective registries, especially in patients with lower surgical risk, are needed. Thank you.
Thank you, Raj. Always so wonderful to have you and your talk on bicuspid valves. So right on with the case that we had, and I'm seeing Dr. Vinod Tarani, who's the Bernie Marcus Chief of Cardiovascular Surgery at Piedmont Hospital, Piedmont Healthcare, and the Marcus Heart and Vascular Center at Piedmont Heart Institute in Atlanta. It's so nice that you're with us here today, Vinod, and Dr. Larakis is also online. He's jealous that he's not there with you in Atlanta, but we're happy that we have him here in New York. We're going to move on. We're moving very swiftly through these great talks. We'd love to have you back, Vinod, if you can come during the Q&A. It's been a very live interaction. We have over 500 people online sending us questions and answers, which is lovely. And we're going to move to our next speaker, who's a fantastic dear friend of mine, Dr. Howie Herman, the John W. Breyfogle Professor of Cardiovascular Medicine, Professor of Medicine and Surgery at the Perelman School of Medicine at the University of Pennsylvania, serves as the Healthcare System Director for Interventional Cardiology, Director of the Cath Lab, a brilliant mind. I love working with him. He's a fantastic friend. He's going to talk to us about TAVR and small annulus. Howie, take it away. David Wood, I'd love to see you online. It's lovely to have you. We can't wait to hear about your TAVR Complete trial, which is getting everybody so enthused. But, you know, Howie's going to go first because he wants to talk about the SMART trial as well. So there's a lot of excitement now that we're going to get COVID-free very, very soon and get to see everybody. Okay, let's go live now. Back to Howie Herman. Thank you.
Good morning. My name is Howard Herman from the University of Pennsylvania in Philadelphia, and my talk is on the SMART trial, the use of TAVI in small annulus patients. These are my disclosures. And this is an outline of what I'll share with you over the next 10 minutes. I'm going to discuss the adverse effects of TAVR with suboptimal hemodynamics, some of the lessons we've learned from small surgical valves as well as from TAVR, the incidence of small annulus in patients undergoing TAVR, some of the comparative hemodynamics of current TAVR prostheses, and then finish up with the rationale and design of a new trial that has just been announced and will be beginning very shortly. So this is a meta-analysis of 34 observational studies comprising 27,000 patients and 133,000 patient years of surgical prostheses in patients who had mismatch of the prosthesis to the patient. And what you can see that in patients, particularly with severe prosthesis patient mismatch, defined as less than 0.65 centimeters squared per meter squared, that there is an increase of almost twofold in all-cause mortality and more than sixfold increase in cardiac mortality in this meta-analysis of surgical patients. Some additional lessons that we've learned from surgery include the fact that less prosthesis patient mismatch is associated with better coronary flow reserve, more left ventricular mass regression, better exercise tolerance, and improved quality of life. And if that wasn't enough, we also have some evidence that prosthesis patient mismatch predicts structural valve degeneration in bioprosthetic heart valves. This study from Fleming and Associates, who followed 564 SAVR patients for more than 6 years, demonstrated that prosthesis patient mismatch was an independent predictor of structural valve degeneration with a hazard ratio of greater than 2. The incidence of prosthesis patient mismatch is shown in this editorial from Philippe Pibereau from a number of studies of both TAVR and surgery, and demonstrated that severe PPM, shown in the red bars, is fairly frequent, occurring in anywhere from 10 to 20% of patients after surgery and of TAVR. And most importantly, in the lower bars at the bottom, you see that severe prosthesis patient mismatch in TAVR trials was associated with an increased hazard ratio for mortality, anywhere from 1.2 to 1.9. This is a study that we did looking at the incidence and effects of prosthesis patient mismatch in the STS-ACC transcatheter valve therapy registry. We examined more than 62,000 patients who received commercial TAVRs between 2014 and 2017, and the incidence of severe PPM was 12.1%. Patients who had severe PPM had an excess adjusted mortality of 17% versus 15.8%, a hazard ratio of 1.19 that was statistically significant. And although the difference here appears to be relatively small, keep in mind that this is only at 1 year, and these curves do appear to be diverging. And I would expect that over time, this will have an even greater effect on subsequent mortality. We also know that many patients who undergo TAVR in the US have readmissions for heart failure. This is the overall readmission rate, which averages still at 30 days around 13%, even in contemporary series. And we showed in our study that patients who had severe patient prosthesis mismatch had a higher rate of heart failure rehospitalization in that first year. When we looked at the multivariate model of predictors of severe PPM, one of the most significant was small valve sizes. Valve sizes less than or equal to 23 millimeters was associated with a hazard ratio, an odds ratio for PPM of 2.77. Are small annulus patients and the use of small prostheses common? They are indeed. Here is some summary data from several studies looking at the surgical world. SAVR prostheses of 21 millimeters or less have been utilized in 20 to 40% of patients undergoing surgical AVR. If we look at the use of small TAVR prostheses in our recent randomized trials, we can look at the 2 intermediate risk trials, one with balloon expandable valves and one with self-expanding valves, and our 2 very recent low-risk trials demonstrating the superiority of TAVR to surgery, both again in balloon expandable and self-expanding valves. And you can see that small annulus devices, small valves, 20 and 23 millimeter balloon expandable valves were used in about a third of patients in these 2 recent trials, and 23 or 26 self-expanding valves were utilized in about 20% of patients in these 2 trials. The incidence is even higher when patients are smaller, as they can be in Southern Europe and Asia. When we do TAVR in SAVR, it's very common to use small prostheses, 70 to 80%, and women, who make up about 90% of the small annulus population. If we look at which valve is better in this setting, we have data from randomized TAVR trials shown here for Choice, Reprise, Portico, and the 2 recent SCOPE trials that were presented. And what I've shown here are the effective orifice areas for self-expanding valves in red and pink, for balloon expandable valves in blue, and for the mechanically expandable Lotus valve in green. And you can see that the effective orifice area is larger for the self-expanding valves, and the mean gradient to the right is lower, again with the red and pink bars, compared to balloon expandable and mechanically expandable valves in these randomized trials of all comers. So these are not just small annulus patients. If we drill down a little more on the small annulus patient, what you can see here is that when choosing a TAVR prosthesis, this is from 3 core labs that pooled their data with best quality analyses of echo gradients and LV outflow tract areas at 30 days and compared the smallest 2 quintiles of size for balloon expandable valves and self-expanding valves. The effective orifice area was smaller with the balloon expandable valves than the self-expanding valves. The mean gradients were higher with the balloon expandable valves, and the DVIs, the dimensionless index, was also lower with balloon expandable valves than with the self-expanding valves that have better hemodynamics. In the 2 low-risk trials that were just completed, severe prosthesis patient mismatch using the VARC-2 criteria occurred in 8.3% of patients in partner 3 and 1.1% in low-risk evolute. These are not compared to each other, just the incidences in these 2 trials. And if you use an even more restrictive definition for severe PPM, the VARC-3 definition, it's still 4.6% in partner 3. As we think about expanding to these low-risk patients, and these are going to be younger and more active patients, we have to also recognize that exercise increases the cardiac output and the mean transaortic gradient, and the exercise gradients do go up more rapidly and almost exponentially as the effective orifice area decreases. So these differences may be even more important in these younger, more active, and low-risk patients. So some initial conclusions are that expansion of TAVR to younger and low-risk patients emphasizes the need for optimal hemodynamic results both in the short and long term. Awareness of these risks is important, thinking about severe PPM, low dimensionless indexes, and high gradients. And these risks, based on the surgical world, as well as some of the TAVR data that we have, indicates that patients who have adverse hemodynamics have higher mortality, reduced exercise tolerance, less left ventricular mass regression, impaired exercise tolerance, as I mentioned, and worse durability. And these effects will be worse in the younger and more active patients and emphasized in those who have a small annulus, particularly women. So utilizing the largest prosthesis based on the annulus area and perimeter and manufacturer recommendations with the most optimal hemodynamics is going to be key to getting the best outcomes. And this is the rationale for the soon to be initiated SMART trial. The SMART trial, the acronym stands for Small Annuli Randomized to Evolute or SAPIEN, will be a head-to-head trial of the 2 commercially approved valves in the US, Evolute and SAPIEN 3, in patients who have a small native aortic valve annulus defined as less than or equal to 430 square millimeters on CT scanning. They will be randomized 1-to-1 stratified by sex to the Medtronic Evolute Pro or Pro Plus versus the Edwards SAPIEN 3 or SAPIEN 3 Ultra. This is a prospective, multi-center, international, randomized controlled study that will be conducted in approximately 700 randomized subjects at 90 sites in Canada, Europe, and the United States. Patients will be followed at 30 days and annually thereafter for 5 years. I have the privilege of being the chair and principal investigator for this study with my co-principal investigators, Roxana Meyron from Mount Sinai in New York and Didier Cheche from Toulouse in France. Some key aspects of this trial is that they will be all patients with a small annulus, but all risk groups, low, intermediate, and high surgical risk. It is an all-comers trial that will include bicuspid valves, but patient's anatomy must be suitable for transfemoral TAVR with both devices. And of course, it will include an echocardiographic core lab, a clinical events committee, data safety monitoring, and subject confirmation with a case planning committee. The co-primary endpoints are shown here. The first primary endpoint is mortality, disabling stroke, or rehospitalization due to valve-related or worsening heart failure at 12 months, a clinical outcome, and the study is powered for non-inferiority between the 2 devices. The second primary endpoint is bioprosthetic valve dysfunction, BVD, defined at 12 months, a measure of valve durability, and is based primarily on the VARC-3 criteria. It includes a criterion of hemodynamic structural valve dysfunction, meaning a mean gradient of 20 or more millimeters, non-structural valve dysfunction, which includes severe prosthesis patient mismatch, and moderate or more paravalvular leak and aortic regurgitation, valve thrombosis, valve endocarditis, or aortic valve reoperation or reintervention. There are other powered secondary endpoints as shown here. So we're very excited about this new trial that will help us to identify the best candidate valve and the best prosthesis for patients with a small annulus undergoing TAVR in a large head-to-head randomized trial. Thank you for your attention.
You are muted, I think.
Thank you so much, Dr. Howie Herman. Fantastic. And now our next speaker is no other than the incredible Dr. Samir Kapadia, who is now the new head of the cardiovascular department over at the Cleveland Clinic. An impressive showing of what he's done. And we're just so glad that he's able to today talk to us as the expert that he is on neuroprotection and TAVR. Is it effective? We're a little bit behind. I understand that our panelists are here for the Q&A, and I apologize because of the live case and some of the live work that we did. And Dr. O'Gara, it's just wonderful to have you live here. Thank you for being here. It's so nice that the wonderful talk that you gave was just so right on and so apropos for our audience, especially during this time of COVID. Your incredible take on how we will continue to open up, and now with the vaccinations. And I know everyone is busy back and forth also listening to the vaccine panel. So thank you so much for being here, Dr. O'Gara. I don't know how much you got to see, but we talked about the bicuspid aortic valve today. We did a live case, which was fantastic. It's just so nice to have you. And I see that George Dangus is also live here. He's professor of medicine and vascular surgery here at Mount Sinai. It's wonderful to have you here as well, George. Just a quick, I wanted to just make sure that you knew that it's going to be about another half an hour before we get to the live Q&A. So if you can come back, that would be great. If not, if you have any comments, if we miss you, we want to have you here. I don't know what comments you might have, Dr. O'Gara. If we have you live, we want to have you open up and tell us your thoughts a little bit before we go to the next lecture.
Well, thanks very much, Roxanne. I really appreciate being involved in this spectacular course, and I know you're running behind schedule. It's just a wonderful faculty and case-based demonstrations that are quite educational. I think that Mount Sinai has really shown the way in how to do clinical research and how to take care of patients across the socioeconomic spectrum during the COVID-19 pandemic. And we've learned a lot during the first phase of the pandemic that we absolutely have to apply during this next phase. We're certainly all very excited about the vaccine, but it will be weeks to months before we see a downturn in the clinical activity that is now dominating our institutions, especially in urban areas as well as across the country. So I'm hopeful that we can apply those lessons learned and not fall too far behind with regard to our research and clinical enterprises, and particularly in making sure that we encourage patients with cardiovascular conditions to not hesitate to seek medical attention for any decompensation in their status. Thanks very much.
Thank you so much, Dr. O'Gara. It always is a pleasure to have you and to listen to you, and your first and important slide on structural racism and how we all have to understand best how to make sure that we are equal in all access to care, especially in TAVR and structural heart programs that are so disruptive and so important. And so it's great that you are the head of the task force. You are there for practice guidelines, and you will help us get there and erase this. So thank you so much for being with us. And we'd love to have you back, but we understand because we're off, you may not be able to. I know you're very busy. You're the doctor's doctor. If I want you as my doctor and I have a problem, I'm calling you. Thank you so much, Dr. O'Gara, for being here with us. We're going to move now to Samir Kapadia. He is the chairman of the Robert and Susan Tomsich Department of Cardiovascular Medicine, Seidel and Arnold Miller Family Heart and Vascular Institute at Cleveland Clinic. I'm so impressed by that. He is such a close friend, such an amazing contributor on the clinical trials and certainly in structural heart disease. He's led the way. And we are so thrilled to have him talk about neuroprotection with so much mixed data and so much heterogeneity on how we're using neuroprotection across the TVT registry. We really need some answers, and Samir Kapadia is here to give it to us. Dr. Kapadia, take it away. Thank you.
Hello, everybody. I'm Dr. Samir Kapadia. I'm at Cleveland Clinic. I'm chairman of cardiovascular medicine. I'm going to talk to you about neuroprotection in TAVR. Is it an effective strategy or not? I have no financial disclosure, but I am a national co-PI for the Sentinel trial. I was, and I'm a PI for the protected TAVR study. So this is a patient where, as you can see, we are putting the Sentinel device. As the arrow points out, there is a small device coming from the right radial artery, going through a innominate artery there, first in the subclavian, then the innominate. It passes through the innominate artery, and you can see here that it is going down. This is in the ascending aorta. The arch is somewhere there. So the proximal filter is deployed initially right there. So you will see the proximal filter coming out. And this is in real time. So this is a TAVR patient. And you can see that now the filter is being exposed right there. This is in the innominate artery. And then if you go, and this catheter will be pulled back and will be flexed in such a way that you will see that we will put the distal filter again live. So this is not a trimmed video. And we are flexing this catheter up, and the carotid artery is somewhere there. So there is a small wire. Typically, I use the whisper wire for most of the cases. And if you need more support, then a BHW wire. So it's an 014 wire, and it will go right there as the pointer points out. And as you can see, the wire is going up now. And now the next thing you will see is the distal filter going up. So what you see here is that once the filter is deployed, you will see a proximal filter and a distal filter. The proximal filter is in the carotid artery, and the distal filter is in the left carotid artery, innominate and the left carotid. Now, what is the purpose of this? What is the risk of stroke currently? So if you look at the first generation device, so these are the first generation devices, the risk of stroke was about 5%. Even second generation, most of the time was 5%. Remember, it is not the device, but it is the type of patients. So now the patients are lower and lower risk patients as you move this way. So when you have lower risk patients, the stroke risk is falling down, but still it is 2.5% of stroke. If you look at the TVT registry, again from 2012 to 2017, you see that the stroke rate has been very stable at 2.5% in the TVT registry, thousands of patients. And most of the strokes happen, 68.4% of all the 30-day strokes are within first 3 days of TAVR. So the NeuroArc definition of procedural stroke is stroke happening in 72 hours. So that is 70% of the stroke happening in NeuroArc. And if you develop a stroke, the chance that you will die, patient will die, is 12.7% versus if at in-hospital mortality, and 16.7% 30-day mortality. Huge. So very high procedural or in-hospital mortality. And even if you develop stroke, you are not going home. So 80% of the people who develop stroke end up in a nursing home. So this is our extended care facility. Very few people, actually, I'm sorry, 36% go home, but 66% of the patients are going to a nursing home. Well, if this is the case, is SAVR any better? No, SAVR is not better. So if you look at the major stroke with SAVR, it's 3.9% versus 2.2%. So 2.5% stroke with TAVR is less than that of SAVR. However, it is not 0.1% or less that we see with PCI. So our goal for the stroke, for the TAVR, should not be as much as SAVR, but should be as much as PCI. So I think we have a possibility to improve our stroke outcomes. So what are the data for the EPD? So that randomized trial, single center trial, and there is TVT registry data. So if you look at the most important randomized trial that was done, and I say most important, but we did it, so that's why sometimes it feels more important. But this is the randomized trial of 363 patients. It's a relatively small trial, and it has a control arm where nothing was done, and then there is an arm where the device was used, either with the meaning the MRI outcomes, or without MRI outcomes. So if you look at these patients, first of all, the filters, 99% of the filters had some debris, 99%, and 98% with some significant thrombus, tissue foreign material inside of the filter. However, if you look at the primary endpoint, although compared to control, which has the how many new lesion volume was there on the MRI, that was the primary endpoint, was 177 versus 102, but there was a big spread, and therefore the p-values were not significant. So the trial missed the primary endpoint. We published this in JACC 2017. However, if you look at all different ways, so the intention to treat trial, intention with imputation, because some of the patients could not have the repeat MRI, still, although there was a reduction of about 40%, it was not statistically significant because there was a wide variation. There are 3 separate trials, all randomized, very similar design with the same device, Sentinel device, Clean TAVI, Mistral, and Sentinel. And if you combine all these 3 trials and then look at the primary outcome, change in the mean new lesion formation, we did a patient level analysis. There was clearly a benefit of putting the device. So this was clearly there in that patient population, and this is displayed in another way, and the p-values now are significant, and there was a significant decrease, as you can see there. However, if you look at not in the protected territories, but all territories, still there was no statistical significant difference. That was not the primary endpoint. So the most important part, what we learned, which was not an endpoint, was to just look at stroke. Why do we look at these new lesions and in the protected territories and things like that? Just look at stroke. If you look at stroke, what we found was the control was 9.1%. Of course, all of them had MRI, neurologists seeing them. So the stroke risk, the ascertainment was very high. So the stroke risk was 9.1 in control, 5.6 in the test arm. And if you look at the percent reduction, it was 66% reduction. And if you look at the first 3 days of stroke, 8.2 versus 3, again, a major difference in the stroke, actual procedural stroke that was seen with Sentinel. With that in mind, the FDA approved the device, and so the device is available. Since the device has been available, there are several single center studies looking at stroke in 72 hours, and they all find very similar numbers. So Sentinel, as I showed you before, there is an Ulm study, there is an Erasmus study, and there's Cedars-Sinai, and very similar results are also there in the Cleveland Clinic. So all of them show a very substantial decrease in the stroke in the propensity matched patients. Dr. Cohen published this or presented this data from the TVT registry, where he took 1,200 patients and divided them with the patients who are EPD versus no EPD. So it is very important to recognize that the EPD was used in very few number of patients compared to the patients who did not have EPD. And the EPD increase has been happening. So if you look at 2018 to 2019, we went from 7% EPD use to 28% of the hospitals. So these are the proportion of the hospitals using EPD. And proportion of the patients is 5 to 13%. So still a small number of patients are having the EPD at the time of TAVR. So the instrumental analysis was one way to analyze this data. The instrument is the EPD, meaning that it is like as if we are doing a randomized trial. If we are using EPD versus not using EPD, what would be the outcomes? And the numbers are statistically not significant. 1.39 versus 1.54. So, and the p-value was 0.41. So although there was a numerical decrease, this was not statistically significant. If you did a propensity weighted analysis, so a different way of analyzing the information, then the numbers were statistically significant. But again, the differences are small, 1.6 versus 1.3. So after first 2 years of approval, the EPD use is minimal. So there is a marked variation between the centers, generally safe, at least it doesn't look like that there is increased risk of vascular complication, major bleeding, device failure, none of that. But if you look at the primary analysis, a 30-day significant reduction in stroke happened or not, did not happen. And if you extrapolate this data, you would say that you need about 300 patients to prevent one major stroke in this particular device by this data. The reflex study is another device. This is not a sentinel device. This is a device, the TriGuard device. As you see here, the TriGuard, there are two different versions of TriGuard. And the TriGuard device is a deflector device. So it stays in the ascending aorta and deflects the emboli. And again, small study, control is 63 plus 58 and the TriGuard in 121 patients. And if you look at this safety versus efficacy data, so efficacy cohort was this predefined, safety, as I pointed out before, Dr. Moses presented this data. And what you see here is that the clinical outcomes, actually in the TriGuard, composite outcomes was worse compared to in the control group. And that was also true, although statistically not significant, but numerically it was on the wrong side. And here again, you can see the disabling, non-disabling strokes. So the TriGuard is beige color, blue color. And you see that, although the disabling strokes were less, not statistics, all strokes 6.4 versus 5.3, 8.3 versus 5.3. So, excuse me, a little bit disappointing. And the all-cause mortality was also slightly on a higher side rather than lower, again, statistically not significant. New lesion volume was also statistically not significant, but definitely not in favor of the device. So what is the next step? The next step is to do a proper randomized trial with clinical endpoints. And this is the trial that we are doing. I'm the PI for this trial. This is the Protected TAVR trial. We are doing one-to-one randomization. And there are 100 centers in US, 3,000 planned patients. And when we are 70% enrollment, that is 2,100, we will do an interim analysis. And then, if necessary, we'll increase the size of the sample to almost 6,000 patients. So this study is already ongoing. We are already randomizing in this trial. As I said, one-to-one randomization, simple trial. Primary endpoint is stroke at 72 hours or at discharge. Subjects are followed. If you develop stroke, then you will be followed for 30 days or 90 days, but otherwise you won't be followed long-term. And neurological assessment will be done for all the patients, including neurological exam, modified Rankin score, NIH stroke scale, CAM-ICU score, and MOCA. So what can we conclude? The stroke after TAVR remains to be a clinically relevant problem. I explained to this, that it is there in all patients, clearly not very predictable. I didn't go in the data, but it is not a predictable event. And more data are needed to prove the efficacy of EPD in stroke prevention. Safety of Sentinel is fairly proven, but efficacy, you can argue that we do not have a randomized trial, and that's why we are doing the Protected TAVR trial. We have enrolled almost 300 plus patients at 30 plus active sites now. So again, thank you for your attention and happy to take any questions. Hi, Roxana. This is Samir.
This is wonderful, Samir. Oh my God, what a wonderful talk you gave. Thank you so much. I can see that you're getting into a case right now. And Howie, a wonderful, wonderful talk on small annulus. Two important comments from each of you before you go off, because we're very behind. People did not follow the rules. Howie did. I think you were under 10 minutes with your talk, but many went over. So now we're far behind. but I do, because we do want to have the live Q&A session. I know that George is going to go up next on the pharmacology, but before we lose you guys to your cases, and I ask you, we're going to send you the exact time that the live Q&A is going to be back on. So if you can come back on, it would be great to have you. But in the meantime, since I have both of you, does neuroprotection work, Samir?
So I
in
think
an unbiased way, after David Cohen presented all of this, everyone is like, what are we doing?
In my personal opinion, I think we need data, but at least if you look at all the, and I'm looking at it now at our Cleveland Clinic data to try to figure out that if the strokes are less, not just less, but how severe are the strokes. So remember that this part of the information is impossible to get from the TVT, that, if the strokes are there, how people report it, what really happens. At least my personal experience would suggest that our strokes, I don't see major strokes with the Sentinel. So I'm hoping that that is true or not, but then that's why we are doing the Protected TAVR trial, to see if we see the difference or not. So both ways, I think we should learn about it pretty soon. And we can discuss
I think the answer is exactly that. We need a prospective randomized study that even with the best possible matching, we can't know the true answer. Howie, would you agree to that?
Yeah, I agree with both of you as always, and thanks again for inviting me to this great course.
Oh, we love having you. Thank you for your wonderful talk, and I can't wait to start the SMART trial with the smartest guy I know, you.
Thanks. I think from the stroke standpoint, I think one of the issues is that there are signals that it works. We clearly need a better evidence base, but the safety is so important that it's a relatively safe device to utilize. And given how safe it is and some signals that it may work, I'm in favor of using it, waiting for the evidence base.
Yeah, great for us to pool our data in hope of finding this. Samir, we're doing the same at Mount Sinai with Dr. Sharma. We're looking to pool our data. So it would be great. I would love to spearhead that and work with each of you to pool individual patient data and come forth with a larger numbers of patients to see what are we really finding. Be great. Raj, you have any comments on distal in embolic protection? Open up, and then we'll go quickly to small annulus quickly, and then we'll
sure.
go back to your cases.
I was an enthusiast, and we were one of the earliest adopters. It was the standard of care, and we did almost 1,600 TAVIs with the Sentinel device. Following the David Cohen presentation, I believe that now that except for situations like bicuspid aortic stenosis where the stroke rates may be actually higher, I think it is time to randomize patients. So, so starting that, since the Cohen presentation, it is no longer the standard of care in our lab to use Sentinel device with every single TAVR like it was. And we've actually now shifted to randomizing these patients in the clinical trial, of which Samir is the PI.
On the clinical trial that Samir is
That's correct.
is leading, and I know that Dr. Kapadia had to run to a case. We're going to send you all the exact time for the Q&A. If you can come back, we would love to have you. If not, we understand. Vinod, your thoughts on this, and then I just want to keep you. Raj, for a minute, because I want to talk about the small annulus. Vinod, your thoughts on distal protection?
Yeah, we haven't been using it. We haven't been using it on every patient, and we're using it in select patients, like you said, for valve and bicuspid, Raj. So I think that's really what we've done across the board. In fact, we just randomized a patient last week for the Protect TAVR study. So we're doing the same study with Samir.
Yeah.
Wonderful. This is great. So now let's go to, I think, our next speaker, if that's okay. Well, no, I want to talk a little bit just before I lose you. I'm afraid you're not coming back. The SMART trial. Raj, what do you think? Do you think that there is a better valve, or it's time to also randomize the small annulus to these balloon expandable versus self-expanding valves?
I think it's an important study. And I'm glad you are one of the, Roxana, one of the leaders.
We're expecting you to give us a lot of patience. So make sure that whatever you say, I'm holding you to it. Right, Howie?
You bet.
So I think it's an important study. I think it'll give us the opportunity to understand whether better hemodynamic outcomes with the supraannular valve translate into better clinical outcomes as well in the long term. I think it's important to find that out. So in that way, I think it's an important concept study.
Thank you. Vinod?
Yeah, same thing, you know, especially in the women, we see this more frequently.
Yep.
And I think that's something that we need to pay a little attention to. So I'm looking forward to it, also to trial and hopefully participating and seeing what we come up with. I think a randomized trial is needed for this patient population.
Yes, I wanted to call it the Empress trial, but I lost. And so now it's really the SMART trial, which is a smart way of moving forwards. Thank you, guys. We're going to move to the next talk. I'm going to send you the exact time that the live Q&A is going to go on, and I'd love to have you all back. I'm really sorry about the late thing. There are so many people online, 500 plus, who are sending questions, and we want to be able to have a nice live discussion around this. Thank you again for joining us. Our next speaker is Dr. George Dangas. He is the Director of Cardiovascular Innovations here at Mount Sinai Heart, Professor of Medicine, Cardiology, and Surgery, Vascular Surgery, and it's wonderful to have him to talk about an update on pharmacology. We discussed it lightly, but it's post-TAVR. What should we do? Where are we going? Dr. Dangas.
Hello, I'm George Dangas from Mount Sinai, and I had a great pleasure to join you today regarding a very interesting and controversial subject, the TAVR antithrombotics in 2020, and we can go right in the presentation. These are my relevant disclosures, and in general, the subject of antithrombotics after TAVR is intertwined with the risk of stroke around TAVR or in general in the TAVR population. These patients are elderly, they have many atherosclerotic risk factors and an ongoing risk of CVAs or other ischemic thrombotic events due to this region. And on top of that, they have a lot of atrial fibrillation, either long-standing, subclinical, or clear new onset perioperatively. This, as we know, the atrial fibrillation is very frequent after surgical aortic valve replacement, maybe about a third or a quarter of the patients. And it's around 10 or 15% after TAVR, or maybe I would say 5 to 15%, average 10-11% after TAVR, but clearly a bump that related with increasing events. The new aspect of the aortic valve is essentially an imaging-based and created a new entity, the reduced leaflet motion, but we can see by the CTA and not at all well by echo, gave interest and a lot of anxiety early on because obviously having microclots sitting on the leaflets of the aortic valve doesn't seem very reassuring to anyone. Particularly the difficult part of this interesting finding was that it's not really related with a bump or a jump in the echo gradients across the valve. Hence, it was really emerged as an imaging finding up front. A lot of theories around the valve thrombosis have been created over the years. We have summarized those in a category of intertwined 3 types of factors: the surface factors, with an incomplete prosthesis endothelialization being the leading one, hemostatic factors that are related to patient blood, hemodynamic factors related to the overall CHF, other hemodynamics, as well as the change of those hemodynamics with a TAVR. If all those are intertwined in not such a good way, we may have unfortunate events appearing. And those have been documented also in surgical aortic valves, just to be very, very clear. And there is an aspects of degeneration as well as thrombosis around these valves. And this imaging has also been a little bit confusing between the two. And there's a theory that a lot of thrombosis start as such, and then they progress to a bioprosthetic degeneration and dysfunction over the years. Let's go a little bit to new data that we reviewed within the past 12 months or so, particularly the fact that this phenomenon of the valve thrombosis on the leaflets of the TAVR and SAVR is actually fluctuating regardless of any therapy we give. This is one of the 2 studies in the interest of time. This is with a SAPIEN valve. There was a similar results with a core valve type self-expanding prosthesis in 2020 that indicate that patients imaged blindly to the medical therapy at 30 days and at 1 year. Those who had some by 1 month did not by 1 year, and vice versa. Patients who did not have clots by one valve did develop by 1 year, and in general by 1 year there was about even about a 20% perhaps in between both types of valves, surgical or aortic, with some minor differences in general. But the most interesting finding was indeed the fluctuation of this phenomenon, regardless of the therapy that we give. And indeed, there are isolated reports that all sorts of therapies, particularly anticoagulation therapies, may have resolved some of these clots that were appearing. And as you can imagine here, in very diverse examples in one or more of those leaflets. And you can see how beautiful this phenomenon is imaged by CT. Hence, the very increased anxiety this created when it first appeared. Let's go and see what data we have in patients without, and then later on patients with underlying oral anticoagulation need. First of all, in patients without, we have indicated in the trial, the Bravo trial early on, that the clopidogrel loading may be more of a burden than a benefit. This was in a non-randomized trial, and you can see it was associated with increased vascular complications. Didn't really offer much. Did this pan out in the clinical studies? Well, apparently yes. The Arte trial indicated in a randomized fashion, just about 200 patients. There were a couple of more initial randomized trials from Italy of about maybe 50 or 100 patients per group or altogether. Very small one. And then everybody preloaded here with the clopidogrel before the TAVR. And in comparison between aspirin monotherapy of dual antiplatelet therapy, and you can see with a follow-up of all the way up to 6 months, all the activity was within the first few days and the first month, and no real difference between bleeding and between the ischemic events, but clearly a lot more bleeding with clopidogrel. This panned out again in 2020 in the POP TAVI cohort A group that is included a 3-month follow-up with clopidogrel versus aspirin monotherapy, and then at 1 year assessment of all the events. So every patient received aspirin monotherapy between 90 and 360 days, and anyone can see that the activity was all within the first few days, again, mostly driven by the initial loading dose, in my view. Interestingly, you can see the data of aspirin and clopidogrel all the way to a year, and again, you can see a lot of activity in the initial days, but then on you can see further down the line, particularly beyond 6 months, an updrift of events in the aspirin monotherapy. And there's the first time a study like that introduced this factor, and one may say that A, this is a 100% chance, or B, if you are indeed not inhibiting aggressively the first few months after the procedure, maybe events will emerge later on. This is a hypothesis, but again, this is a small study with about 300 patients per group as well. And this is the first time we see follow-up after initial 90-day treatment ending. And the first time, again, we see that there's a significant updrift of events in the aspirin monotherapy group between 3 and 12 months of therapy. In the Galileo trial, we tried to approach this phenomenon with a different pathway, utilizing a combination of a low dose or a medium dose anticoagulation with rivaroxaban 10 milligrams. As you all know, the AFib full dose is 20 milligrams daily. And we compare that to the more classic pathway of dual antiplatelet therapy for 3 months, followed up with monotherapy. Unfortunately, the results were not favorable for the rivaroxaban group in the long-term follow-up, and particularly you can see in this graph the antiplatelet group was significantly better and included the all-cause mortality that you can also see here, particularly in the long term, inclusive some mortality quite longer after drugs were discontinued. Bleeding was no surprise in this study. There was a trend, there was a major bleeding, a significant other types of bleedings higher with the low intermediate dose rivaroxaban. Interestingly enough, we also had, and this is the first time, a leaflet motion sub-study as assessed systematically by CTA has been subjected to a randomized treatment to see if it can be prevented by an alteration in therapy. And we saw in this, in our CTA sub-study, also published earlier this year in the New England Journal of Medicine, that although the dose of rivaroxaban was medium, as I said, and a lot of people were doubting its effectiveness, it was actually highly effective in preventing this CT finding. So the good results with the prevention of the CT-based diagnosis of clots on the aortic valve leaflets, nonetheless clinical failure because of a higher clinical event rates, particularly the long-term mortality. We all await the results of the Atlantis in the next year regarding the utilization of apixaban twice daily with either Coumadin or dual antiplatelet therapy control groups, depending on the stratification about need or not of open antiplatelet therapy. Again, this study is about 1,000 patients or 1,500 patients in the same league of the previous ones, and no definitive trial plan as of yet in this phenomenon. And let's move into the anticoagulated patients. And first of all, let me start with again a non-randomized yet interesting clinical outcomes of non-vitamin K oral anticoagulants versus vitamin K anticoagulants in a study from Germany that indicated in the series of patients that they studied, the non-vitamin K anticoagulants fared somewhat favorably compared to this warfarin, this non-randomized trial. In going to the randomized arena, the only study we have right now is the one published earlier this year in the TAVI investigators that starting pre-procedure, let me be very clear about that, oral anticoagulation plus clopidogrel versus oral anticoagulation, not interrupted by protocol. So a lot of people, probably most people, underwent TAVR with on uninterrupted anticoagulation. One can see the bleeding was in the range of 15 to even 30%, and one can explain that by the fact that all these procedures were performed on uninterrupted oral anticoagulation plus or minus clopidogrel, as well as some ischemic events. And then on the right side, you can see it's the same flavor. The clopidogrel addition to oral anticoagulation went particularly on the face of both uninterrupted administered orally pre-procedure, raised both types of events, particularly again in the first hospital period and early on. It's very clear that in hospital, day one, the results in bleeding was 10 versus 20%. That's like a lot of bleeding in my mind. And clearly, this feature of administering the therapies pre-procedure is something different than most people practice, in my view. But again, this study was designed and conceived at a time that everybody was very sensitive about possible strokes perioperatively or intraoperatively, and no wonder these investigators had some good reasons to believe that if we perform TAVR on a complete anticoagulation, you may be preventing events. This has since not panned out in the wake of the great advantages in device and technologies and techniques that have reduced dramatically dropped the rates of day one or day zero strokes. We have ongoing and completing the follow-up in our study, the envisaged TAVI-AF in collaboration with Thorax Center in the Netherlands is 1,427 patients. The follow-up is completed the end of this year, and we hope to have the results, if not in European Society of Cardiology, definitely by the American Heart Association 2021. And that's going to be an interesting study randomizing patients into warfarin target 2 to 3 of INR versus a Doxaban 60 milligrams, and as required, an adjustment down to 30 milligrams, all of it once daily. In for patients, obviously, who have somewhat decreased renal function, these adjustments indicate in the study in general, had about half and half those who require the full dose versus those who require the reduced dose based on the renal function adjustment. So in the midst of all these trials coming up and all the studies coming up, and none of them being definitive, one can see that's no wonder the practice of what we give in our patients varies a lot, with a lot of subdivisions and individualization per hospital, per country, per hospital, and per doctor, or per patient, or per heart team, I should say. So in conclusion, we'd like to say that we have reviewed the incidence of leaflet thrombosis after TAVR that indeed seems to be high, and its clinical implications are not well understood. Initially afraid of early strokes or TIAs, this doesn't seem to pan out at all in studies. And the situation that we faced is whether to this phenomenon is contributing to a limited or shorter valve durability, and how that could be studied and remedied. Clopidogrel loading before TAVR is associated with more bleeding and vascular complications without obvious benefit in stroke prevention. This has been clearly indicated, suggested by our study a couple of years ago, but clearly shown by a series of small yet interesting trials around the world. What happens after the procedure with clopidogrel or not is not clear at all, because no study has particularly focused in the successful TAVI and what do you do afterwards. The current practice guidelines indicate a 3-month administration of clopidogrel after successful TAVR. This is very clear. In the experimentation with an intermediate or a lower dose than the one used in AFib with anticoagulation in patients not otherwise requiring this type of therapy didn't pan out as clinically beneficial in the Galileo trial. Nonetheless, Galileo CT substudy also indicated that in order to prevent these types of microclots in the valve, you don't need to worry about high dose anticoagulation. Even a medium dose can do the job pretty effectively. And going into oral anticoagulation, the monotherapy in general, based on non-randomized studies, seem to be favorable. In selected patients, the non-vitamin K anticoagulants have done well so far in the small studies. In the randomized arena, we can only quote as of now the POP-TAVI, and we wait for Atlantis and for Envisage TAVI AF in 2021, and albeit with a caveat that most TAVI procedures were performed on uninterrupted oral anticoagulation. The POP-TAVI can advise us that the monotherapy is interesting, and I don't think it's interesting and actually advisable. No clopidogrel use if the patient is needing anticoagulation and has no other reason, for like a stent for the clopidogrel. But at the same time, I don't think anyone is following the protocol of the POP-TAVI and performing TAVI or TAVR procedures on uninterrupted anticoagulation. Pretty much everyone interrupts a couple of days before the procedure and restarts them when it is safe from a vascular closure point of view, essentially upon a patient ready for discharge. So in brief, additional large-scale randomized evidence base is required to properly inform the guideline recommendations regarding particularly the type of antiplatelet therapy after a successful TAVR. And let's leave it at that for 2020, and we'll look forward for an update next year. Thank you for your attention.
Thank you, Dr. Dangus. That was really great, a great overview of where all the confusion around anticoagulation, antiplatelet regimens, and I don't know that we have a clear answer. I fully agree with you. Our panelists are here, so I want to quickly take advantage of them being here. We have Howie Herman, we have Dr. Bino Tarani, I see Dr. Saibal Kar and Dr. Kinney just quickly on the panel. Any thoughts on anticoagulation or antiplatelet regimens? Just quick, very, very short. We're heavily behind. We're probably going to do away from the Q&A, but we will answer all the questions that are coming through. We have over 500 people online sending us questions, so we want to make sure we're responsive. So let's start with Dr. Kinney. What are you doing for your antiplatelet regimens right now, Dr. Kinney?
So right now, as we discussed during the first case, we are still doing aspirin and Plavix for these patients. From 6 months, we have made it to 3 months. And if for whatever reason they're on anticoagulation, especially if they are AFib or any other indication for NOAC, then we will only keep them on aspirin.
Okay, sounds great. Howie, do you do the same now, or what do you do?
No, we stopped dual antiplatelet therapy about a year ago. We do single antiplatelet therapy unless they have a recent stent or some other indication for dual antiplatelet therapy. And if they have an indication for oral anticoagulation in general, we use either no antiplatelet therapy, or if they have, again, an indication, single antiplatelet therapy. We know the bleeding's higher.
Very interesting. Vinod?
Single aspirin, if they need Coumadin or if they need have atrial fibrillation or something else, and we add that on top of aspirin, but we always have the aspirin going, and we're not doing dual antiplatelet at this point.
All right. Well, so a lot of differences. Saibal, any thoughts on that?
Yeah, we also, I don't know what's the answer, but I just use single antiplatelet, aspirin.
Well, we're hoping that we could do a randomized trial. I wonder if you guys would randomize in a large scale, but it will be very, very interesting to evaluate this. Well, we're going to go now, and I'm really thrilled too. I'm switching a little bit because Dr. Kinney needs to go into the cath lab to get ready for our next case. But I'm just so lucky to work with Annapurna Kinney. I've learned so much from her, and Dr. Sharma is so lucky he has two of the best women on his side, and one in the cath lab on a daily basis performing large numbers of procedure. She's the director of the Cardiac Catheterization Laboratory, director of the Structural Heart Disease Program, and our fellowship program. And she's the Zena and Michael A. Weiner Professor of Medicine. It's a very, very, our Heart Institute is the Zena and Michael A. Weiner. And so she holds that professorship, which really speaks loudly to her commitment to the Institute. Dr. Kinney is going to talk to us. She's always on the innovative path, and now she has probably developed educational apps for the kinds of procedures, and her decision-making and working also from a clinical trial data into app technologies that she's developed with a very, very massive group of people who are really in the back end making the programming and taking her brain into an app, which is fantastic. She's going to talk about coronary access post-TAVR. The work that she's done was published in JACC as a main paper, but she's now taken that to the TAVR Cath Aid app. Dr. Kinney, take it away.
Good morning, everybody. I'm Dr. Annapurna Kinney, Director of Cardiac Catheterization Laboratory, as well as the Interventional Director for Structural Heart Program at Mount Sinai Hospital. Today, for the New York Symposium, I'll be discussing coronary access post-TAVR and what is the update that we have with the TAVR Cath Aid, the new web app, as well as the phone app that will be released today. So coronary artery disease before and after TAVR, if you see here, the incidence of coronary artery prevalence based on various trials can vary anywhere from 20% to 80% CAD. This is existent in patients with aortic stenosis. Also, management of CAD after TAVR has, there are a few reports to say the access could be difficult based on the valve that we have been using. So what did this study show? The risk adjusted at 30-day for all-cause mortality in patients with TAVI and PCI versus who got TAVI alone. What you see here is even if they had CAD, what patients who had TAVI alone actually did better compared to patients we had TAVI plus PCI. 1 year all-cause mortality also showed that patients who had concomitant CAD but only had TAVI did better compared to patients who had TAVI plus PCI. So the meta-analysis actually concluded saying that PCI with TAVI in patients with severe aortic stenosis and concomitant CAD grants no additional clinical advantage in terms of patient with clinical outcome. So further randomized trial needs to be done to see whether these patients' coronary artery disease has to be managed before or after. The ongoing trial, the study design of the complete TAVR is that patients who are with aortic stenosis who have more than one vessel disease of vessel more than 2.5 millimeter in diameter and 70% visual angiographic stenosis will undergo TAVR, but will have a randomization of revascularization. You see here post-TAVR versus those patients will be managed medically, guided medical therapy. All of them will be on good medical therapy based on what treatment they get, and there will be a 3-year follow-up looking essentially for death, MI, and ischemia-driven revascularization in these patients. Also, couple of trials which have shown that a reaccess after the SAPIEN valve, if you see here reaccess, a small study, was successful about 100% of the patients, but PCI success was about 97% of these patients. So what is the, after TAVR, what is the presentation of this patient? Majority of them stable CAD, and some of them do present with unstable symptoms. This is another study where all available TAVR valves were used. And if you see here, 7.7% unsuccessful cannulation after TAVR compared to before TAVR, if you see here. And what important thing is the left coronary cannulation after TAVR usually is very difficult. So this is before TAVR. After TAVR, multiple catheters are being used to cannulate the left coronary artery. Right coronary artery is usually okay. You are able to easily cannulate. And what did the multivariate predictor for unsuccessful coronary cannulation was that, TAVR valve with the sinus of Valsalva relationship, the depth of the implant, and of course the use of evolute valve. Odds ratio was close to 2.6% in this study. So we were the first one actually who put out this review article saying what are the important factors for include patients who are undergoing TAVR. This was the central figure showing there are anatomical factors as well as the device and procedural factors. Anatomical factors are the sinotubular junction dimension, the sinus height, then we have the leaflet, how bulky it is, and the length of the leaflet, sinus of Valsalva width, as well as the coronary height, which is very important for consideration. And device and procedural is where is the commissural tab placed, the sealing of the skirt, as well as the valve depth. Everything has to be taken into consideration so for reaccess. So in the same paper, we also said that, how do we make sure that we are able to cannulate the coronary artery? So all depends. If the commissural post is away, it is much easier. And what we also found that based on our experience that the catheter size usually smaller because now you have the metallic valve that is sitting in front of the left main and RCA. So a smaller size catheter, which is FL, if not, quickly go to the Akari guide. And then I'm going to show you some animation, how actually so many times you're not able to cannulate, but you can place the guide at the ostium and then, able to wire through one of the diamond, use balloon support, use guide extension catheter to access and subsequently do the procedure. If the commissural post is in the front, then it's harder, but the animation will tell you how to get it across. So for the balloon expandable valve, same, if the commissural post is away, you can use any standard catheters. If the commissural post in the front, you just have to be again cautious, but still will be able to get it with a smaller, but any of the regular catheters that you have been using to engage the left or the right coronary artery. So the TAVR cathode, what we did is we is the second version of the TAVR catheter that has come up now. We have made a web version, and this app is free for download. And let me go over what are the important features in the newer TAVR catheter. The important features are added case reviews. So 8 detailed case reviews show how coronary access was achieved in patients. So guide catheter escalation when it's required, guide extension catheter use, as well as proceeding for diagnostic catheter to intervention, how we did it. All these cases have been discussed in this new app as well as in the web app. Most important is offline functionality. No matter where you are, shielded cath lab, whether you're on an airplane, underwater tunnel, where there is no internet access, you will never get this try again. You'll be able to, go through this app as well as the case reviews, whatever you want to do offline. And a beautiful updated user interface, which is very easy to browse and understand exactly what you want to do and where you want to do. And important is a powerful search function. Application-wide search function has been introduced that will find that it will take you right where you want to, and will be able to get the cases or any kind of things that you're looking for. What is the catheter you need to use? This kind of powerful search function has been included. And more important is 8 detailed animation of exactly how you can engage this coronary arteries. And this is whether it is a diagnostic catheter or whether it is a PCI. You see here, you just click the button, it will take you whether you want to go to coronary artery or PCI. And then you see here, we will have that animation subtitle before how it works. So left coronary engagement, this is the bird's eye view, how exactly you have to manipulate the catheter clockwise, anti-clockwise, so you will be able to enter the diamond. So in this particular procedure, you see here in the commissural post is in front. So you have to move the guide anti-clockwise. So we'll be able to get into a diamond either below or above. And then you get your guide through the diamond slightly into the sinus. And then you will have your coronary wire to engage the coronary artery. This is the full animation that is showing how you can engage. So you see here, the catheter size is smaller. Since you have this wide cage that is now sitting in the aorta, so this curve will be smaller. And you see this post is right in front. So what you do, you see that you have to rotate the catheter anti-clock. So you're now below the diamond. And once you're entered the diamond, many times you're not able to advance and engage the coronary artery. That's okay. So when you are right in front, then you will wire. It'll go further down the wire. And then what you did was, with the balloon support, you dilated the lesion. And once you're dilating the lesion, your guide extension will come into the left main. And just be cautious not to cover the circumflex. Just stay in the left main. You did the PCI with the balloon, then you place a stent and you then come out. Now there are cases where use 7 French, guide, and even we have performed rotational atherectomy. So there is also a new web app that we have. This is the website. This is the new website that we have created, which shows everything very easy, which is the basics, where all the basics and discussion of each and everything, the toolbox, valve engagement, applied anatomy, everything, as well as the animation. Also, what we have created, this animation will be free for download. So you guys can download and use it for educational purposes wherever you want. So the web app is available on www.cardiologyapps.com, and then you go to TAVR catheter. So thank you for your attention, and we are ready for any questions you have regarding this TAVR reaccess.
Anu, that was thank you, Anu. That was wonderful. I hope you're on live because we do want to have a little bit of a discussion about this just quickly. And we have Saibal Kar live, Vino Tarani live, Dr. Kinney, Dr. Sharma, and I did see David Wood, who's live. Thank you, David, for being here. I'm so sorry we're really running late, and Howie Herman. Have any of you began using do you guys know of any kind of technology like this? What do you think? David, I really would love to hear your thoughts. As you saw, Anu put your trial up first. She was supposed to go after you, but we pushed it up because she's got to go into the live case. But the complete TAVR is going to be looking at this sort of access to coronary arteries are kind of important. And she's developed this app. What do you think about using technologies to help physicians guide and help them through and giving them these video recordings that helps them in some difficult cannulations, etc.? Welcome, David. So nice to have you.
Thanks, Roxana. And as you're on the steering committee and the executive committee for Complete TAVR. I think this app is absolutely crucial for operators and patients. If you're at a site that's not doing high volume TAVI and you have a supraannular valve come in or any valve platform, and for whatever reason, the stent post is in front of the left main, there's cell misalignment if it's valve and valve. Without this app, you're really trying to operate in the blind. So I think it's absolutely crucial. I think we're going to learn a ton from Complete TAVR, but I think in the interim, apps like this are going to help us safely treat our patients, whether that's guide extension, all these different things, a purpose-built device maybe in the future, but for now, we need the tips and tricks from all the operators on this panel.
Oh, that's great. Well, thank you, David. It's wonderful to hear your thoughts about that, and I wonder how Dr. Kinney could make that app available to all of the operators in Complete TAVR, which you have a large numbers already. Everybody wants to be part of your trial. It's amazing, and I think it's so exciting. It speaks so much to the fact that there's so many of these patients that have concomitant and coronary disease and understanding. So what do you think are some of the most important technical challenges of access to the coronary artery and with post in a post TAVR? And does the valve type make a difference? Of course, we know that it does, but can you just give our audience some questions?
I think there's all these different THV platforms, not just in the US, but around the world. And I think if you don't have an intimate knowledge of where the leaflets insert and where the skirt comes up to, if you're just trying to look at on fluoroscopy where the frame is, you can be led astray very easily. And we, like many people on this panel, have had cases where peripheral sites were unable to access the coronaries and then got transferred. And by understanding the anatomy, a case on Wednesday, we did a CT pre to understand where we thought we could slip in next to the post through an adjacent cell. Luckily, there wasn't cell misalignment, so we were actually able to get through, as we just saw beautifully on the app. I think those are the techniques we're all going to need to learn in this TAVR era.
Dr. Kinney?
Yes.
You hear
Roxana.
Dr. Wood wants your app for his investigators.
Yeah,
do you
that
have
would be good.
any comments?
No, I think this is the second, I would say, generation of the app, because after we did the first one, we had several requests from many people who have been using it. They wanted some cases, so that's what we did. We added some cases, showed some cases, so they could learn exactly, how to engage. But more important also is so the change of catheters, which catheter to what, so that algorithm has been provided, and offline functionality. So some of the cath lab don't have good access of internet everywhere. So then that is why offline functionality is very important, and search functions. You know how the interventionalists are there, short time they have, don't have, so they want to quickly search what they want in the app. They can quickly get that. And other one is also we have made is a website. The last time we did not have a website. We have a large website where if people just want to learn various things as well as various catheters and why this is happening. I showed you the animation. I think like David mentioned, I think if you see the animation, they will have a 3D idea exactly what we are talking about. What is the valve height, where the skirt is, why you need to, clock the catheter, counter clock, and how exactly get into the diamond, and the animation shows it. I think once they see the animation and understand how to engage the coronary artery, many times you leave it right in front of the diamond, you wire the coronary artery, and then you get your guide extension catheter. With the guide extension catheter, we do the procedure. So all that has been shown there. That will help the operators. Our goal is the knowledge we have, we share it with other people.
I love that. I love that. There's no need to have complications just due to not knowing what to do. And I think this kind of an app technology, and I know that now you're using augmented intelligence, using some of the technologies from the CT. And I know that Dr. Kinney is on to the next thing. And it would be great to have that kind of evaluation of incorporating the CT, the different anatomic levels, and then kind of simulating what it would look like with a balloon expandable versus a self-expanding valve. And why is it important to have those differentials and have people visualize those? I know you're doing this work. I think it's going to be an incredible addition, and we look forward to it. Final comments before I go to the infamous Dr. David Wood's talk, because we're talking about complete TAVR, so it's perfect. Saibal, Howie, any thoughts about this?
No, I think
you love it. You want one?
Yeah,
we'll get it to you.
We'd love to have it, and I think the point about guide catheter extensions is very key to doing these procedures successfully.
Great, Saibal.
I think this is fantastic. These are the things that were very, very useful. And I actually practiced on a model. Medtronic also has a model, wet model to do this, and which I worked on it actually, but they used but I really think this is very helpful.
Wonderful.
This is going to be just like how we do valve in valves. That app is so helpful. This is going to be just like that.
Well, thank you all. Thank you all very, very much. Thank you, Dr. Kinney. You really are stepping into the future with all this digital technology that you're leading. It's wonderful to work with you. So it's my pleasure to introduce our next speaker, a dear friend, but an incredible, incredible colleague, Dr. David Wood, professor of medicine and the head of cardiology at Vancouver General and University of British Columbia Hospitals. He's the director of both the Center for Cardiovascular Innovation and Cardiac Catheterization Laboratory at University of British Columbia. He is the co-founding member of the Center for Heart Valve Innovation and president of the Canadian Association of Interventional Cardiology. He's amazing, basically. And at the moment, I've had the unbelievable pleasure of working with him on the main complete trial, because he's not only a structural interventionalist, but a true coronary incredible interventionalist as well, always available, incredibly collegial. We're just so proud to have you, David, with us today. And of course, he's the chair and the principal investigator of the complete TAVR, and he's here with us to tell us about the rationale and design of complete TAVR. Dr. David Wood, welcome, and thank you so much for being here. Can't wait to see you in person. Dr. Wood.
Good morning. It's David Wood here from Vancouver, Canada, with my colleague Janar Sadhanathan. My good friend Roxana and the organizers have asked us to talk about TAVR and CAD, rationale and design of the complete TAVR trial. So our disclosures are noted. So complete TAVR, I'm co-PI with John Webb on this 4,000 patient, 103 center trial. All the information that we're going to present is available on clinicaltrials.gov with the identifier noted, or through the CCI-CIC website. So we have a fabulous steering committee with John Cairns as our steering committee chair and other luminaries as noted there, both in the world of transfemoral transcatheter valve replacement, as well as acute coronary syndrome and percutaneous revascularization trials. Our core labs include the CT core lab led by Jonathan Leipzig and Philip Blanke, and the coronary core lab circle led by John Mancini. So these are the sites that have so far signed on to participate in complete TAVR. I would argue these are some of the leading sites in North America, both the United States and Canada. So a study objective. So among patients who've undergone successful elective transfemoral TAVR with a balloon expandable platform, we specifically chose a short platform, so hopefully there'd be no issues with coronary access post-TAVI, who are receiving guideline-directed medical therapy, is a strategy of complete revascularization involving stage PCI using drug-eluting stents to all suitable lesions. And here, this for those who know the complete trial that I did with Shamir Mehta and STEMI, we're using the same criteria, a 70% visual angiographic stenosis in a vessel at least 2.5 millimeters in diameter. We're not using FFR, IFR, and we're not using either a syntax score to start with or a residual syntax score at the end. If you see a 70% visual angiographic stenosis, that would be a qualifying lesion. If you're randomized to stage PCI, that would be treated. And the question is that approach superior to a strategy of guideline-directed medical therapy in the composite of death, new MI, ischemia-driven revasc, or hospitalization? So I'm going to turn it to my colleague, Dr. Sadhanathan, who can take us through some of the background slides. Thanks, Janar.
No, thank you, David. So I think just as to some of the rationale as to why this trial has been undertaken, I think it's clear to most TAVI implanters that the presence of concomitant coronary artery disease is a fairly common occurrence in patients that have been considered for TAVR. And depending on what registry you look at, overall, it's at least half of patients in an all-comers population have some degree of concomitant coronary artery disease. The key thing is that all these are registry data, it's not core lab adjudicated. And you can see that even in the randomized trials, PARTNER and the Evolut low-risk trials, the occurrence of concomitant coronary artery disease is common. Now, one thing to highlight is that when you look at recommendations from the guidelines, there's really not a lot of evidence to guide practice. So it's level C level of evidence. And as David will show you, there's significant heterogeneity in terms of practice. The other thing we don't know is, firstly, who should have a PCI? And also, secondly, when should the PCI be done? And really, what we hope to show you is that really there's a need for a large, appropriately powered randomized trial. So one of the key things here is that we know that the burden of coronary artery disease plays an impact in other clinical scenarios. And it would seem that based on early registry data and different multi-center reports, the same approach seems to be consistent in patients undergoing TAVR, in that if you have a higher burden of disease as per syntax, this seems to be associated with worse outcomes. Now, of course, importantly, this is a recurring question. Should the PCI be done before or after? We have a number of series that are single center reports that have looked at this. And actually, as of November 24th, presented at EuroPCR was the activation trial, a small...
This morning, yes,
absolutely,
this morning.
A small randomized trial which showed that PCI before TAVR did not have an impact compared to medical therapy to 1-year outcomes. So clearly quite a timely study that's just been presented. So just to highlight this heterogeneity, these are two examples from our heart team rounds just last week, David, right? These are two patients, both relatively young in their 70s. And as you can clearly see, this is patient A who's got 2-vessel concomitant coronary artery disease being considered for TAVR. And this is patient B, a very similar situation with disease in the LAD and in the RCA. And even within our local context, there was significant debate as to what should be the appropriate approach in these patients.
Thanks, Janar. So at the start of this, I guess 4 months ago now, we sent out a site feasibility questionnaire to all 103 sites because we wanted to understand what was the practice currently and would centers be willing to randomize per protocol. It's crucial, if you're a clinical trialist, that the transfemoral TAVR happens first. We're following these patients for a median of 3.5 years, and it's separated, the efficacy and safety in time, from the stage PCI. It's very challenging to do the PCI prior or concomitant to then separate out safety and efficacy. And we wanted all patients to have a transfemoral TAVR as part of their inclusion because we're going to be following them for a median follow-up of 3.5 years. So I think this is fascinating. All 78 sites who've completed the survey to date believe complete TAVR will influence global clinical guidelines, and all 78 sites are willing to randomize patients to stage PCI versus medical therapy 1 to 45 days post-successful TAVR. But let's look a little bit deeper. And we're actually sending this survey now to a lot of our colleagues and friends throughout the world, because we want to get a snapshot of what's happening at the start of 2021 with regards to CAD. And I know you've had a lot of wonderful lectures on small annuli, pharmacotherapy post-TAVI, the SMART trial, others. So I think this is a fabulous time to be doing TAVI globally. So what proportion of cases also have concomitant CAD with at least one major vessel with a greater than 70% visual angiographic stenosis? Percentage on the x-axis, number of sites on the y. And you can see approximately half will have coronary disease. So this is what we believe from the registry data. And then the next question, similar to the question we asked for the STEMI population with complete, what proportion of significant proximal LAD, circ, or right? And again, approximately half. And I think this is absolutely fascinating. In your TAVR patients with CAD, what's your preferred approach? And we asked 2019 because obviously the pandemic changed people's normal practice for the last 10 months. Currently, about 60% do PCI prior, and 40% would do it only if the patient had recurrent symptoms or in a staged approach, which I think is fascinating. So you've got a 60-40 split. Of the 60 who would do PCI, about 75% would do it prior to TAVR, and a quarter would do it either at the same time as TAVR or after. But regardless of that, 78 of those 103 sites to date, and we're expecting to get hopefully all 103 to complete the questionnaire, have agreed to randomize patients post-TAVI. And I think that's supported by the small trials that have been reported today, and we had activation come out earlier. So I think this is crucial here. We only have a couple minutes left, but let's just look. Symptomatic AS patients with at least one coronary artery lesion in a vessel that's 2.5 millimeters, and heart team consensus that the anatomy is suitable for transfemoral TAVR and for percutaneous revascularization. They must have successful transfemoral TAVR with a balloon expandable THV. Obviously, if there's an intent to revascularize or they're going for surgical revascularization, that would be an exclusion. So after you have the successful transfemoral TAVI, you're randomized the next day and stratified both by intended timing of PCI and requirement for oral anticoagulant. 2,000 in complete revascularization, 2,000 in medical therapy. The antithrombotic therapy, we've had a lot of discussion with the steering committee with Roxana, Rob Welsh. Right now, aspirin and clopidogrel for 6 months, then aspirin lifelong if you have PCI, versus aspirin monotherapy for TAVI. If you require an OAC, which in this population, we expect our mean age is probably going to be in the mid-70s, is going to be rivaroxaban and clopidogrel for 6 months, then rivaroxaban 20 lifelong. That may change as data comes out. Remember, this is a 5-year trial versus rivaroxaban 20 lifelong if you're in the medical therapy arm. Median follow-up 3.5 years. We've gone through the primary outcome. Secondary outcome will also include fluoro time, contrast utilization for the stage PCI if randomized. I won't go through all this. It's all available on clinicaltrials.gov, but basically symptomatic AS, coronary artery disease, and consensus by the heart team, they're suitable for transfemoral TAVR and would receive a bypass distal to the lesion if they were going SAVR. And the exclusion are similar to partner 3. Anatomical exclusion criteria in clinical, again, identical to partner 3, other than we've taken off bicuspid, given now the FDA indication. Sample size calculation, you can see there approximately 4,000, actually 4,060 patients. We plan to randomize in January 2021. You can see the timeline. Last patient enrolled April of 2024, follow-up April 2026 with database lock. And we actually hope to randomize the first patients in Vancouver.
Yeah, it's exciting to get started.
In December, which is amazing. This has all happened during the pandemic. So in summary, this will be the largest TAVR study to date, and we'll have a median follow-up of 3.5 years. In addition to the main findings, we envision more than 20 sub-studies, at least 20, including coronary access, where we have 4,000 baseline core lab CT scans and 6,000 baseline core lab angiograms, antithrombotic therapies, stenosis severity, lesion location, obviously syntax, residual syntax, intracoronary imaging, CT-FFR, quality of life, cost effectiveness. We've had studies proposed on left atrial appendage closure, all sorts of different things within this hemodynamics. We believe there is clinical equipoise with regards to the benefit risk of PCI. That's the reason for the trial. All patients enrolled in complete TAVR will be elective. So these are not acute coronary syndrome patients, and they must have symptoms. And the hypothesis here is, are the symptoms from the AS the concomitant coronary disease, or both. And we believe the trial will strongly influence global coronary, transcatheter, and surgical guidelines in 2026. So on behalf of myself and Dr. Sadhanathan, thank you. And if you're interested in the trial, please reach out to us as per the attached slide. Thank you so much.
Thank you.
Wow. Wow. Thank you. Thank you, David. Thank you, Dr. Sadhanathan. What a wonderful, wonderful explanation of the rationale for this very, very important trial. We're going to talk a lot about this, especially during the live case, because we do have a live case and we're very behind. So what we're going to do is go to the last talk by Vinod Tarani. And I think, as I already introduced Vinod Tarani as the head of the Piedmont Cardiovascular Surgical Center, and he's really absolutely doesn't need any introduction. He's obviously the lead of the STS-TVT registry at the moment, chairing that, and it's just fantastic to have him here. His work and data on failed TAVR and surgical explants is what his topic is today, and we'll take you there. And then immediately after that, we're going to the live cases. So please stay tuned if you can. This is a 10-minute talk, and we'll go straight into the live case, which is a wonderful case of a small annulus. I need your help, David. I want to hope that you're going to be there helping us. And Dr. Sharma's jumping back into the cath lab. So Dr. Tarani, wonderful to have you.
Hi, I'm Vinod Tarani, and my topic today will be failed TAVR, results from surgical explants. These are my disclosures. So first, I thought it would be very nice for you to see two cases where patients' TAVR valves were implanted, and then what we were able to do is explant those valves. And here you can see the first one that I'll talk to you about is an 82-year-old male who has a bioprosthetic infected valve. And 2 years later, you can see he has developed a pseudoaneurysm. Now, this is a high-risk patient. And so when he first had his surgery at 80 years of age, he was considered high risk. You can see he had a self-expanding, and you can see in 2 years what's happened. He has a large pseudoaneurysm at the base of the anterior leaflet of mitral valve. Now you can see my resecting it. I'm coming down onto the non-coronary cusp between the right, and we're trying to tease this TAVR valve, which has incorporated itself into the aortic root. Now we're in the STJ. I've transected the aorta for the cardiologist, and I'm taking a 15-blade knife, and I'm just slowly teasing the valve off of it. Now I'm getting into the left main cusp. And here you can see now I'm having to go, I've passed the left main, I'm going towards the right-hand cusp, and now I'm right over the right cusp. You can see how the valve has incorporated itself into the root itself. And you have to use very fine to fine. And now I've now almost removed the valve. Some people use ice cold saline to try to shrink the valve. And here you can see I've now removing the whole valve carefully with a 15-blade knife. And this is not trivial as far as taking this valves out, but it is doable. Here you can see I'm about to deliver the core valve completely. And now we've completed it. Now I have a relatively a core valve that has been explanted with the coronary, with the aortic valve leaflets into place. This patient was extubated post-op day 2 and discharged on post-op day 7. So a high-risk 82-year-old patient, but still doable. Now I'll talk to you about a different type of patient. And this is a 58-year-old who had a bicuspid aortic valve. And at that time, his aortic valve was 3.5 centimeters. His ejection fraction was at 60%, and he had a STS prom of 0.5%, very low-risk patient. He, for whatever reason, underwent a TAVR in March of 2017 and consequently had intraoperative paravalvular regurgitation. And an immediate TAVR and valve was done, and the patient was discharged with mild to moderate PVR. Over 2 years, when I saw the patient in 2019, he had now severe PVR and presented with an ejection fraction of 25%, not 60%. He was in class 4 failure, and he still had his aortic aneurysm of 3.8 centimeters. Remember, it was 3.5 before. And here you can see the large defect, and that is right at the commissure of the right and the non. And you can see my entire pickups are able to fit into this, and you can see the TAVR, a balloon expandable valve, position into place there. This is also a very difficult operation as far as resecting. You can see how the sapien valve has incorporated itself into the annulus. Unlike the self-expanding, which has sometimes incorporation into the root itself, this had more incorporation into the annulus. And here you can see on the panel to the right, we're now slowly, again, using a 15-blade knife to tease this off of the left main. And again, very tedious operations, but they're doable. I was able to remove this. The aortic cross-clamp time was 55 minutes. The cardiopulmonary bypass time was 62 minutes. When I did remove this, I was able to put in a 25mm Inspiris tissue valve into this patient. He still wanted a tissue valve and not a mechanical valve. And you can see these type of operations that we are performing for TAVR valves. So for this patient here, I show you, in this is the non-coronary cusp, and the area that I show you where there's a patch is that this valve, sapien 3 valve, had grown into the anterior leaflet of the mitral valve, and the only way to get it resected was a large defect that had to be patched, almost like a root enlargement. And as you can see, this is now the area of the non-coronary cusp, and the right coronary cusp is at the top at 12 o'clock, and the left coronary cusp here is at about 9 o'clock. And you can see here that this patient had an Inspiris valve that was implanted, 25. This patient did well. He was extubated on postoperative day number 1, went to telemetry in postoperative day number 3, and was discharged on postoperative day number 5. So what is the data for this? There's not a ton of data for this. I think this is a really burgeoning area for us to look at. Here's one of the earliest reports by the Michigan database, where they had 1442 TAVRs. Explant rate was 1%. The mean age was 73, and the STS score was high at 9.9. The indications per PVR, indications for removal of the TAVR valve was PVR in 41%, complications of TAVR 23%, structural valve deterioration 23%, endocarditis was only 6%. They ended up having 11.8% in-hospital mortality. I now personally have done about 15 explants myself since 2006, and we've been fortunate with 0 mortality early on, but you can see that this is a relatively high mortality, I think indicative of the high risk nature of these patients. The next analysis was really done from the STS database. So this is looking at the country's database. This is something that we did in collaboration with the multiple institutions. And this was just recently published in JACC of 2020. And here you can see that we had patients with previous TAVR 205, patients with a record of TAVR explanted at 28. So the overall population was 233 patients. When we look at it, our final population was 123 patients. The indications are a little bit different. You can see the PVR was 15%, structural valve deterioration 11%, sizing position issues, i.e. valve is too high or too low at 11%, and endocarditis was 10%. As you can see, the operative rate was 17%. So we're looking at over a 10% mortality in these patients. So I think that experience of how to remove these valves becomes critically important. There are 2 more studies that I'm going to share with you. One is presented by Dr. Kaneko last year at TBT, which then consequently was just recently published in JACC by Dr. Hirja Samir, and this looks more at the nationally represented analysis. And this is this is a summary slide of the entire study on one slide for you. And what this does is this looked at CMS database, as you can see, from 2012 to 2017. A total of 132,000 patients were evaluated. The mean time for explant was 212 days, and you can see the breakdown from 30 days, 6 months to 1 year. The indications was quite different. You can see that 20% of the patients had endocarditis and 79% had bioprosthetic valve failure. And then the average age for these implants, and you'll note explants, what you'll notice that a lot of these patients in their 70s that are getting these explanted, and you can see that the surgical explantation rate was 0.2%, but once again, an over 10% mortality rate. And I'm concerned about that across the board. You can see a 1-year mortality of 23%, obviously based on CMS linkage. The last and probably most comprehensive is something that the guys from Mount Sinai have looked at, Gilbert Tang, and this is called the Explant TAVR Investigators. And some key findings include the idea that the mean age was 72. There we go, with the low 70s once again showing us where we're getting our explant patients from. You can see the mean STS score is 4.8. And remember, this is a little bit different than what we saw earlier. In the Michigan, we saw almost a 10% STS prom. So this is, I think, reflective of the lower risk patients. Unfavorable anatomy for redo TAVR was presented in 19% of patients. That's mainly low coronaries and patient prosthesis mismatch. The time to surgical explant was 12.9 months. We're seeing that across the board. And you can see the indications are a little bit different. We're seeing, again, more endocarditis and more SVD, and a little bit less perivalvular leak and patient prosthesis mismatch. I think that's because the perivalvular leak has gotten better as we've gotten into third generation valve products. Some of the key findings are that root replacement was required in 37% of patients who had balloon expandable and 62% who had self-expanding or mechanical expanded. For me personally, of the 15 patients that I've done, I've had 0 root replacements. I have had the one patch that I showed you, the anterior leaflet of the mitral valve. And you can see root replacement in their hands was done in 14% of patients. You can see more of them that were self or mechanically expanding. And 48% had concomitant cardiac procedures. The procedure mortality was 0.9%, meaning that surgeons are getting these patients out of the hospital, but the in-hospital mortality was 11%. And I imagine the 30-day outcomes, again, was 12%. So you can see that we're still above a 10% mortality. And I think we have to work on this. The one-year outcomes, similar to the CMS data, showed a 28% mortality and a 10% stroke rate. I'm not sure that those are great outcomes. I think we have to do a better job as surgeons having these outcomes for these very difficult patients. The overall survival after TAVR explant at 1 year is 78%. You can see it by a KM curve, and then at 3 years, 73.3%. But you can see the number at the patients at risk are relatively low. I think that with the increase of TAVR in younger patients, and specifically since these are all now bioprosthetic valves, is expected for patients to return for reintervention. I think this will be an increasing concern for us. Decisions on whether we should do a SAVR after a TAVR or a TAVR in TAVR, a talk that we didn't talk about right now, I think will become even important decisions for our heart team. Personally, at the Piedmont Heart Institute, we're doing modeling for all of these, computational modeling for all these patients, and we decide on whether TAVR in TAVR is the right pathway or SAVR after a TAVR is the right pathway. I think that patients with endocarditis and severe PVR will almost always go towards SAVR after TAVR, or maybe some of the SVD patients will be a relative indication for SAVR after TAVR. Maybe we can do TAVR and TAVR in those patients with a very low mortality rate, and hopefully we can do this without any major complications and not have patient prosthesis mismatch. Since I am one of the few surgeons giving talks here, this is a patient that showed up in my office at 30 days, and I didn't have him wear the shirt. He just wore it on his own. And I thought you guys would find this as a funny algorithm. You can see that he says stents are for wimps. Real men have bypass surgery. And thank you very much for the opportunity to present.
Oh, very, very nice, Vinod. Stents are not for wimps, okay?
He showed up in my office with that, and it just blew me away. I thought that was hilarious. I said, I've got to take a picture of you, man. I said, this is incredible.
We're going to do a survey of all the surgeons. You want bypass or stents?
Yeah, we're very, very excited to have you on the panel for this next live case. We're going to go straight into the live case with Dr. Sharma, Dr. Kinney, Dr. Tang, and Dr. Lorakis.
Hey, Eric,
do
you think she needs more fluid? The heart looks kind of hyperdynamic.
Dr.
How much fluid have you given so far?
Dr. Saibal Kaur, Dr. Raj Makar, Dr. Vinod Tarani, Dr. Eberhard Grube, and
yeah, we'll just give another 250, just a little bit wiggle room.
George Dangus. George,
Yeah.
are you available to lead?
I'm right here. I can see all of you. I can hear.
Okay, excellent. Let's go to the live case. Dr. Sharma, you're.
If you can hear me,
Yes, we hear you well. Dr.
we
Grube is
have the
online.
CAFLAB team introduce themselves and say hello.
Yes. All right. Hello to after the extensive. I know that we may be a little late, but so what? What are you doing extra? You're learning. Great teaching sessions. I mean, this is phenomenal. I mean, those in our circle of audience, I at least got 12 texts in last 2 hours that how high level talks they are and really talking about the future. With that note, we are ready to put another case of the live case. We felt that any meeting cannot be complete without live cases. First case we did with the sapien in a difficult anatomy, particularly bicuspid aortic valve and dilated aortic annulus and root. And this case is the of evolute valve, which has its own issues in terms of calcifications, and so we'll discuss. Every team members remains the same, except change of Sahil Khera or another junior structural attending, associate director of the structural interventional program here, and ready to start presentation of case number 2. Let's start the slides, please. The disclosures remain the same, nothing much change, although Dangus is a little remote, will be moderating from there with help of Roxana. I really thank both of them. This is the 91-year-old patient who has presented with progressive angina and of course on good medical therapy, multiple other medical problems, but nothing unusual, but it has a normal sinus rhythm with right bundle branch block and left anterior fascicular block. So that's very important with a PR interval of 142. This kind of case, when you're doing the valve and particularly the evolute core valve, that in terms of leaving the pacemaker compared to with the sapien, we take it out. In these cases, we do leave it for 24-48 hours because of the baseline bundle issue. Now, the patient also has a severe aortic stenosis, and we will ask now Stam to just show live echo.
Yes, good afternoon again. This is parasternal long axis view. You can see the patient has normal LV function. You can see the thickened, calcified, and decreased mobility of the aortic valve leaflets, and also the calcium in the LVOT, the significant calcium in the LVOT. This zoom image of, again, the long axis parasternal view to appreciate the calcium in the aortomatral cortin. That is very important to know ahead of this case. The patient also has about moderate aortic regurgitation. This is the X-plane of the long axis view. As you can see, significantly decreased mobility of the leaflets with severe calcification and decreased mobility. And again, about moderate, most likely moderate aortic regurgitation. This is a 4-chamber view, again, normal LV, normal RV function. And you can appreciate the calcium, again, in the aortomatral cortin. And this is a better view for that, again, about moderate AI. And you can see here the subvalvular LVOT, the LVOT very calcified, important for this case. No pericardial effusion, again, important to know. And these are the gradients, max gradient of 54, mean gradient 32, aortic valve area 0.5 centimeter squares, critical aortic stenosis is also, the SVI is 32, so low flow, low gradient aortic stenosis. The pressure half time is aortic regurgitation. And this subcostal view to appreciate, again, no pericardial effusion, and also the hyderatrial septum that is important because of the significant calcium in the LVOT. Dr. Sharma, back to you.
Perfect. Well, go back to the slides now. So we just go through
Stan,
our
can I ask you a question?
CT.
Stan, I have a question for you. You see some septal hypertrophy there. Does that bother you at all? And I see a lot of MAC also. Does that bother you at all? Can you just comment on those two things?
Yes,
Vino.
great to hear from you, Vino. And good to see you to participate in this meeting.
Thank you.
Yes, and I wanted to say that the base LV bulge is a little bit worrisome, as you know, for a risk of embolization. So yeah, that's one thing that is very important, and you picked up on it. And the MAC only, as I say, is on the anterior side because of the risk of rupture. So all these are significant. That's why we show this case for these learning points. So very important observation, of course.
Yeah.
Okay. All right. So we can go back to, I think there is some, back to the slides now. Go to the next level, which will be our CT scan evaluation of this particular case, and already has been emphasized about the LVOT calcium. Okay. So want to comment on
Sure. Yeah. So you can see this is severe annular and LVOT calcification, very small LVOT. You can see the annulus itself is around 428, 74.5, but look at the LVOT, 321, 65.5. So, you know, we're going to talk about balloon expanding versus self-expanding, but certainly this could be a pretty high risk of annular injury if you choose a balloon expandable, not because of the annulus per se, but the LVOT. Next slide.
And those are two nodules of calcium in the LVOT.
And it's short, and it's on a short axis as well. Next slide.
Okay.
So you can see it's a bit of a large root, sinotubular junction and ST and sinodorsal are very large. Left main height is very generous, so we're not going to worry about coronary issues here. Next slide. And Sahil, you want to talk about access?
Yeah, access is, I think it's relatively straightforward. There's no calcium in either of the common femoral arteries. There is some tortuosity in the abdominal aorta, but I think it's easily navigable at this point.
Okay. And so central point of view?
Central is, there's some tortuosity of the carotid, but otherwise straightforward.
And did we do a sentinel already?
Yes, we have a sentinel.
Okay, so this case also we had sentinel. As you said, that we make a sentinel as a default. And if the sentinel is not used, I know there has been a lot of pro and con, whether should you use sentinel in all cases or not. But if we don't do, we do write it actually in the cath report that why sentinel device was not used. Yeah. So then this is from the valve selection point of view, which is Evolute R Pro Plus. And this becomes with the annulus, and so it fits into the category of the 29 millimeter. Right? Everybody agrees on that? Yes. Good.
Dr.
And
Sharma,
so we are ready to start here.
I know.
Yep.
Can we stop for a second because you have some of the experts here, and it would be great.
Yes.
You know, Howie, you're the PI, you're the study chair for SMART. Does this patient fit into the SMART trial? And would anyone randomize a patient like this to a SAPIEN device?
So I think theoretically this patient could fit into the trial, but I think the concerns that you've raised already about the LV outflow tract calcium makes this patient less desirable for a balloon expandable valve. And so I think this is a better chosen Evolute patient. I also think we don't have to be quite as concerned about a small annulus in a 91-year-old patient. We're not looking at long-term hemodynamic durability of the prosthesis in the same way we might in a low-risk 70-year-old. The last thing I would just add, it's between a 29 and a 26. The LV outflow tract is smaller than the annulus. The annular perimeter would say 29, but the LV outflow tract with the calcium might say 26, and you might have some trouble landing the 29 as high as you would like. And in this case, you want to be as high as possible to avoid the pacemaker risk. This is a real cusp overlap, careful high placement as best you can to avoid pacemaker afterwards.
So let's talk about that because many people are not clear about this cusp overlap. So who wants to explain it really well?
We have a slide that way.
Or George, do you have a slide on that?
We have a slide. Can we go to the slides and show the cusp overlap slide because we anticipated this discussion coming up. Can we see the slide, please, regarding the cusp over? There's some technical detailed slides that we need to show that's going to come up during the discussion. This is a patient selection. Very good. Next slide.
Yeah. No, but did we add to the slide? Unless it was separately out. If you have it, George, you need to share your screen. If you have, because unless it was given to them.
I asked them to add it to the end of this presentation. Anyhow, this wasn't done. So why don't we ask Dr. Grube the experience from Europe regarding the cusp overlap projection, and we're going to see it actually displayed in this case live.
Can you show that?
Thank you very much.
Can you show the aortogram? I'll explain.
Okay.
Thank you very much.
Just to say, since we don't have the slide, let's go to the aortogram if we can show based on that aortogram here. Yeah, this
exactly.
Otherwise, I'll say.
Can you let Dr. Grube speak first, and then Dr. Kinney will explain it. Dr. Grube goes first.
Yeah, please show the angiogram while he's speaking.
Basically, you overlay the two cusps and leave the non-coronary in order to expose the membranous septum. So that's basically the double S curve that has been
stop it.
Importantly,
so you can show
there's a change in the delivery of the core valve. When we started it, we went into the ventricle, across the valve, and pulled the valve back. We don't do this anymore. We stay at the middle of the pigtail and then let the valve go down so it doesn't touch it doesn't get in contact with the conductor system. That's the essential.
Eberhard, I wish I could hug you again, my friend. It's David Wood. Look at that background. Oh my goodness. Wow.
My castle.
The only thing I would add, George, is obviously this patient, because of their age, but a lot of things that come up in the heart team meeting, pre-existing right bundle branch block definitely guides myself and John for which THV platform, redo as far as what's the strategy for our redo. Here, less important given the age, but those would be the other things we'd be chatting about. The subalveolar calcification, again, we can chat about how that would influence our THV selection.
So I'm curious for David. David, would you have chosen a self-expanding or a balloon expandable valve for this? Looking at the LVOT calcium and looking at the septal hypertrophy.
Yeah, we would just do a bespoke balloon expandable most likely, but we use cusp overlap as well. We've been using the DART, and we've actually been very impressed with the pacemaker rates. So I think hopefully we're going to see a beautiful example of that today.
Yeah.
But again, we also have access to some valves that aren't yet available that might be perfect for this situation. So there you go.
Great. Let's proceed on how to use it practically, Dr. Keeling, Dr. Sharon.
Yeah. So let me explain to you. So you got to take the angiogram to see this cusp overlap view. I think you can see that the catheter is actually in the right cusp. So what you see here is the right and the left cusp is overlapping with each other, and the non-coronary is, you see it without the pigtail. So we also know the non-coronary cusp is the lowest. So that is why when we start, once we go up, you'll see how we are going to start releasing. We'll start releasing in this cusp overlap view. So the valve is just at the cusp of the non-coronary, which is the lowest. So you don't want to go lower than that. And then we will go to the LAO view just to confirm everything is okay. And that's the time we will release it. And that is how we practically do that.
Okay, good. Let's start now. What did you do so far?
Kenny, I have a question.
We have crossed.
Excellent.
Yeah. Kenny, I have a question. So when we do the cusp overlap, I use cusp overlap in every case, but I put the pigtail in the non-coronary cusp. And you don't want to put the pigtail in the
no. What? When we're deploying, of course, we will place it in the non-coronary. Yes.
Yeah. I got it. You just want to show that. Okay, that's fine.
Yeah.
And by the way, David, I would definitely prefer a self-expanding valve in this patient compared to a balloon expandable. For the reason.
Actually, that is what we will be using in this particular case. Actually, we have a very because we have very nice the review in the JAMA Cardiology a few months ago about the tower choice, and many of these points which we have discussed now, I'm so glad that we have made exactly on those lines the recommendation of using the balloon expandable or self-expanding, and of course we have the modified indication of the Lotus valve, which is no longer there. But clearly all these points are very important in discussion of in a valve selection. We all know that probably 80% of the time you can use any valve interchangeably, but in 20% based on the specific anatomy, the one anatomy will favor one valve versus other. So now we are ready for valve has been crossed with the AR2 and exchange with the exchange length wire. Now going with the pigtail so that it change it to Confida.
Yes,
Safari.
So we like to use Safari because of the small ventricle and the 91-year especially. But I think one thing to make the point though is that this patient, as you have talked about, has a pre-existing right bundle branch block, left ventricular block. So any inducible heart block can happen once the wire is crossed. So we actually have Ramon here standing by the pacemaker just in case that we have to temporary pace because of inducible heart block from wire manipulation.
So the other thing that I've changed to, I'm not using Safari or Confida in cases, and they're just using the double curved Lunderquist through a pigtail.
Lunderquist.
Double curved Lunderquist.
Lunderquist in a 91-plus-year-old got to be
No.
That's a California thing.
It's a double curved Lunderquist through a pigtail. It's very effective. It's very safe. It actually is more stable. It's stable also.
Hey George, that's the East Coast versus West Coast thing. We started using the
we need to finesse the valve into the LV.
Vino, you know how much I love you, but even we have been playing around with this double curve Lunderquist in
that's
Vancouver,
a West,
and I must.
like I said, David, that's a West Coast thing.
No, Vino, I'm going to chime in from the East Coast and say we also like the double Lunderquist.
But I think Eberhardt's point about the fact that we don't go in now deep and then pull back and come from above with that dart double curve, you know, all those pieces, I think it's crucial for the operators listening to this call, Eberhardt.
It's a very stable wire, by the way.
Yeah,
it is, and it also
you can put it through a pigtail.
We use a lot more
go
pacing now as well.
150
to the valve stable as we're inserting it.
Vino, would you show the hemodynamics also, guys?
Wow, very resistant valve. You see, only in full deployment did it really give. Very important to have done this dilation.
So I was going to ask Dr. Sharma, what is it common, or Kimmy, Dr. Kimmy, how is this common for you to do BAVs, or is it just in this specific patient who has a lot of issues crossing the valve?
Yeah, I know that there are a lot of the whole camp using no BAV, and so we actually at Sinai still in the self-expanding. I would say almost 70% time we'll do BAV. In a balloon expandable, almost 90+%. We still use quite a bit of BAV pre. Idea is the same. Try to avoid the post. So post is, I mean, of course, with the balloon expandable is very rare, like we did earlier case with additional CCs or dye. That's very little. But even with the evolute and so, our post dilatation is it like in 20-30% range. Idea is the same. The pre, so I know this is always a question comes, do you want to do a little more pre versus post, particularly with the self-expanding valve?
Okay, flush for at 3 o'clock.
What is your practice? I know that a lot of people have gone away from the BAV at all with the tower.
No, I think it's in the larger valves. I think it's better to do pre-AV. Otherwise, sometimes the evolute folds.
Well, what is buckling too much?
Yeah. You can see now that the head marker is in the outer curve of the descending. If you go, we're in the LAO view. So we're going to make sure that we don't.
Yeah, very interesting to see here how it passes clear of the sentinel.
What's the sentinel? Okay, good. And then you can see the head marker is now in the outer curve of the ascending and down to the annulus. Okay, so at this point, we're going to go into the cusp overlap view.
Did you attempt to do commissural alignment on the back table? Is that
very good question, David?
We inserted at 3 o'clock. Yes. That's exactly what we did, and you can see that.
Can we explain that a little bit, Gilbert?
That's an important concept, Gilbert, if you want to take us through that.
You directly. You can see the head marker is facing almost at yourself directly. That's how you know that you have.
Yeah, Gilbert, maybe you can talk
a
little bit on this.
Explain a little bit. This is a little bit high, very high end. Let me explain a little bit for the simple viewers. It's you're looking at the marker of the valve at the most distal part, the one that's inside the LV, and you can see that the marker is actually a double marker, and one of them is very dense, and the other one is not so dense, and the one that's not so dense is not exactly all the way through. There seems to be a little bit of a filling effect, if you want, or a drop out on the right side of our screen as we watch. And this is a desirable, entry into this location. From practical point of view, you focus on the marker of the valve just below the pigtail.
I'm trying to reposition into the non.
Pigtail into the non, yes. Yeah. It's a small, it's a big root, but small annulus.
So yeah, sometimes we pull back to
bring the pigtail back.
Reposition.
The wire
we did.
Give us a little bit more of a chance to talk about this alignment of the valve. And again, you see sometimes it doesn't work that well as here. You have to pull back the valve and then turn it into descending and reinsert it, and hopefully it will end up this way.
Okay, I think I'm not. No, I'll leave it here.
No,
I did.
No, you have to go to the left.
Okay, now.
Good. Yep, that's fine.
I think I'm going to leave it little curled.
A little bit in a cross position, but it did go.
Yeah.
Yep.
And we're going to do a test.
I mean, this actually, I have to say that the Zoom technology allows us to moderate from anywhere. knowing that we got little
Immediately,
delay,
moderate
George has
from
to go
anywhere.
to
Little bit died.
anywhere. So he's moderating from remotely from Queens.
Good, looks really good. Okay, all right. You can see that we're starting to deploy. We're
Okay,
a little bit above the calcium.
Okay, inject.
We just dive down slow. Okay,
Yeah,
150.
Excellent alignment, and it's expected to come a little bit further down. So we're very good.
Inject.
Can we see it?
It's coming down.
Okay,
The
inject.
problem is that the
Pigtail.
valve is the sheath is taking the pigtail out.
I'm going forward.
So we got to be injecting
Yeah.
higher volume here, please.
Oh, oh.
Okay, deep.
Make sure you do a very powerful injection.
Inject.
Yep.
So far, so good.
Okay,
far,
so
so
we're
good.
80%, back up at 30, 80.
80.
So now we go to the LAO view. Just make sure there's no parallax on the valve.
Please inject
We'll
with
mark
a
it- we'll mark
bigger
it so that
power
everyone can
because
see.
the sheath is pulling the pigtail high.
And the pigtail is, yeah, pigtail is very high. Okay, so
Okay,
let's try
ready?
that. Let's see.
Inject with
Inject
bit more
again.
volume.
Inject.
Big volume, yeah, right there.
That looks really good.
I think we look good. What do you
Yes,
think,
very good.
everybody?
Looks
I mean, look at
great.
that. Just like
Looks very nice.
no high, little bit of okay,
That's okay. Go for it.
okay.
No, pigtail is already
Pigtail
up.
is already up. Okay,
Go. Pace again.
pace 150.
With a, yeah.
Ready?
Yeah.
So pacemaker at a higher rate and a little bit of a push typically.
I'm
in these
holding it
cases.
neutral.
Go forward, go forward.
Okay,
It's not a
forward.
realty.
Yeah.
Okay.
We should not
Good,
be.
good, good. Okay,
Okay,
good.
oh.
Excellent. That's okay. All right. Well,
Moved
150.
up. The valve
120.
moved a little bit. Did
Yeah.
you see that, guys?
Yeah.
Watch
Yeah.
the wire, please.
Yeah.
The valve
Typical.
is just very borderline.
Yeah.
It's a
Okay.
zero deployment.
80?
It is okay.
Yeah.
It's a supraannular, but that's okay. No.
Yeah,
As
the
long as
valve
not
moved up
minus.
a little.
Yeah.
Basal hypertrophy.
Not a
also.
little.
Yeah. It's a small LVOT. So let's do an aortogram now.
And I think
check.
which was said about the basal hypertrophy has something to do with it also. The push
Yeah,
it
yes.
up.
But it's okay.
Let's approach
It's a
the
zero
pigtail
deployment.
and do a high power angiogram.
Inject.
It's beautiful.
Okay.
Yeah, it's okay. Yeah, a little bit on the high on the non, but I think it was still
Let's do the echo.
below the annulus. Now
No,
we,
either way, we are not going to post here.
yeah,
Okay.
good, but we should do a
Agree.
hemodynamics or no?
Good. Let's do the
Exchange
echo.
pigtail. No
I
pigtail.
don't
I'd like
do
to
anything.
see the
No,
echo.
exchange with the pigtail before we take it out. though.
Yep. You show the echo now,
Let's do
please.
the hemodynamics.
Put echo on the main screen. And the diastolic
Let's do
pressure was
pigtail.
always
Let's do
60,
pigtail
remains
exchange.
60. So that's a good sign.
Yeah, let's try to get the
And the patient's
we
rhythm
don't pull the
also.
wire all together.
Looks like they were a little bit in hard.
Because if it's high on one end, there may be significant PVL. We want to exclude that.
What heart rate are
No,
you
but
pacing
actually,
now?
it's not
Ramon?
high. It's a zero deployment. It's a very good deployment. I think it's very good. It's
Show
zero.
the echo.
3216.
Yeah,
And-
we'll show you.
And you
We'll
can
show
see
you.
by
yeah.
echo.
Okay. Yep.
It's excellent deployment.
Yeah,
Yeah.
we have a
It's an
wire
excellent
still.
deployment.
Right. The wires,
Yeah, that's
I
the
think
wire
that's
bias.
like central AI over the wire.
Guys, this looks great.
Yeah.
Mile is good.
This one,
This-
Okay, we are, you want a
Do
picture?
you want to
No.
take the, Gilbert, do you want to take the wire out so that you can see the,
Fluoro.
We are going to take the wire out.
Okay,
Yeah,
Yeah, take the wire. Yeah.
On fluoro.
okay.
careful, wire out.
Wire out.
Yeah,
You want
wire
wire
out.
out? Okay, all right,
Good.
good. Okay, no more
All right.
wire.
Can you see apical
Let's
views?
see the
Apical
echo
views.
back again on the screen.
Apical, let's see apical.
We have the
Yeah,
D
apical
sign.
views, yeah.
Yeah, I have wire. You want a wire out?
Hmm?
Okay. All right.
Okay, this is the apical views.
What's
You
that?
bring the aorta- Yeah,
I
yeah,
think
beautiful.
the echo.
What we
Shows the
wanna do
short-
is
short
just get
axis.
Final comments and go off to our next session, guys. So let's show
Yes,
us the
yes,
final thing.
yes.
Final comments. We're way behind.
I think the echo also shows you how difficult this would have
Exactly.
been with a balloon.
Dr.
It's
Herman,
animal
any
device.
comment? We listen to you. Dr. Herman?
Yeah, I
So
was
there
going to
is,
say, it
there
shows
is
you
a
on the
strong-
echo that big,
A strong
big
mild
septal
paravalvular
knuckle,
leak.
how
Yes.
difficult
It's
it would have been
expected-
to deploy a balloon there.
Yeah.
It would have
Push
pushed
it
it right up into the aorta.
Okay, let's measure
That's
the
right.
That's
So
a
we
big
just left it
paravalvular
at that place.
Yeah, diastolic
So the-
around 70 here.
Show the hemodynamics.
And again, remember this is
That's
91
the leak.
plus.
Yeah.
So compared to the previous patient, we wanted to be perfect with a no PVL. Here, as long as we don't create any damage, there is no
Yeah.
much
Yes.
gradient,
Yeah.
mild plus even 1 plus paravalvular leak, I think we'll accept it. Because valve may otherwise embolize.
Move up.
Does everybody agree? I think I'm in agreement to that.
and I don't think you can
Okay.
post dilate with this.
No.
Good.
You can't post dilate.
No,
I think
you
there is a bit of
can't
a.
afford the post dilation, and there were some issues regarding the Einrus as well and the advanced age, so we'll accept a small degree of PVL. Very well. I think it was very well
this
done.
is going to be one of the endpoints you're going to be looking at, right, Didier and Howie, in the SMART trial. The PVL is important. What would you do if this patient was in the SMART trial, received this? Would you say that to get rid of all the PVL or to move ahead?
Well, I don't think you can post dilate this patient because of this. It's such a high location, it would pop out. So your options are either to let it sit for a while and hope it gets a little better as the valve frame expands over time, or come back later and close it if you think it's more than moderate. But I don't think it's moderate, and I think it's going to be under moderate once the valve fully warms up.
Yeah, Howard was very smart in selecting out the patient away from the SMART trial in the original question you asked him, Roxana. So this patient would not be in the SMART trial, and he doesn't have to answer the second question. It's a like non-evaluable question. Great answers.
Yeah, that's why we call it the SMART trial.
But I think it's a crucial question, and John and I are eager to enroll patients for you. So sounds good.
Great,
Moreover, how important was the predilation here? Because if you ended up in a high position in an unexpanded valve because you hadn't predilated, then we may have another difficult scenario to overcome.
George, can I just add one thing? You guys are discussing you guys are still not discussing the overlay. That's the point where the difference is. What we thought is a high deployment, not a high deployment, if you stay in the LAO projection. So don't get confused, and we all are trained and used to these high deployments or supposedly high deployments. In fact, I think what you've shown is very nicely that this is a correct deployment. What we earlier thought was a high deployment, if you stay at the LAO, then you know it is exactly what we need to do in order to achieve the pacemaker rate. So I think it's good. And Howie and you know, honestly, I don't think it needs to be post-dilated.
Perfect.
But if you would, I would be.
I want to do an angiogram to show that
on the predilatation, obviously, you know that I have a different opinion.
Simon, what's the rhythm?
I want to thank this incredible cath lab.
Yeah, just show the last angio. So we just did the aortogram.
You're going to show us the
Let me show the
angio, but
aortogram,
as you're showing the angio.
One final aortogram here, Dr. Sharma is going to show us. One final aortogram, and seems to be a small amount of PVL.
There is a little bit of a leak.
Perfect. Excellent.
Of course it is perfect.
And the valve is in position exactly.
That just tells you high deployments are okay.
Great and very challenging case.
Very nice.
Challenging case, beautiful. I want to thank the incredible cath lab, Dr. Sharma, Dr. Kinney, your staff are amazing. Team you've assembled, the work that you do, the live case, and this incredible panel, and Howie Herman, Eberhard Grube, Saibal Carr, David Wood, Vina Tarani, Didier Cheche. Thank you, thank you, thank you. I'm going to turn this right over, no break. We're going straight into the hot topics with Eberhard Grube leading the way. Dr. Grube, take it away to introduce our first speaker, which is you yourself. But maybe you want to just
one
give
master
a little bit
to
of
the other.
Maybe you just want to give Dr. Grube a little bit of an overview of the TMVR session that you'll be leading. And we'll go straight into your first talk.
Thank you very much, Rox. Very kind of you. So we're opening up session 2 and 3. Yeah, we're opening up session 2 and 3 with great.
You know, with the new app, I don't think I got a new way to.
No. It's not released yet.
That's why I was like,
for having me, and it's great seeing all these wonderful friends far away, but now close in this session. So we are behind, and I think maybe we can start my presentation.
I would like to thank the organizers for having me again at this virtual, and I'm excited to present to you the next generation mitral devices for repair and replacement. These are my financial disclosures. And the structure of my presentations are shown on this slide. Some brief remarks about surgical and transcatheter mitral valve therapies, update on treatment options for TMV repair, new innovative solutions for TMV therapy, and update on mitral valve replacement devices. And then I would like to finish with some final remarks. We remember, with this claim, we started the TAVR journey many, many years ago. All things being equal, less invasive therapy will always reign supreme. Have we achieved this goal in mitral valve disease yet? The repair and replacement design goals are very clear. They have to be safe, efficacious, and easy to be used. If we compare the two, surgery and catheter, I have to say, though, that surgery is still the gold standard for mitral valve replacement and mitral valve repair. Transcatheter approaches have not achieved the level of safety and efficacy yet. We might have to find new, innovative solutions outside the surgical toolbox to achieve the same results as surgery. Here are some points on current surgical treatment options. Surgical treatment for mitral regurgitation utilizes a toolbox approach, mainly annuloplasty, leaflet resection, and chordal repair. Mitral valve replacement is performed only at a rate of 34%. Management of secondary MR with conventional surgery is obviously less common. So we know there's an unmet treatment need. In a US community cohort study of patients with moderate and severe mitral regurgitation, they found mitral valve surgery was performed in only 14% of patients with either primary or secondary MR. These results suggest the unmet need in this patient population might actually be higher than expected. These are the numerous transcatheter mitral valve repair devices that are under development. Many, and that actually might indicate that none of them really work very well. The repair devices target the leaflets, the annulus, and the chordae, as shown here on the left side, basically the clip, Pascal, Carillon, Cardioband, Millipede, Neocord, and Harpoon. These are the edge-to-edge devices presently in use, mitral clip and Pascal. The mitral clip has the largest experience of any transcatheter mitral valve repair or replacement device, with more than 100,000 cases worldwide. Pascal received CE mark in 2019 and will compete with the clip in the future. The global EXPAND study showed 97.5% of patients achieved MR less than 1% at 1 year. Mitral regurg less than 1 was achieved more often with the NTR and XTR compared to earlier device iterations. Significant MR reduction obviously was associated with improvements in quality of life. The CLASP study of the Pascal device showed that the procedure was safe with a composite MACE rate of 14.5%. 82% of patients had MR less than 1 at 1 year and also sustained improvements in quality of life. The next generation Pascal ACE device will be narrower with the ability to fine-tune to optimize mitral regurgitation reduction. Those are the devices: indirect annuloplasty, Carillon, MVRX Arto, and mitral loop cerclage, direct annuloplasty, Cardioband, Millipede, Valcare, Valfix, and AccuCinch. The Carillon device, the longest out, received CE mark in 2009, began commercialization in 2011. The device is a coronary cinching system. The results of the randomized sham-controlled reduced FMR trial showed excellent safety, reduced MR severity, and the device resulted in favorable remodeling of the left ventricle. Of note, though, 71.4% of patients were in class 1 or 2, and only 28.8% in class 3 or 4. This is an example before the Carillon and 1 month after the Carillon. You can see very nice coaptation of the two leaflets due to the cinching of the device and of the remodeling of the left ventricle. Cardioband is a percutaneous direct annuloplasty system that utilizes the transeptal axis. In the CE mark study, the safety profile was favorable, reduced MR sustained out to 2 years, but there was poor technical success, 78.3% due to anchor disengagement. The Millipede device is a percutaneous direct annuloplasty system, 2019, acquired by Boston Scientific. A feasibility study was initiated in 2019 and is currently enrolling with a redesigned device. Moving on to the chordal repair devices. Here, the transapical devices, Harpoon and Neocord. And those are the transseptal chordal repair devices, Pipeline, Cardiomag, Corematic, and Neocord. All those are in their early stages. Pipeline has done 2 cases in humans. The Neocord has a relatively large experience with more than 1,100 patients treated. Studies have provided patient recommendations based on mitral valve morphologies. The prospective multi-center RECORD trial aims to enroll up to 585 patients, of which 60 will be non-randomized roll-in patients, 450 randomized to Neocord repair versus surgical repair, and 75 non-randomized high-risk patients. A complex study that will last some time. Harpoon chordal repair implant system utilizes a needle with the EP-TFE suture used to fix the mitral valve leaflets to the apex. In 2 prospective multi-center studies, early feasibility and CE mark, the device's primary endpoint was met in 91% of patients. Mortality at 1 year was 3%, reoperation required in 13%, and mitral regurgitation less than 1 achieved in 75% of the patients. Combination therapies with annuloplasty are obviously possible. Here are some examples: Carillon plus clip, Cardioband plus clip, Millipede plus clip, and the Cardioband and Neocord. Moving on to an interesting session, which is innovative mitral repair solutions, which is neither replacement nor total repair. It's probably in between. Posterior leaflet enhancement and replacement is a rather new focus area for TMVR, and these devices are early in their experience. The Polaris system, the Sutra system, the Half Moon system, and the AV system. Very interesting devices. And here you can see fundamentally how it works. Here is the device implanted in the region of the posterior leaflet, and the anterior leaflet coapts quite well with the posterior device. Here you can see the implant, its delivery and anchoring system. You can see the implant on the left side, and you can see here the anchoring system, 5 screws with a central screw and 4 lateral screws. This is the first in human, November 22, 2019, by Dr. Schäfer in Hamburg. And you can see here the device and the screws anchoring the system. Polaris pre and post results are shown here. Pre-implant and post-implant, very nice reduction of mitral regurgitation to maybe trace. Next is the Half Moon repair device system. Recently cooperating with Medtronic, this device is designed to eliminate regurgitation by restoring physiologic coaptation in a diseased mitral valve. This brief animation shows you the principle. Here you can see in a second the device implanted into the left atrium, and here is the device, and the anterior leaflet coapts quite nicely with the posterior application, and this reduces mitral regurg. TCMV replacement devices in humans, transapical, transseptal, Intrepid from Medtronic, Tiara from Neovasc, Tendyne from Abbott, and transseptal, Cardiovalve, Cephea, HighLife, Evoque, and M3 Sapien. This is the timeline of the devices. CE is certified for Tendyne, and you can see some of them are already resting in peace. Those are the 4 that are already gone. I suppose some more will follow. Those are the numbers in humans up till now, but this changes almost daily now. The reported human experience, the list is led by Tendyne and Intrepid, followed by Tiara with more than 71 patients, and Edwards and 3 with 43, and Evoque by 23. HighLife has 15 patients, and Cardiovalve and Cephea more than 7. A brief device parade. The Tendyne device from Abbott, the largest TMVR experience, is this with this retrievable and repositionable device. Tendyne received CE mark in 2020. Mortality rates at 2 years were 39%, MR less than 1 in 100%, and improvement in New York Heart Association functional class 81.7% were in class 1 or 2. Very nice result. The Summit revised pivotal trial, on the left side, you can see randomization between Tendyne valve and the clip. And on the right side in red, non-surgical patients, the MAC cohort and the control device. The next generation valve and sheath are integrated and a complete retrieval will be possible. Moving on to Medtronic's Intrepid device, reported outcomes were generated with the transseptal device, but the transfemoral early feasibility study was recently FDA approved. The 51 patients from Apollo roll-in had a 2% 30-day mortality as shown on this slide. Here you can see the Apollo updated pivotal trial design, which initially randomized against surgery, but now changed to 2 arms. Here the TMV arm and here the MEC cohort arm. FDA approved, and this device is this study is presently enrolling with a second generation device. Tiara from Neovasc, the self-expanding device, anchors using ventricular posterior anterior taps to fix the valve onto the fibrotrigon at the posterior annulus. The Tiara 1 and 2 trials showed a 12.7% mortality at 30 days, mild or less MR in 100% of patients at 1 year, as you can see here on the screen. The next generation Tiara devices are here on the transseptal approach system, less than 30 French, smaller ventricular footprint with less structural material, and the device is retrievable up to the last point of the device following the anchor release, improvement to the present devices. All of the 3, once successfully implanted, had achieved the design goals. 0% of patients has MR more than 2 at 1 year, and that is excellent at what these devices should actually achieve. Sapien N3 system is a dual stage system, a docking station that is delivered first and circuits the native leaflets and chordae, followed by delivery of the Sapien 3 TAVI valve. It is a transseptal access. Early feasibility and compassionate use outcomes in 45 patients were favorable. Mortality at 30 days, 2.2%, mild or less MR at 92.7% of the cohort. Basically the same approach you can see with HighLife, a valve in ring approach as shown on this slide. And here you can see a case. The nice thing about this device, the footprint in the left ventricle is very, very low. Another interesting approach is Saturn adaptive technology. It is a single device characterized by an annular structure mechanically connected to a central valve, as shown here. This is a solution to address the challenges and the wide variability of the native annulus sizes. It does reduce the mitral annulus and fixes the valve and the annulus. Another interesting approach is the Aortic-Valve. You can see here on the slide, there's a nitinol stent with multiple sizes to fit the left atrium, as shown here, and then within this spaceship, you can see a bovine tissue valve, 27 millimeter. The first transapical approach has been done in Quebec by Dr. Rhodes-Cabot, 2018, and the 1-year follow-up still shows no MR. The first transseptal Aortic-Valve case was done by Dr. General in Morristown, and you can see here also no significant MR at follow-up. Coming to the last slide, the take-home message. Edge-to-edge techniques are currently standard of care. Large numbers of patients are treated, well-studied device, randomized controls to support the indication in DMR and FMR. Excellent safety and acceptable efficacy. Limitations are residual MR, Future options may be excluded, and the results are not predictable. Not all anatomies are suitable. Other repair options that will be important for the toolbox include annuloplasty devices, transeptal chordal devices, and posterior leaflet enhancements. As far as replacement is concerned, the progress has been slower than expected, but continues to grow and innovate. Transeptal valve programs are showing very promising feasibility, and the patient selection still remains a challenge. With that, I would like to thank you for your kind attention, and again, thank you for having me at this great meeting.
Yeah, so thank you very much. And I think for the sake of time, I think we move on to the next speaker before we come to the Q&A. And maybe I can introduce, actually nobody needs introduction, to present, to talk about Greg Stone and Saibal Kar. But Greg is the presently director of academic affairs for the Mount Sinai Heart Health System. And Saibal is a professor of medicine at the David Geffen School of Medicine at UCLA in Los Angeles, and the director of structural heart disease interventions and clinical research at the Los Robles Hospital in Thousand Oaks. Welcome you to the session. Is Greg with us already, Rox?
Yep, I'm here.
Oh, there you go.
Hey, how are you?
Great, Greg. So I don't, introduction with your titles and your achievements will fill the 15 minutes. So why don't you just go ahead and present on update on mitral clip, COAPT, and more.
Yeah, so that's been already recorded and it should be playing right now as we speak.
Hello, I'm Greg Stone from Mount Sinai Medical Center and the Icahn School of Medicine. And it's a pleasure to be here today to give you this talk on the update on the mitral clip, COAPT, and more. These are my disclosures related to the mitral valve space. Most importantly, as the principal investigator for the COAPT trial, I was uncompensated. So as you recall, the COAPT trial is the largest randomized trial today in the mitral valve space. And it was an ambitious study in which 614 patients with heart failure and moderate to severe or severe secondary mitral regurgitation were randomized to either mitral clip plus maximally tolerated guideline-directed medical therapy versus medical therapy alone. This is one-to-one randomization. And the goal really was to see if reducing secondary mitral regurgitation and heart failure in patients who remain symptomatic despite all other class 1 guideline recommended therapies would interrupt the vicious cycle of volume overload, getting to more MR, getting to more volume overload, going to more LV dilatation, more MR, et cetera. Now, important is to note who we enrolled in COAPT. We did not want to enroll patients with the worst left ventricular dysfunction, such that the severity of the LV systolic dysfunction would totally dominate the prognosis. So we excluded patients with an ejection fraction of less than 20%. And perhaps even more importantly, we capped the size of the left ventricle as a left ventricular end systolic dimension of less than 7 centimeters. We wanted there to be truly severe mitral regurgitation, and this therefore had to be confirmed by an independent echocardiographic core laboratory before enrollment, despite all maximal med therapies, and this was using the multiparametric American Society of Echocardiographic criteria. As I mentioned, patients had to be symptomatic with either NYHA class 2, 3, or ambulatory 4, despite a stable, maximally tolerated guideline-directed medical therapy regimen and CRT and revascularization if appropriate. And we had an eligibility committee assess that patients really were on maximal therapy, but were still symptomatic, that is failing those therapies. And we did have important exclusion criteria, particularly those with very severe pulmonary hypertension, not responsive to vasodilators, moderate to severe right ventricular dysfunction, or severe TR requiring surgery. Now, you know the results of the COAPT trial. Our primary endpoint was all heart failure hospitalizations with follow-up to 2 years, and there was a nearly 50% reduction in heart failure hospitalizations, highly statistically significant with a p-value of 4 zeros and a 6. The average rate of heart failure hospitalizations was 68% per year in the control group and 36% per year after MitraClip treatment. The number needed to treat to prevent one heart failure hospitalization was only 3 patients. And this was an extremely safe therapy. The primary safety endpoint would have allowed up to 12% adverse events to offset that effectiveness outcome, and only 3.4% of patients had any safety issue at 1 year. So even more impressive, perhaps, was the fact that mortality was substantially reduced with MitraClip treatment. You note that in the control arm, nearly 50% of the patients died at 2 years. So this really demonstrates how desperate these patients are. And I mean, really, this is a mortality that's very similar to many cancers. But by reducing the left ventricular volume overload, even though the MitraClip doesn't cure these patients because it doesn't do anything about the underlying left ventricular dysfunction, you can see that mortality was reduced by an absolute 17%. So this is a 1 in 6 patients lived who otherwise would not have. The number needed to treat to save 1 life was only 6 patients. To try to put this into perspective with other class 1 guideline indicated therapies, if you look at just the HFrEF population, that is those with the ejection fraction of less than 40%, in the COAP trial, there was only 5 patients needed to save 1 life with the MitraClip. In contrast, if you look at other therapies such as beta blockers, ACE inhibitors, mineralocorticoid antagonists, and neprilysin inhibitors, it's 20 to 50 patients to save 1 life in 2 years. So this truly shows how potent and life-saving this therapy can be in the right patients. We now have data out to 3 years, and here are the 2-year results. And following these patients out to 3 years, you can see that if anything, the curves continue to spread so that the death or heart failure hospitalization rates are now further reduced. And in fact, you can see the p-value has like 10 zeros followed by a 1. And I only show that to point out that this is beyond the shadow of a doubt that this is a real statistical finding. The number of needed to treat to prevent 1 death or heart failure hospitalization was 3.4 patients. And a unique aspect of this trial was that at 2 years, crossovers were allowed in the surviving control arm patients to receive the MitraClip, which was provided for free. So this slide, as you see it right now, includes those patients in the control arm by intention to treat. If we remove those patients, you can see here are what the data look like. And now if we look at the outcomes of those patients who crossed over at 2 years from the control group to receive the MitraClip, and we restart their outcomes at time 0, now you can see they basically reassume the death or heart failure hospitalization rates as the MitraClip treated patients. So the important take-home message here is that it certainly is better to treat these patients earlier rather than late, but it's never too late. That patients with heart failure, refractory on medical therapies are still going to benefit whenever you can reduce their LV volume overload with a MitraClip. Now, the real reason that the benefit occurred was because of the reduction of MR. And this is a busy slide, but what it shows is the severity of MR in the 2 different arms at baseline, 30 days, 12 months, 24 months, and 36 months. And at every time period after baseline, there was a marked reduction in MR grade in MitraClip treated patients compared to medical therapy treated patients. And even more important, perhaps, was the fact that the recurrence rates were less. And if you look here at just the recurrence rates to 3 or 4 plus mitral regurgitation in the MitraClip arms, you can see that it's like 7% at 30 days and then 5% at 12 months. And then about 0.6% and 1% at 2 and 3 years. So very low single-digit recurrent rates of severe MR. And that's because the MitraClip actually treats the underlying pathology of secondary MR, which is lack of coaptation of the anterior and posterior mitral leaflets from the tethering from the spread out chordae. So the MitraClip will reapproximate the leaflets, and because of that, you have a very low recurrence rate. And this is actually not surprising. We know that if you have a therapy such as just surgical annuloplasty, from some of the surgical trials that have been done, you have a high recurrence rate from just an undersized annuloplasty ring, compared to mitral valve replacement, which has essentially no recurrence. In the CTSN network trial, 14% of the patients had recurrent severe mitral regurgitation at 2 years. And that's because while the ring will keep the annulus small, it doesn't do anything for the underlying tethering issue. And when you have more and more LV dilatation, you'll get more tethering and you can redevelop severe MR. And in fact, this was seen by Alfieri's own work, that he found that a ring only would lead to a high recurrence rate of MR, but a ring plus an edge-to-edge Alfieri stitch would basically eliminate recurrent MR. Now, we can further demonstrate that it's the MR reduction that leads to improved outcomes by looking at the outcomes at 30 days. So here's the baseline two-group MR severities, all 3 to 4 plus. And you can see at 30 days, 93% of the MitraClip patients had 2 plus or less MR, about 73% with 1 plus or less. In the medical therapy arm, of course, you know, that they had much more MR, but interestingly, about a third of the patients did have 2 plus or less MR. And this may reflect the dynamic nature of mitral regurgitation, maybe slightly better medical therapy or regression to the mean. Now, if we look at the outcomes of all these patients, according to the residual MR obtained at 30 days, and then look at the rates of death or heart failure hospitalization from 30 days to 2 years, you can see that if you achieved 1 plus or less MR, 39% of those patients had an event, relatively low. If you achieved 2 plus MR, it was only slightly higher and actually not even statistically significant. That's the blue curve. But if 3 to 4 plus MR either was not achieved or had recurred by 30 days, then your outcomes out to 2 years were very poor. And you can see when you look at it separately with the MitraClip group on the left and the medical therapy group on the right, that the curves look very, very similar. So it doesn't matter how you reduce the mitral regurgitation, whether it's from the MitraClip or medical therapy alone, or probably any other technique, it's the reduction in the MR and the LV volume overload and the left atrial pressure that is going to lead to the improved prognosis. Now, on the other hand, if you are going to reduce the MR, the second factor is that you have to keep it low. And we also know that while, again, about a third of those patients in the medical therapy group did have a reduction in MR at 30 days, it was less likely to stay reduced compared to the MitraClip group. So here in these first 3 bars, you see the MitraClip patients at 30 days, the ones that had residual 0 to 1 plus MR. And almost none of those patients through 2 years developed 3 plus or 4 plus MR. If on the other hand, if you look at the medical therapy group patients who got down to less than or equal to 2 plus, you can see a substantial number do develop severe MR, up to a third of them at 2 years. And now here are the ones who got down to less than or equal to 2 plus MR at 30 days. And again, you can see the MitraClip results are very stable, whereas now 55% of the patients are developing severe mitral regurgitation in the medical therapy group. So again, a lot of that is just some random fluctuation, the dynamic nature of mitral regurgitation. We also know that the MitraClip led to substantially better heart failure symptoms and quality of life. And if you look at this objectively with the Kansas City Cardiomyopathy Questionnaire, you can see very early on, within 1 month, the KCCQ, which was fairly severely impaired in both groups at about 55 points, increased by almost 20 points in the MitraClip group compared to minimally in the control group. And this was a benefit that was sustained out to 2 years. In addition, if you look at the association between that early symptomatic benefit and the long-term reduction in death and in heart failure hospitalization, an early improvement of 10 points in the KCCQ correlates with about a 25% reduction in 2-year death or heart failure hospitalization. So early symptoms portends good prognosis. We know that pulmonary hypertension is one of the most important prognostic predictors of adverse outcomes and in patients with heart failure and secondary MR, and that was the case in the COAP trial as well. But we found an almost identical influence of pulmonary pressures, which ranged in this trial from anywhere from about 13 to 100 millimeters of mercury in both the MitraClip groups and the medical therapy group. So if you look at the benefit, the hazard ratio reduction of the MitraClip versus medical therapy for death or heart failure hospitalization, it was almost constant across the range of pulmonary artery pressures studied. We also found that tricuspid regurgitation, particularly for medical therapy treated patients, was an adverse prognostic sign. 16% of the patients had, oh, this is the pulmonary hypertension, sorry. Here you can see the effect of pulmonary hypertension in the medical therapy group, and here you can see the effect of the pulmonary hypertension in the MitraClip group. So no significant interaction. While it's a negative prognostic factor for both groups, MitraClip improves outcomes whether or not there's pulmonary hypertension. And here's the effect with tricuspid regurgitation. 16% of the patients had moderate to severe tricuspid regurgitation, and that was also a negative prognostic factor, even more so in the medical therapy group than in the MitraClip group. Finally, of course, when we treat these patients, we want to bring their mitral valve gradients down. So we would like it to be less than 5 millimeters. But interestingly, a quarter of the patients in COAPT who were treated with the MitraClip had gradients above 5 millimeters, actually ranging up to 13 millimeters. And in that quartile of patients in which the mean mitral valve gradient was 7, you could see their improvement in terms of both symptoms and death or heart failure hospitalization was equally good as if there was not a gradient. So while we always want to have a minimal gradient, it seems as if with secondary MR and LV dysfunction, the benefits from reducing the severe mitral regurgitation are even more important than leaving a mild gradient behind. This may not be the case with primary MR, where the patients are younger with fewer comorbidities and exercise-induced pulmonary or mitral stenosis is a real issue. But for the sicker secondary MR patients, this seems to be true. So as a result of this, in March of 2019, the FDA approved the MitraClip for selected patients with severe secondary MR who remain symptomatic despite guideline-directed medical therapy. And I won't read the label, but the FDA essentially said, follow the COAPT criteria, because they found that basically all subgroups of patients using those inclusion and exclusion criteria benefited. And this has now made its way into the guidelines. If you meet COAPT criteria and you remain symptomatic despite guideline-directed medical therapy, you should undergo transcatheter mitral valve repair with the MitraClip. So we are on an ascent to widespread utilization and therefore improved patient outcomes of a relatively narrow part of the segment of populations with heart failure and severe MR who can really benefit by this therapy. First, we had to generate the evidence, which we did from COAPT. Then we had to receive the FDA approval and indication. Then we needed guidelines adoption, and all that is happening. The next big step is CMS reimbursement. And we expected that for about the last 6 months. COVID kind of slowed it down. But any day now, we will receive CMS reimbursement. And then we get the heart teams organized with a heart failure specialist, imaging specialist, interventional cardiologists, cardiac surgeons, and general cardiologists to help select the right patients. And that will lead to improved nationwide outcomes for heart failure patients with severe MR who can benefit from MR reduction from edge-to-edge transcatheter vascular repair. Thank you very much.
So, Greg, thank you very much. This was an excellent update. Rox, you have to guide me a little bit on the sequence of events here.
Let's see, who do we have here on?
We have the side.
Dr. Sharma is on.
Can
yeah,
we do
exactly.
Q&A now, or shall we?
Carr, Dr. Sharma, Howie is on. So we've got Howie Herman. We have Didier Cheche is on, but but Greg Stone is available. The idea is for us to have a wonderful round table. And if you're seeing questions come in to the portal, which we would put into the chat, we could, there's over 500 people sending questions. So we want to make sure that we answer the questions as well. But yes, it's really about you three, Saibal, Greg, and Everhard to create a nice discussion around mitral valve replacement, but take advantage of Howie, he's here.
So I mean, if you guide us a little bit on the timing, because we are, we are behind. Obviously, Greg, that was a phenomenal talk, a wonderful update on how things are happening and actually how the whole spectrum widened. Is Saibal with us?
Yeah. Yes, I am.
So I think in the next 10 minutes, if any questions you have next 10 minutes, Everhard, you can answer those if people have put in the chat questions.
Yeah. We have 10
Everhard, I'm there. I'm talking about the Band-Aid.
Yeah, and don't look so seriously. I still believe in it. I still believe in it. And
I like your dark glasses.
Good, but you're getting me out of my concentration here, Simon. Now that your professor Los Robles, stop that. So anyway, any comments on the mitral clip? Do we actually need something else?
I think there's 2 trials starting that, the repair MR for intermediate risk, DMR, which is an important study to extend the indication of mitral valve mitral clip for intermediate risk degenerative MR. And you showed some data from the EXPAND registry showing that the outcomes with the new generation mitral clip is definitely superior than what we achieved in Everest 2. The functional MR actually, I think, is very well answered in the COAPT trial. And in fact, even the outcomes are very good in clinical outcomes and excellent. But I think DMR now is very important that we now extend it. And there's a lot of controversy with the surgeons, including the surgeon from Mount Sinai, who doesn't like the endpoints, but David's not on call. But that's, I think, going to generate a lot of controversy in the next few years.
Eberhard, if I could take a stab at that question too, and just point out that, as wonderful as the results of COAPT were, there are many patients who don't fit COAPT inclusion criteria for one reason or another. They have small valves, they have radiation-induced leaflet damage, they have rheumatic heart disease, and we still had, even despite the benefit in COAPT, even the COAPT-treated MitraClip patients had a significant heart failure, hospitalization, and mortality rate at 2 years. So there is still room for improvement, and that's where I think transcatheter mitral valve replacement is still going to have a role, and maybe some of these other repair techniques as well.
So,
Howie, I just like to mention one comment about your comment. The words that transcatheter mitral valve will have a role, this sentence that you used, you've been using it for the last 7 years.
And the results keep getting better. I think what we're seeing are successes, and the safety's improving. And I think these
I'm just telling you that
going to go forward.
So Saibal, now we see you can leave a gradient up to even higher than 12, 13. So you open up the doors, and my concern is that we are kind of shifting a little bit away from a very rigid inclusion with granted excellent results into a mainstream device that everyone, even with much less experience than yourselves, think, the results are actually good. I can put 5 clips in, and then I have a gradient of 15, and patients will still do better.
No. There's actually data coming out soon. There's a new paper that's coming out by one soon to show that if you have gradients above 10, they actually don't do well. So you definitely above 10 or 12 is not acceptable.
Yeah, I think
when you go into severe mitral stenosis, that is not right. But we do know that if you have gradients of 4 or 5, it's okay. Every TMVR that I've seen has a gradient of 5. I've never seen a TMVR whose gradient is less than 5.
Nor do I.
Every valve in valve the gradient is 5, 6, sometimes even higher.
But,
I said greater than 10, 15, and 12 is not acceptable.
Good.
I agree with that.
We agree on that. Greg, would
you? A couple of points. We didn't have many patients in COAPT with gradients above 10. We had a few, but very few. So we had a fair number, that were around the 7 and 8 range. And again, in these severely compromised patients with functional mitral regurgitation, it seemed as if relieving the mitral regurgitation and the volume overload from that was more important than the potentially deleterious effect of leaving a gradient of 6 or 7 or 8. But that being said, remember, everyone strived to have a gradient less than 5.
Exactly.
Nobody wanted a gradient of more than 5. And there's no doubt that there were many cases where the gradient was going to be 10 or 15, where the operator didn't put in the clip or didn't put in the extra clip. And also, these are patients with functional MR who are really pretty severely limited. So this totally does not apply to patients with degenerative MR who are younger, who have less comorbidities, who are much more active, in whom exercise-induced mitral stenosis an increase in pulmonary pressures will be much more important than in our patients.
So Greg and maybe the three of you, can you maybe have some few comments on left ventricular or even left atrial remodeling? Is there a cutoff point that we should watch before it gets into good results and something that is not so good when the ventricle is just overstretched?
So left ventricular remodeling?
Yeah.
You say left atrial remodeling. So left ventricular remodeling. You know, what we've learned is, you know, Paul Graeber and Milt Packer gave us this tremendous conceptual framework to try to understand this relationship between the EROA and left ventricular size and how that may impact on improved outcomes. But what we've also learned from our own work and about a dozen other manuscripts that have tried to do this is that it's very hard to apply any particular ratio in an individual patient. Number one, there's too much variability. Number two, it's dependent on the individual ejection fraction, left atrial pressure, regurgitant fraction, and other factors that we can't routinely measure. There are too many degrees of freedom. So we're left with a concept, and if the ventricle is severely dilated and blown, and there's not much mitral regurgitation, those patients are not going to do well by relieving the mitral regurgitation. If, on the other hand, all the way at the other end of the spectrum, the ventricle is normal size and you've got just wide open, severe mitral regurgitation, those patients are going to do tremendous. And then there's everything in between. So all we can say and be kind of comfortable with at this point is that since we haven't really found any population that were enrolled within COAPT that didn't benefit, that at least if you follow the COAPT inclusion criteria, on average, if you qualify the patients right with our, left ventricular end systolic dimension, 7 centimeter cutoff, pulmonary pressures, less than 70 millimeters of mercury, et cetera, with true 3 to 4 plus MR, that those patients are going to benefit.
I think that was a very fair presentation of the data, Greg. And I think that one of the key points in that is the need for optimal guideline medical directed therapy, because some of those patients who have the largest left ventricles and the less than massively severe MR are just the ones who get better on medical therapy and their MR becomes more moderate as you fix their ventricles.
So, it's interesting how I have interesting discussions with Milt Packer, who, of course, is one of the preeminent heart failure doctors of our time. And of course, we have to say that. We only tested a population that were maxed out on heart failure medications. And as Seibel knows, we saw many patients who did get better on heart failure meds and who became asymptomatic, or the MR went down to 2+. But that being said, I can tell you Milt Packer believes that the effects that we saw in COAPT were so much more profound than any heart failure medications that he thinks, even if you're not on maximally tolerated medications, that those patients should get a MitraClip. And I can't believe as interventionalist, I'm pushing back and I go, Mike, or Milt, you can't say that yet. We didn't test that. But he goes, I'm sure that's the case. But, that could be a future trial, but we haven't.
So Greg, putting all of these arguments all together, what you just said, what Howie said, the most important determinant, and the data that you showed about our manuscript together, is that the MR is the most important determining factor in the prognosis, right?
Absolutely.
So see, if you look at the MITRA-France trial, if you look at it absolutely globally, the real difference was not necessarily the ventricle size, was their degree of MR, right? Because their threshold for severe was slightly different from the threshold that we used. As a result of that, they took patients with lesser degrees of MR. So if you combine the data that you just showed, that if you have 2+ MR, it didn't make a difference whether you got GDMT or MitraClip. It tells you that it's like coronary disease. You take a 50% lesion and you put a stent in it, you're not going to get a benefit. So that's really what it is. So I have the other theory that if you get a patient with a very large ventricle who's outside the COAPT criteria, but the MR is significant, then doing a clip is okay.
Well, we don't know. I mean, I
so
think
the ventricle being large to me is not always the only term.
We don't know. I mean, I don't think there's any doubt that in MITRA-FR, they had some of those patients. They had some patients with an EROA of greater than 0.4, pulmonary systolic venous flow reversal, et cetera. But they had very, very dilated ventricles. And I do suspect there's some point when you're on the falling limb of the Starling curve, you're just too far beyond it. The sarcomeres are too stretched out. The ventricle is just way too large that you are beyond the point where you can salvage that heart.
But Greg, they didn't cause any harm. Even if you look at the 3-year data, it showed neutrality. And did you see in the 3-year data, there was actually some improvement in cumulative heart failure admissions. It was not statistically significant. It didn't show a mortality benefit. So at least it was not harmful. So in a given patient,
but we shouldn't be doing procedures that are neutral. We should only be doing.
I would argue with that. Even saying it doesn't do any harm, because you can, if the left ventricle is overstretched and it's at the end of the Starling curve, and you increase the afterload, you cannot predict whether that patient tips or not. Saibal,
no, Greg,
to believe that.
Plus,
we have to. I just wanted to ask Howard, because obviously he's deeply involved in the replacement. In the replacement phase, or in EVOC and everything. So, Howard, what do you see? Because next is tricuspid, and we have to kind of, after 10 minutes, see what's the role of the replacement of the mitral valve at this point, considering what we've been talked about.
Well, as Saibal said earlier, it's still investigational, so we don't have a role for it yet other than to study it. But I do think there will be patients in whom getting the MR down to 0 will have an advantage, and there will be patients in whom we will be able to look at the anatomy and say, these are not going to be an ideal clip patient. We're going to end up with a high gradient, or we're going to end up with residual 2+ mitral regurgitation, and they have an ideal anatomy for a replacement, and that we will need to start to choose based on the various safety, efficacy, specific anatomy, and the patient's wishes, whether they're 80 or 90 or what their role for risk aversion is, and that we will end up with a substantial portion of patients who are better candidates for replacement than attempted repair with one device that we have now.
Would you agree that the path and the pace that we're moving with these valves still slower than expected, dealing with some of the issues?
Yeah, I mean, I think the devices are getting better and that the pace of safety is improving, but the randomization has been difficult, in part because the trials are starting with transapical devices and they're randomizing against surgery to begin with and not necessarily to MitraClip. So I think that's going to be part of the problem. The registries are going to fill up faster. And so finding candidates who are not good for MitraClip that we can enroll in replacement registries to get more data, I think is going to be very important.
Yeah. Just one question for the 4 of you, actually, Samin, maybe you can also comment. What do you think is the role for future devices, particularly the devices that augment the posterior leaflet for the improvement of coaptation? Any of take that? Saibal?
Yeah. Yes, I think there's going to be a role of cords, artificial cords. I actually like the idea of artificial cords for DMR. And there are at least 2 or 3 technologies which you mentioned in your talk, which are now close to feasibility. Neocord is now, as you know, moving from transapical to transeptal. You have CardioMech, which has actually got a nice technology, and then you have also Pipeline. And I think it's going to be good for DMR patients, some groups, not all, and you can always add a clip to it. So I think artificial cords is the way to go. Annuloplasty would be nice, even though it's not. I mean, I don't know where Cardioband is going. By the way, I'm not against your concept about replacement. I'm definitely not. Transeptal valve replacement is very challenging by itself with such bulky devices, but they're going slowly and steadily, and hopefully we will get a transeptal valve replacement. But the problem is there's so many exclusions. The exclusions are so many that you don't get many patients to treat.
Yeah. Any word on the half moon concept?
What?
Yeah, I think it's an interesting one, but I don't think we have enough data yet to really evaluate it.
Definitely not.
The half moon?
Yeah.
The question was
posterior leaflet augmentation.
Yeah. Half moon is, it's interesting, but I'm not sure it's going to, it's actually challenging because it prevents, it allows you to, the leaflet to coapt, but then if the annulus, well, it'll prevent you from annular dilatation, right? Because it's got a whole.
It's only augmenting them.
It's going to be a half ring.
It has augmented, but it actually has an encircling thing, the anchor from the top.
Rocks.
The whole anchor is circular.
I hate to be a rough police here, guys, but we're, as you said,
move on, right?
The next one back, and we have to move on to the next session of tricuspid valves. But this was amazing. Thank you, Greg. Thank you, Sybald. Thank you, Eberhard. And Eberhard, please move ahead. You're still moderating.
Thanks, everyone.
I introduced, thank you very much, Greg. And we move on to the forgotten valve, whatever you call it, the tricuspid. And we are joined hopefully by DDA and Sybald will talk about the tricuspid valve disease, pathophysiology, and evolving therapies. Sybald, now you're going to be an expert in tricuspid disease, huh?
So, good afternoon, everybody, and for me, it's good morning. I'm going to talk about tricuspid valve disease, the pathophysiology and evolving therapies, and I'd like to thank the organizing committee and Samin Sharma for inviting me to this conference, and I'm really sorry that I can't be in person in this meeting. These are my conflicts of interest. Of importance that I'm on the steering committee of the child limited trial. The pathophysiology of tricuspid valve disease is rather interesting, and I would like to start with a bit of the anatomy. The anatomy of the tricuspid valve is well shown in this diagram, and you can see here, this is actually quite a simplistic diagram demonstrating the septal leaflet, the anterior leaflet, in the posterior leaflet. But realistically, actually, in many cases, you don't actually have 3 leaflets. You can actually have up to 4 leaflets, 5 leaflets in tricuspid. And in addition, you have the papillary muscles and cords, which makes it quite complex as a structure. This is another way of describing the changes that occur with tricuspid regurgitation anatomically. On the left side, you can see the anatomy, looking at it on the surgical view. And then you can see over here that you can see the tricuspid plane is not exactly in one plane. However, when you do get dilatation, TR, often the ring dilates. And when it does so, the septal remains fixed. And so it dilates along the anterolateral direction, causing a separation between the septal and anterior leaflet and a separation of the posterior leaflets. And therefore, therapies are based on this pathophysiological phenomenon. These are some of the causes of tricuspid regurgitation. As you can see on the slide, 75% of tricuspid regurgitation are secondary to left heart disease, sometimes right heart dysfunction, pulmonary hypertension for any cause. And then you can get primary annular dilatation, which can be usually from atrial fibrillation. The 25% of patients have a primary cause, which could be Epstein's anomaly, carcinoid, endocarditis, rheumatic, or degenerative, just mitral like tricuspid prolapse. But a very important cause that we are seeing quite often these days is iatrogenic, related to a pacemaker, ICD, or a biopsy. And these are actually the 2 important groups that I'd like to focus on, is the ones on annular dilatation and pacemaker and ICDs. So here's a lady, the 80-year-old lady, who complains of fatigue and abdominal pain and leg edema 7 months after a pacemaker. Her rest of her LV function is completely normal, and it could not explain why she was in right heart failure. This is a T, which shows you, this is the RV inflow view and the X-plane view. What you can see is a pacing lead right in the middle, and this pacing lead is actually tethering the septal leaflet. In another view, in a transgastric view, what you can see over here, this is the transgastric view showing you the 3 leaflets. And what you can see here is this, the pacing wire is actually tethering the middle of the septal leaflet and causing malcoaptation, severe tricuspid regurgitation, and then secondary phenomena like annular dilatation. So in order to treat this patient was extremely symptomatic. So the patient came in for therapy options and we could not do anything because of the septal lead. So what we did is we actually removed the spacing wire. And after we removed the pacing wire, what you see in this diagram, the leaflets are moving much better. The septal leaflet is less tethered and is moving better, but there's severe tricuspid regurgitation still because the annulus is dilated and the leaflets are slightly tethered. So this patient was later considered and enrolled in the TriLuminate trial. There is also an important grading of tricuspid new regulating, because in tricuspid regurg, even severe can be very severe and it's sometimes even massive. And we found that if you go from massive to just severe and one grade reduction, you get actually an improvement of symptoms. And that's why it is important to consider a potential five-grade grading of TR, which was proposed by Dr. Rebecca Hahn. Tricuspid regurgitation affects prognosis, and this is a study which demonstrates patients with tricuspid regurgitation, and the greater the degree of TR, independent of other risk factors, affects prognosis. And this is probably one of the important slides, which tells you that if TR should not be ignored. However, we didn't know that if you treat the TR, it does make a difference, but we do know it does change, alter the prognosis. Now, the evolving therapies of tricuspid therapy are based on surgical principles. We know that tricuspid regurgitation affects prognosis. The tricuspid valve is not a forgotten valve anymore. Isolated tricuspid surgery is not common and carries a high mortality. And in the era of tricuspid therapies for left heart disease, there's a need for transcatheter treatment options for tricuspid valves. These are some of the categories of therapies evolved, starting from annuloplasty, leaflet devices, heterotropic valves, and finally tricuspid valve replacement. And I'm just going to cover a few of these. So the leaflet grasping device are the probably most well-studied devices for tricuspid therapies, the MitraClip and the Pascal system. And the mechanism is that when you have functional MR, when it actually separates the anterior and septal leaflets, if you actually can put a clip between the two, you actually can stabilize the annulus and help the coaptation leaflets and reduce TR. This is the TriClip. This is basically the MitraClip adapted for tricuspid therapies. The difference of this therapy is the guiding catheter is slightly different. It actually can be navigated in two different directions, whereas the CDS only moves in one direction. And over here, it shows you the strategy of where you should put the clips. Basically, you do them either between the anterior and septal or between the posterior and septal, or a combination of both. So that same patient, which I just showed you, we actually put her in the trial. She got 3 clips, and you can see that now her TR is only mild, and you can see that all the 3 clips were between the anterior and the septal leaflet. The clinical experience of TriClip is the most common tricuspid treatment for TR. Off-label commercial use of MitraClip tricuspid has been done in several thousand cases. The TriLuminate study had completed enrollment. The CE mark approval was obtained in 2020, and the pivotal TriLuminate study in the US is ongoing. And the study is actually enrolling pretty rapidly. This is the data for the TriLuminate study, which led to the approval in Europe with 82 patients. You can see that there's a substantial reduction of tricuspid regurgitation in the 30 days. And also that resulted in a significant improvement in functional class and KCCQ-12. The TriLuminate pivotal study, you can see is ongoing right now. It has 2 parts. It has a randomized arm and a single arm. The randomized arm randomizes TriClip to medical therapy in a 2-to-1 fashion. And the single arm is 100 patients, which are patients who are actually cases which we consider that they are anatomically suitable, but the TR is so high that you would not get a reduction enough to be moderate or less. The Edwards-Pascal system is another leaflet therapy system. And you can see over here, this also got CE mark approval based on the compassionate use of this device, where they showed a significant reduction of TR at 30 days, and the device seemed to be very safe. There's CE mark approval of this device too, and the pivotal CLASP TR trial is ongoing now in the United States. The cardioband tricuspid system is based on an aneuploidy technique. It's done through the jugular vein as a femoral vein, and you can see you can put in a ring, but it requires multiple anchors, and so it is often quite time consuming, but it does mimic the surgical ring placement. There has been CE mark approval. There was an early experience in the US. The procedures seemed to be safe. There was moderate reduction in tumor. There was moderate reduction of annular diameter. However, the company is making certain modification. The procedure time is quite long. The pivotal study is on hold in the US, and it could be used in conjunction with edge-to-edge repair. Transcatheter replacement finally is the last for those patients who cannot be repaired. As we know, it is difficult to repair torrential tricuspid regurg patients, and it may be safer to perform tricuspid replacement than mitral valve replacement. We here abolish TR, not just reduce TR, and will require long-term anticoagulation. There are concerns whether a failing RV can tolerate the sudden abolishment of TR. These are some of the concerns, of course, of replacement. These are some of the devices. This is one of the earliest devices, the Navigate device. This device is very bulky and has to be done through a right atrial approach. It's a self-expanding valve, and it's got a large profile. And this is just one of the slides that I'm sharing from Dr. Sushil Kudadi, which shows a successful reduction of TR with the placement and the valve. And you can see a very good result. Most of the cases have been compassionate. The other valve that is very interesting is the Evoke tricuspid valve. Now, this valve was actually designed for the mitral valve replacement. This device is now being tested in the tricuspid position, and actually with quite encouraging results in its compassionate use. And this also, as you can see, has a low atrial and ventricular profile, and it comes with two sizes. The early feasibility trial had 25 patients which completed enrollment with some very fascinating and encouraging data, which has led to the pivotal study, a multi-center randomized study with 300 patients, device 2-to-1 to medical therapy, and a single arm registry for certain groups of patients. This study has been approved by the FDA, and this will probably be one of the first clinical trials of tricuspid valve replacement. So my conclusions are that tricuspid valve is not a forgotten valve anymore. Significant tricuspid disease affects prognosis. In the era of transcatheter therapies, there are several transcatheter treatment options. Leaflet repair using a triclip or off-label use of the MitraClip is probably the most well-studied procedure. Encouraging data on the use of tricuspid valve replacement has led to the starting of the pivotal trial, and the treatment of TR is a toolbox, and there's going to be a role for both repair and replacement. Finally, I'd like to mention that pacing-induced tricuspid regurg is a phenomenon that cannot be ignored. And I have seen several cases where the pacemaker wire has actually impinged the leaflets and caused severe TR. And removing the pacing wire and then trying a therapy option is actually very helpful for the patients. And so I don't think we should ignore it. And that's why I encourage most people, when they need a pacemaker, I actually try to recommend a leadless pacemaker in these patients, because I've seen quite a few cases where the pacemaker lead has done more harm than good. Thank you very much.
All right.
Thank you very much, Saibal. As usual, very calm, very quiet, unusually well done on the tricuspid side. Very well done. And I think we should be moving on, right? Before we come to...
Yes, and I think Didier wanted to give his talk live, and he is. There he is. Hi, Didier. Thank you so much for all that you have done for us today, being available It's already late at night in Paris, and we love having you. So Eberhard, go ahead and you can introduce Didier, and he's going to give a live lecture. Isn't that great? He's our only live lecturer.
Wonderful. Didier, thank you very much. I don't think we need to introduce you, actually. You know, obviously he's French. He works in Toulouse, and he's a director of many courses, or co-director of many courses, international, and he's working at the Clinic Pasteur in Toulouse. Obviously, you know, he has been an expert in aortic-valve disease and mitral valve disease and tricuspid disease. We take the privilege now of taking your experience in the tricuspid disease now. Didier, welcome to the club.
Thank you very much, Eberhard. Thank you, Roxana. So it's a true pleasure to be here with you and to present in the next during the next 15 minutes how to plan for transcatheter tricuspid valve interventions and what are the results of the main trials that Saibal had just mentioned in the previous talk. So let's start with the planning and the role of imaging. So I wanted to start with some key messages about planning for transcatheter tricuspid interventions. The first one is that planning is crucial, and it is a case for the other valves. It's of paramount importance for the tricuspid valve. So it goes through proper quantification of the tricuspid regurgitation, trying to understand what is the anatomy of the patient that we're going to treat and the mechanisms of the tricuspid regurgitation. And multimodal assessment really plays a role, and it's a key to integrate all the imaging methodologies to understand the anatomy of the patients and the way we're going to use the devices in that particular patient. So you've seen with the previous talk that in functional tricuspid regurgitation, most of the time we have an enlargement of the annulus in the anterior and posterior region. And you clearly see on the left picture, in the anatomical picture, that the tricuspid annulus is clearly a complex structure. The tricuspid valve is a complex structure with many surrounding structures, and we need to analyze that before going into the procedure. So echo remains central in that assessment. Echo is the gold standard because it's extremely helpful to understand what is the mechanism of the tricuspid regurgitation, to quantify that tricuspid regurgitation and localize the position of multiple jets, because it's sometimes the case. And it's also extremely important to understand what are the right ventricular volumes and function and the pulmonary arterial pressures. Saibal said that of paramount importance is to identify the presence of pacemaker leads and their location, because they may be at the origin of massive tricuspid regurgitation. So it's really difficult, it's complex to quantify tricuspid regurgitation because it's not a circular valve. And so maybe this 2D assessment that we use to apply for the other valves is not enough for the tricuspid. And we, apart from the 5-scale grading that is more and more adopted and seems to be corrected with the outcomes for the patient, there is a role for the 3D integration of the both the Doppler and the color imaging with the PISA. And the 3D EROA, 3D PISA, is something that should be integrated in the daily practice when it comes to the tricuspid valve to better quantify, to properly quantify tricuspid regurgitation. So another modality when it comes to planning and understanding the tricuspid function and regurgitation is CMR, and CMR may be implemented just to understand what is the amount of regurgitation and what are the RV volumes and the RV function. So this is a more modern and contemporary way to assess the TR and the tricuspid apparatus, and this could be one of the key players in the future. To my opinion, one of the key methods for planning a procedure remains CT scan. CT scan is one of the gold standard technique on the aortic and the mitral side. It is also the case for the tricuspid side because it helps us sizing all the dimensions of the tricuspid annulus. It's even interesting because it helps us understanding where are the differing in relation to the various septal to the various leaflets of the tricuspid valve. So it's something that we need to maybe not master at the start of our experience, but to implement in terms of understanding the anatomy, the angles, the way the catheters are going to behave within the anatomy of the patient, and this is crucial before diving into the procedure. So as an example, something that we may also assess with CT scan is the location of the right coronary artery. This is a device that is not anymore utilized, studied, because it's not manufactured anymore. This was a tri-cinch coil system, and it was necessary, as it is the case also for the cardioband and the tricuspid side, to understand what is the relationship between the right coronary artery and the tricuspid annulus, because there is a risk to impinge that artery with the anchors. So the overall integration of the tricuspid valve and the surrounding structures. So during the procedure, you're going to see that more and more often. It's another multimodal assessment, multimodal imaging to guide the procedure, to guide the deployment of the devices that we're going to use. So we need to integrate that to understand that we need to combine, as for it is the case, for example, for the TriClip, the echo imaging and the fluoro imaging, and this is meant to really guide us towards the location of the jets and to navigate through the various structures before reaching the tricuspid valve. So if to make it quite more synthetic in terms of planning, if we do a kind of overview of the imaging modalities for planning and procedural guiding, if we start with the echo for pre-procedural planning, it's all about TR mechanism and severity assessment of the right ventricular function and volumes, estimation of both the right atrial and the pulmonary arterial pressures also. While when you go more into the procedure, the guiding through the procedure, it's really helpful to visualize the catheters and the leads, to identify the location of the jets and the target points, and to assess the immediate results. We may also use the fusion imaging when it comes to echo guidance. For CT scan, it's all about the measurements, the true measurements of the dimensions of the tricuspid annulus and the RV dimensions, but also the subvalvular apparatus may be assessed, as can be the surrounding structures, whether it be the coronary sinus, the superior or inferior vena cava, the right coronary arteries, so multiple ways to assess the overall anatomy of the patient. For the procedure, it's a superb tool to anticipate the angles and the optimal projections for the fluoro C-arm. Fluoroscopy, to my opinion, it's mainly for the opacification of the right coronary artery and to guide the navigation of the catheters through the inferior vena cava, superior vena cava to the right atrium, and then the right ventricle across the tricuspid annulus. So this is definitely a multimodal integration of these imaging modalities to plan your procedure. So we've seen what were the available options for the tricuspid regurgitation in terms of transcatheter techniques. I will start by just showing this slide that clearly tells us that we have a very large portfolio of available devices where for various targeting various aspects of the tricuspid valve, whether it be direct suture annuloplasty, direct ring annuloplasty, coaptation enhancement devices, or TTVR, transcatheter tricuspid valve replacement technique. So a very large portfolio of devices under clinical evaluation, and this is really superb for our patients. So the TriClip, the clipping of the tricuspid valve is the most popular one so far, and we has gathered most of the experience in the tricuspid side with more than 2,000 procedures performed worldwide, which is already a good number. And we've seen the triluminate study, but before that there were real-world registries, and from these real-world registries, what we understood is that if we achieve procedural success when it comes to clipping the tricuspid valve, this is going to have a positive impact on the survival of the patients. The patients for a procedural success have a better survival as compared to the patients with a procedural failure. So if we go for the procedure, we should do our best to decrease the tricuspid regurgitation, because this is going to have an impact for our patients. The TriClip has been described in the previous talk, and this is definitely a device that is designed for the tricuspid. And we just focus on the TriLuminate trial, 85 patients that was meant to evaluate the safety and performance of the TriClip in symptomatic patients with moderate or greater tricuspid regurgitation. And definitely, you're going to see that first, in terms of procedural success, this was extremely impressive. We have 100% procedural success rates, and this is clearly, clearly illustrates the safety of the procedure in the tricuspid side. We had seen that in the mitral side. It's even greater and even safer, seems to be safer in terms of procedural aspects on the tricuspid side, and this is really reassuring for the patients. When we focus on the primary safety endpoint at 6 months, you can see that 94% of the patients were free of any major adverse cardiovascular events, namely cardiovascular mortality, myocardial infarction, stroke, new onset renal failure. And this pattern was sustained at 1 year, with 93% of the patients being free of major adverse events. Once again, extremely positive signals for this therapy. So the goal, the ultimate goal, the first goal was to achieve a TR reduction. And what you can see on the left part of the slide is that the TR moved from massive to torrential in more than 65% of the patients at baseline, to only 27% at 1 year having severe or torrential regurgitation. So it's clearly an improvement for the patient. And this TR reduction seems to be sustained at 1 year. Some patients had a worsening of their regurgitation, but the vast majority of the patients kept the degree of reduction of the TR that was achieved after a procedure. As a consequence, improvement in quality of life, improvement in symptoms with a lower NYHA scale, both at 30 days and 1 year. And they also observed early signals of right ventricular positive remodeling. And this is something that is strongly encouraging. It needs further exploration, but these are very great early signals. In terms of hospitalization, if you live a regurgitation that is more than moderate, the patients are going to face a greater risk of rehospitalization. So once again, we need to achieve the better outcomes in the OR or in the cath lab when we use the TriClip technology. The competitor or the device that has the same mode of action as the TriClip is the Pascal. We all know the Pascal device, and through the compassionate use experience with the 28 patients that were treated, extremely impressive in terms of TR reduction, comparable to the TriClip, with very few patients having a severe or torrential regurgitation at 30 days. And this is correlated to an improvement, symptomatic improvement of the patients, and also in terms of quality of life. So once again, very positive early signals that need to be confirmed through larger cohorts and longer term follow-ups. When we move to the cardioband and more the annuloplasty devices, annuloplasty systems, the cardioband is, we have to be honest, is more challenging to utilize in the tricuspid valve. And this may correlate, as you can see, to greater amount of severe, massive or torrential regurgitation as compared to what was achieved with both the TriClip and at the Pascal device in the tricuspid side. It's a little bit more complex with the cardioband, but the patients who had a significant reduction of the TR had a symptomatic symptoms improvement and quality of life improvement also. So if we understand how to use the device, how to better select the patient that are going to benefit from that technology, there may be a future for the cardioband in the tricuspid side. A device that may challenge the cardioband is the Da Vinci system, and the first in-man case was published very recently. It's a two-step procedure. The ring is placed during an index procedure through the jugular axis, and then the cinching is performed only 90 days after, just to have a proper sealing and anchoring endothelialization of the anchors all around the tricuspid annulus. So this is a device that we need to follow, and we're going to see in the future what are the outcomes. The first cases are being performed, and we're going to see in the upcoming months what is the outcome for the patients. But potentially, we may not expect the results as good as the ones that we saw before for all the patients, and there may be a need for a replacement solution. These solutions have been discussed in the previous talk. But briefly, if we take the Navigate device, the early experience on the first 30 patients treated with these devices has been published, and you can see that it's quite efficient, as are all the replacement techniques in terms of reduction of the regurgitation. So it works, and what we need is to have a longer-term follow-up. There is a need for some technical refinements because the device remains quite bulky at the present time, but in the future there may be, if we have some appropriate technical improvements, we may face better outcomes for the patients, particularly procedural wise. Evoke is probably one of the most promising device. It has been nicely described by Sabo before. You can see that it comes from the transfemoral access with steerable catheters in various directions, and through this compassionate use with the 25 first patient, technical success was high. 92% of the patient had a device successfully deployed in the anatomy. Only one unsuccessful procedure due to the lack of coaxiality, and one device that was deployed a little bit low and required a sapien-free implantation to prevent a residual significant regurgitation. So no mortality. So the safety profile is really impressive, really encouraging. And the ability to decrease TR is really in accordance to what we see with these replacement devices. So very few patients had a severe regurgitation post the procedure, and as a consequence, a clear improvement in terms of symptoms for the patients. So we're going to see, we know the Intrepid in the mitral side. We're going to see how it behaves in the tricuspid side. The EFS is about to start, and with this transfemoral tricuspid technique, we're going to see what are the outcomes for the patients. Promising result on the mitral side, and we can expect the same thing, and potentially the same type of result as we obtained with the Evoke with the Intrepid in the tricuspid side. So to conclude and to remain in time, I would say very simply that imaging plays a central role for planning transcatheter tricuspid intervention, and we saw that it's more a multimodal assessment of all the metrics of the tricuspid valve before selecting the appropriate device. It's also a multimodal imaging guiding during the procedure. It's not, most of the time, it's not one imaging technique that is going to help us properly place the device. We need to combine most of the time 2 imaging techniques. We have a large portfolio of devices, transcatheter tricuspid devices, that are under evaluation or under commercial use, but we need to accumulate to better understand what is the patient selection to tailor the device to the patient, because every single patient is different. And we need to accumulate experience as a group, all gather our cases to better understand who to propose which technology, and we need a longer term follow-up. So I thank you very much for your attention.
Great. Wow. Fantastic. Okay, Everhard, we have, I know that you have a commitment, but this was great. Thank you, Didier. We have about a 10-minute.
I just have, this is it'll be for 10 minutes more. Yeah.
Yeah.
Let me go.
10 minutes.
Sit in the lobby.
Dr. Sharma?
So we are trying to see if any questions we need to answer. This is a phenomenal.
It would come up in the chat, but let me put up a question to you, back to you, both Saibal and Didier. Really exciting stuff on the tricuspid valve, and I see even a bigger value for fixing the tricuspid valve, and perhaps even a much more important outcome for these patients. Do you guys view it the same, or is this just sort of like, because it just looks really good? I mean, this torrential TR, but in the past we were like sort of, oh, it's TR, it's benign, it's not that big of a deal. But now I think you see that now that you could treat it percutaneously, it could be an important addition. Didier, and then Saibal.
So clearly, definitely, I think that the tricuspid regurgitation patients are the ones who are going to benefit more from our technology because they are highly symptomatic. And we all see that they are the rate of rehospitalization that is really high under medical therapy. And clearly, we can be optimistic because having seen the results, the reduction of TR that we can achieve with the actual device and the devices under investigation, and the impact on the quality of life, the symptoms of the patient, the hospitalization rate, I think that once we gather larger cohorts, we're going to see very impressive results. And this is really going to be beneficial for the patients. And that's the goal of what we do every day.
Yeah, and I think you can be a little bit more generous in the endpoints, like less hospitalization. It doesn't have to be mortality. I think that what you just said is really important. Saibal or anybody else?
Yes, I agree with you with your observation, Roxana. Initially, when I thought tricuspid is a passive valve, and if you treat the left heart disease, it'll be okay, and it's not the case. It's very clear cut that I actually have a lot of patients who've had mitral clips done before, started to get worse, and then when I treated that tricuspid valve, they actually improved. So for one thing for sure, treatment of tricuspid valve disease makes a difference. That is convincing from everything. Also, the surgical alternative is not great for isolated tricuspid valve disease. So there's a huge opportunity for tricuspid valve repair or replacement. Third is, you do not have to reduce it to trace. Even a 1 or 2 grade reduction translates into amazing clinical findings. And I actually wanted, Didier and me worked with Fortec, and it's a pity, that's actually the first time we actually worked together. And it's a real pity that that technology ended. Didier, do you agree? I mean, he showed me one of his first patients who had a moderate reaction TR, but had a dramatic clinical improvement. Isn't that right, Didier?
Yeah, exactly.
Is she still doing well?
Yeah, she's still doing well. And I remember that patient the first time I saw her, it was 1 month post-procedure. And she said, look, doctor, I was in my garden gardening and it started to rain. And so I went back to my home. And this was the first time I realized that I was able to run, in fact. And it was only a 2 grades reduction. So definitely they're going to benefit in terms of symptoms.
So the other thing is, I have a few triluminate patients from the phase 1 study, and I actually interviewed her the other day. This is what she told me. She says, Dr. Carr, I know you were struggling to find a treatment for me. I was only asking God, take me, but let it be less painful, because I couldn't live anymore. And now you've given me a hope. This is what she told me.
Yeah.
After 2 years with a triluminate.
Saibal, I think these are all very, very understandable and very important statements, particularly from a patient-physician relationship. We want to relieve a suffering. Whether that's enough to move forward with the devices, I'm not so sure. And I still have a problem. With grading. A clinical improvement, which you can find both on the mitral valve and on the tricuspid valve, even if you do not reduce to trace or mild, is very well known. We learned this in medical school. We're not treating necessarily, we have the obligation, I think, to also look at the long term. And if you reduce and you are happy with your device and the endpoint of reducing torrential or severe to moderate, I don't think that's enough. And this is where I believe, devices like the Cardioband you can always say the glass is half full or half empty, but I think that's not enough. If we take the same standards that we apply for the mitral valve, that's why personally, I still have a problem with grading, saying this is successful because the patient feels better. Applying the same standards, by the way, that you and others implemented for the mitral have to be taken for the tricuspid, particularly when we look at the new devices. And that's my question to you. If it does have the replacement, a different position in the spectrum of devices in the tricuspid valve as compared to the mitral valve?
Well, tricuspid valve replacement is becoming more of a reality than a mitral valve replacement, because the same, as you said, as you showed the data from EVOQUE was invented for the mitral position, but is actually ending up being more effective in the tricuspid position. And one of the reasons for that is because it's safer. I remember when we were planning to do EVOQUEs on the mitral, we were like, oh my God, the blood pressure drops, VT, VF. In the tricuspid side, it's much more stable. So of course the replacement will be, but you have to take into account, ask the question to the surgeons, why didn't they replace the tricuspid valve for all these years? There must be a reason. And we know it's a low pressure zone, and there is a high rate of thrombosis. So therefore, I still think, just like in the mitral and tricuspid, these are not by the way, these are not valves. These are apparatuses, which consists of leaflets, cords, and papillary muscles. So if you can repair them, that should still be the first option. And replacement should ideally be left for patients who cannot be repaired. So for torrential TRs, maybe we should replace them, but moderate to severe TR, if you can repair it, I think the best biological valve in your body is your own valve.
Yeah.
Gilbert, what additional thoughts do you have? Because I do know at Mount Sinai, before we were getting involved in the percutaneous tricuspid, and I know that you're the PI of the TriIlluminate at our site, but I would see patients go to the operating room for mitral or other valves, and they would get a ring in the tricuspid position because of the torrential tricuspid regurgitation. So in our institution, we have been treating the patients, but maybe Gilbert, you wanna give some comments on that?
Yeah, no, I think as everyone know now, the tricuspid valve is no longer a forgotten valve, because kudos to all of you having brought it to attention with not just devices, but also imaging, right? There's been a huge new field of structural heart imaging dedicated to tricuspid valve. But from a surgical standpoint, I think for us, at least in Mount Sinai, we've been at the forefront at aggressively repairing tricuspid valve, because we know the long-term data, as you've seen multiple literature, whether it's with medical treatment or even surgery, with residual TR, moderate or severe, is not good. A lot of patients that we've seen have previous mitral done, and a lot of them end up being in evaluable trials and left the tricuspid open. And so I think just like aortic stenosis, where we try to be more aggressively monitoring, diagnosing, and treating them, I think we need to be doing the same for tricuspid, because by the time they come to us, and Dr. Sharma, Dr. Kini, and Sam, and all of us, and you as well, have seen that they come too late. There's no options. They're so dilated, the annulus or the anatomy. We've screened them for replacement as well. Even replacement, the annulus is too big for some of the devices. So I think the message is that not just surgeons, but general cardiologists and others need to just refer them early. We don't have to intervene at that time, but at least refer them early so we can keep them on our radar.
And actually, also, we have our list of TAVR patients which are under investigation, the mitral clip patient, mitral, and the tricuspid. In last 4 months, mitral is in 2 pages and tricuspid in 3 pages. So there are a lot more tricuspid patients now there, because we are understanding this disease process, that patients remain symptomatic and so I think the title was very correct. As Eberhard said, that it's not a forgotten valve. valve. It's basically now we are remembering it to understanding how to treat it. Now, I know that Raj Makkar may be on the line. There is a question specifically for him that in bicuspid valves, do you find it contribute to CVA or otherwise in cases where the TAVI is also non-coaxial with the LVOT? So a specific question is that is there a higher CVA rate in the bicuspid valve, and is it because of the non-axiality of the valve? And of course, we know that clearly there is always a little paravalvular leak in the bicuspid when with our current valve, although it's much lower than in the past, because now we have extra cuff, Ultra 3, and the Evolute Pro Plus, and so. But everybody knows. I hope on the line, and we also request our audience. This is the time. Year ending, and you have the best expert in this structural heart disease field, and any question, any query you have, just put it in the chat box and we'll answer that in next few minutes before we conclude. But key is that yes, there is no randomized trial for the bicuspid valve. As you know, there have been all just low or intermediate risk registries which have been maintained and submitted, and it seems to be that stroke rate is just about similar. And I'll wait for like a tricuspid valve. I'll ask if.
But I think that's a good question. I do think that there is more stroke. I mean, you have to be careful with the stroke in the bicuspid. These patients are usually younger. You certainly wouldn't want to tolerate any kind of a stroke in a patient like that, especially if they're a surgical candidate. So we talked about this during the bicuspid valve that you guys treated, and I was very happy to see that the Sentinel device was used. But I do think it's an important question. What other measures is anyone doing anything differently? How are you telling your patients? Maybe Didier could tell us. How are you consenting the patient with a bicuspid valve who's undergoing TAVR? What kind of a risk of stroke are you quoting them? And then maybe we can go to Alex as well.
So that's a key issue, and it's true that this is the first complication that I present to the patient, the higher stroke rate with bicuspid, because I do believe that there is a higher stroke rate with bicuspid as compared to tricuspid. So we explain to the patient that we're going to take all the precautions to prevent that, including the cerebral protection, and this is one of the key indications for embolic protection devices, to my opinion. But I agree, this should be clearly explained to the patient, but we have to do everything that we can to prevent that. And so it comes through decreasing the number of manipulation across the Aortic-Valve, selecting the proper device to be sure that we're going to have one deployment, a very stable deployment. And I don't think that there is one device, one size fits all. We have to tailor the device and the size to the patient and explain clearly for a particular patient what risk he is exposed to according to his anatomy.
I absolutely agree, Roxanne. I think that particularly because these patients are younger, so we have to take this extra care and protect, of course, the brain. But just to switch gears a little bit about imaging, since Stan is there, for tricuspid procedure, which modality do you prefer, transthoracic or TE? Just quickly about imaging to guide tricuspid treatment.
During the procedure, or you mean during the procedure?
During.
Please unmute, Stam. You're muted. Yes. We don't hear you.
Yes, during the procedure, of course, transesophageal echo is the best way to, especially with the new software that we have, is the best way to align the clips and do the procedure. So TE, sometimes we have done cases here that we have used both a TE and transthoracic echo, but the primary modality is transesophageal, and depending on the views, sometimes we also add the transthoracic echo.
We strictly use
for planning of the procedure. We use transthoracic for assessment of the tricuspid regurgitation, the severity, and for the anatomical reasons for the procedure, we use a CT and the transesophageal echo. before the procedure for planning.
Yeah, I also like to mention that, 3D ICE is coming. There was a 3D ICE catheter that, was recalled, but we've done some imaging using both TE and ICE, and especially using ICE for grasping. I mean, Didier and Saibo can comment more about the technical aspects of some of these challenging cases because of visualization. But we found ICE to be very helpful.
With the Epic machine, the new Philips Epic machine, the visualization of the tricuspid valve is better, which was not there before. So I used additional ICE imaging, bending the catheter to see the tricuspid leaflets. Now with the Epic machine, I'm not having that much of a difficulty. So I haven't had to resort to ICE. In the last few cases, I haven't had to resort to ICE. Even though I do agree that ICE gives you the best view, it's the closest to the leaflets, but you have to, the two-dimensional catheter is the only one that we have. So you really have to flex the catheter a lot to get it aligned to the clip. That's the problem.
Yeah, with multiplanar reconstruction that we have now with the Philips, is fantastic.
Yes.
for the
You can do it with MPR. With the MPR alignment, you don't have to do a deep transgastric. We did a case yesterday, Triluminate. We did most of it by MPR.
Yeah, we did one last week. We put 3 clips in about an hour with minimal residual TR. So
yeah,
the new Philips machine is fantastic.
Oh, well, Dr. Sharma, I think, if you want to close and thank everyone with Dr. Kinney with all of this amazing, amazing day. We're about an hour late, but not too bad, only an hour. We do have an exhibit space for people to visit. I think you have to make that announcement and what you're planning to do in terms of replaying this wonderful session.
Yeah, so very great, Roxana, and of course, all our esteemed faculty to really uplifted the educational value of this conference, and that was the goal. And yes, it will be available even just after the completion of, as soon as we go off, it will be available for the slide presentations, and the whole meeting will be on YouTube. And if you go to the website, and the live case probably by tomorrow, because live case requires the little finessing, will be available, and all the slides will be available to all the participants, which are 500 plus. They can download, and I really thank our faculty to provide those slides so they can be for easy use. So this year was virtual. Hopefully, the New York Valve, Transcatheter Valve 2021 on December 9th, because this we combined with just a day before Dr. Fuster's conference, ACC conference, which is starting, supposed to start tomorrow, but now this time Saturday, Sunday there. And usually it is Friday, Saturday, Sunday. So it will be on December 9th, 2021, and hope it will be in person. Maybe some lectures will be by Zoom, but it will be in person. Then I'm sure New York is a good place to visit, even early December. With that note, and with all my
Maybe Dr. Kinney will say some final words.
Final words from Dr. Kinney. Unmute.
It was an excellent meeting, as yourself and Roxana mentioned. I think the great thing was what we see is people from all over the world able to come together without flying. Except that, they may not have enjoyed the weather and the beauty of New York. But as long as the educational discussion was the best so far. Thank you, everybody, for attending this meeting, and we'll see you for next year, 2021.
Thanks.
Thank you, Ginny.
Okay. Bye-bye.